Good morning, everyone. On behalf of the Scientific and Organizing Committee of this conference, I would like to welcome you to the first Breast Cancer Patients Conference entitled Breast Cancer in Greece Today. It is organized by the Hellenic Association of Breast Cancer Women, Alma Zois, under the auspices of the scientific societies, the Hellenic Breast Imaging Society, the Hellenic Society of Medical Oncology, and the Hellenic Breast Surgery Society, and of course under the auspices of the Hellenic Cancer Federation, ALOC. After many years of internal procedures and consultations, this year, Alma Zois takes the next step to organize this conference in order to address issues that are of main concern for breast cancer patients and the new European Breast Cancer Action Plan aiming at reducing the mortality from the disease and the improvement of the patient's quality of life. In order to bring forward and highlight those questions, we believe that it should go without saying that the state, the competent bodies are on our side. Today's conference will focus on the main positions of the memorandums drafted by Alma Zois associations in collaboration with scientific societies EAM, EHEM and EOP. We believe that this is a very clear, concrete and well-targeted proposal for breast cancer management in our country. The first Pan-Hellenic Breast Cancer Patients Conference in Greece gives the floor to people in order to address issues of interest for patients, tackle the management of the disease in our country, involving all competent stakeholders, representatives of the medical society who are here to share the latest medical updates and developments, patients who will share their experiences, and of course political leadership representatives who will share with us what's their action plan proposal. Those three voices, united together, will pave the way in order to implement the necessary changes and improvements in order to better improve breast cancer management in Greece with a view to reducing mortality rates, as it has also been set forth in European Union and WHO acts in order to include all three stakeholders. In this discussion, we are more than confident that distinguished speakers, guests, commentators of this panel that grace this conference with their presence will play a decisive role in order to meet the conference's goals. And we will make sure that the conclusions drawn from this conference will be capitalized on over the next months. Considering the pandemic, we are hosting this conference in a hybrid mode, meaning both physical presence and online streaming. And this is why we're asking for your understanding in order there are slight delays. I would like to thank you all very much for joining us here today, both physically and online. I wish every success to the works of this conference. And now I would like to give the floor to our dear Miss Cleopatra Gabrielidou, former president of the Pan-Hellenic Association of Breast Cancer Patients, Alma Zois. She will declare the opening of the conference's works. Thank you very much, Christiana. Dear participants, good morning. It is with great pleasure and honor that I find myself here among you today in the first Breast Cancer Patients Conference organized by the Pan-Hellenic Association of Breast Cancer Women, Alma Zois, entitled Breast Cancer in Greece Today. Well, breast cancer, apart from the major medical accomplishment and pharmaceutical accomplishments that we have seen over the past years, remains a life-threatening reality for women today. Screening is key for early diagnosis. The optimum, integrated, personalized clinical care in breast centers is a decisive factor for better survival and prognosis of breast cancer patients, regardless of the disease stage at the time of the diagnosis. However, it is equally important to support patients throughout their treatment and after their treatment. We need to have multifaceted support. We know that there is room for improvement. What we're trying to do here today is to highlight the proposed ways to support those people. Our association innovates once more by putting together this conference. This is why we find ourselves here today. We're here to talk about breast cancer, to address every aspect of this disease, from prevention until the life of patients after diagnosis and treatment. We are here to showcase the significance, importance, and difficulties in managing this disease in Greece today. All the speakers are distinguished members of the scientific community. They have long-standing, either first-hand or scientific experience in breast cancer management and all the related consequences at all levels, psychological, practical, etc. We are going to listen to them very carefully, and I am more than confident that at the end of this conference we will have laid the foundations for the extension and expansion of the existing programs with a view to better managing and addressing the disease and the direct and indirect consequences. With all that in mind, I would like to declare the opening of this conference, and I'm wishing every success to its works. Thank you very much. Dear friends, dear colleagues, I am Athena Vurtsi. I am a radiologist and specialized in breast cancer imaging, and I would like to warmly thank Alma Zois for this highly honoring invitation. I would like to congratulate the association. It is with great pleasure and pride seeing this effort being implemented. I have been standing on the side of the past 25 years, and I have attended the various actions and activities held by the association. I must say that this is a very exciting initiative. Ms. Gavrili, you see how emotional I get, because it is with great pleasure to see that we have Ms. Gavrili with us. It is the first Alma Zois conference, but until today, Alma Zois has played a crucial role in raising awareness among women. Alma Zois had ensured that the huge gap around breast cancer in Greece has been filled. Women now are aware of breast cancer. They're not afraid to share that they're breast cancer patients. Alma Zois has paved a very bright pathway in order for those women to embark on their journey. It is a valuable supporter and assistant. They have been trying to help women reintegrate, return to the society, familiarize with the disease. And today we see that Alma Zois has obtained a new dynamic. We have a new initiative. They have joined forces with the medical community, pharmaceutical community, all the stakeholders involved in this topic with a view to improving the quality of life of patients, and of course to adopting a screening, tangible and concrete screening program, something that would allow Greek women to enjoy what is self-explanatory in other countries. So I fully congratulate this initiative on behalf of the Hellenic Society of Breast Imaging. Congratulations, we will be here with you, we will stand by your side for everything you need. And I would also like to say that this effort is just a small step towards the right direction, but we are all making history here. It's something that will help the Greek society, it's something that will help substantially, because we talk about a disease that is very frequent, it's the most common death factor for women aged between 25 and 40, and we will make sure that we'll adopt the right screening program. It is through prevention that we will be able to save thousands of lives of women. It's something that has been proven by so many extensive studies that have been carried out in Sweden and the United States, something that shows that breast cancer-related mortality can drop by 40% in the case of effective screening program. So in this first roundtable, we have distinguished colleagues and other people from the healthcare sector. They're here to discuss screening and another very, very important issue. I'm talking, of course, about patients' registry. Ms. Valiakou is joining us here today. It is very important because it takes stock of the frequency, mortality rates. We can see what's happening. We can draft our strategies for the future. This is something that we're missing. We're one of the last countries in Europe that does not have a patients' registry. So we will take a stroke, we'll have an overview of the Greek situation. The speakers will share what we can do, which are the rules to be adopted in order to make the change, to differentiate ourselves and improve the quality of lives of breast cancer patients in Greece. Thank you very much. And now I would like to give the floor to Ms. Agapidaki Irini. Ms. Agapidaki is Secretary General of Public Health at the Ministry of Health. Ms. Agapidaki, you have the floor.
Good morning. I'm sorry I couldn't attend today. At least we have been given the opportunity to meet thanks to technology. So I'll start by clarifying certain things as to what is screening and what is not screening within the framework of public health. And this because it has been shown in many cases that in Greece, in our country, and in many other countries, there is some sort of confusion vis-à-vis these parts. And I think it's quite important if we set the framework vis-à-vis screening programs. So at least in the past 3 decades, there's great confusion in population and in experts, amongst the experts, as to what screening is all about in public health and what pertains to clinical care. Now, if one takes a look into international literature, one will see that we have these terms used alternatively. In some papers, we can easily see pre-operative control referred to as screening. However, in any case, we're talking about two distinct categories. In the case of public health, when we talk about screening, we are referring to screening programs, whereas in the clinical framework, we are talking about screening tests. Screening in public health pertains to an organized systematic program and not just the conduct of an opportunistic or occasional test. So if we have a person during a routine visit for arterial hypertension visiting the doctor, then we can talk about screening program for public health. In order for it to be such, it has to be done within the framework of an organized program applied uniformly by healthcare professionals in primary healthcare settings and should include specific procedures for those who have been identified with arterial hypertension, etc. An important parameter is that organized screening programs that are conducted at the level of population as actions of public health are easily evaluated and are considered to be much more reliable because we already know the target population who will benefit from this program. This is how we draw official information on the benefits of such programs, and in this way, through the years, we get reliable guidelines. So both in clinical as well as in classical epidemiology, screening is an indispensable part of secondary prevention, and it is defined as the total of measures leading to timely identification and proper management in order to prevent a disease and to do away with disabilities. So timely diagnosis and identification might mean that we have pathological changes that evolve and can be be traced even before they cause symptoms. This is the exact approach we implement in breast cancer and colon cancer screening programs. Now, within the clinical framework, screening is a recommendation by the doctor to the patient, and this usually takes place when the patients are at high risk for specific diseases. So we're talking about targeted screening programs, whereas in public health, we're talking about massive screening programs. This is a preventive action in the general population or other broader groups of the population without them being limited on the basis of risk factors, thus reducing the eligibility of the patients. So on the basis of research in our country, prevention is particularly underestimated and underrated, particularly in public health. So 75% of deaths are due to cardiovascular diseases and cancer, to a great extent preventable diseases. As a result, we lose on average 10 years of life expectancy. And it is worth noting that in 2018 to 2020, 1 out of 4 women had not had vaginal cancer, uterine cancer screen. 1 in 5 had not had a mammogram, and only 1 in 7 had colon cancer screening tests. As we can see in many countries, as we heard yesterday by the Health Commissioner, Ms. Kyriakidou, during the pandemic, the percentage of people who had who ran tests has dropped dramatically in most of the countries, and we expect to see this trend in Greece. These percentages are much lower in lower socioeconomic strata people. So aside from delayed diagnosis and low screening percentages, we have inequalities in health playing a very important part. In our country, we have the more frequent screenings within the clinical framework on an opportunistic basis, on the basis of the risk factors for individuals, while in other cases, for instance, in a clinical gynecological framework, we have preventive uterine cancer screening tests without there being a high risk. So we have done an adjustment which leads to an indirect distortion. This has taken with it other procedures as well. So when we talk about primary or secondary prevention, this takes place within a clinical framework usually, and it has to do with the individual and not with the general population. This is the reason why we don't have positive results vis-a-vis the health of the population, even when we run preventive tests, because there is no massive screening. Even so, we see that uterus cancer and breast cancer and screening take place, cervical cancer, screening takes place on an opportunistic basis and not on the basis of increased risk rates. This leads to screening being seen as a step towards diagnosis, and this does not allow us to develop a prevention culture, which might lead many a times to iatrogenic morbidity. Bearing this in mind, we want to apply public health screening programs at the level of general population, starting from breast cancer. And as it has already been mentioned by the Minister, this program is addressed to all women 50 to 69 years old who haven't had a mammogram in the past 2 years and have not been diagnosed with cancer. The national guidelines show that this population benefits the most from massive screening programs. I'm talking about general population programs and not about tests that women have while visiting their doctors. Now, in other population groups, we don't recommend massive screening, since research data show that the approach based on clinical framework on the basis of the health profile increased risk is much more effective for the rest of the age groups. So for the first time, our country acquires a massive screening program on breast cancer, colon cancer, and cervical cancer. And this has a dual benefit, aside from the expected and anticipated results vis-à-vis timely identification and proper management, which will lead to higher survival rates in our population. We have given the opportunity through these screening programs to get massive health data and the Greek population profile. This will allow us to build a database that will allow us to draw and design much more effective policies. Thank you very much. We can't hear the speaker. We thank Ms. Agapidaki. The microphone is off. So we warmly thank Ms. Agapidaki. This indeed fills us with joy. This new strategy and the decision by the political leadership is what will make a change. And finally, our country will be part of the screening programs regarding breast cancer. Now we are going to continue. Our next speaker is going to give us a presentation on the internet. We are talking about alternate professor of the University of Athens, a GP and oncologist, Mr. Koteas Ilias, who works with the Soteria Hospital. Mr. Koteas.
Good morning. Thank you very much. I would like to thank you for this invitation. It is with great honor that I participate in this conference. I would also like to congratulate Alma Zois Association for this wonderful initiative that truly focuses on the patient. I believe that this is something what we are missing in conference topics today. I would like to start by saying that we are discussing a cancer that ranks first in terms of frequency among women. 1 out of 7 women will develop breast cancer at some point during their lifetime. It's the second death cause after lung cancer. In Greece, we have more or less 7,700 cases per year. And of course, this should not take us by surprise because only 10% out of them are due to hereditary background. Well, we know that it's very frequent for women to come to us saying that there's no family history. My mother didn't have it, my sister didn't have it, how can I have it? Well, this is not surprising. 9 out of 10 cases, this is what we come across. So this is why we need to run screening programs. Some of you, some women might wonder, what's my risk to develop breast cancer? There is this model, the GUILE model. It's free of charge, it is online, it's addressed women aged 35 and more years of age. They can choose the answers that have to do with age range, what was the age of menarche, meaning the beginning of menstruation, which was the age where they first gave birth, if they have a first-degree relative who suffered from breast cancer, whether they have undergone any biopsy procedures, and depending on the answers provided, the risk rate emerges. It might be a 5-year-long risk or a lifelong risk. So if a woman says that there's no family history or nothing else, the risk will be 12-13%. This means 1 out of 7, 1 out of 8 women. This is very interesting, and on the basis of this model, we can also determine the requirements for the screening program and what every woman needs to do depending on their risk factors. Breast cancer is a disease that has seen an increase in incidence after the age of 45, 50 years of age. You can see that there's a significant increase after this age range, meaning that prevention is key. Prevention can detect cancers earlier compared to other women who do not undergo mammography. Here you can see on this slide what we want to ensure. We want to ensure that early diagnosis could be translated into increase in survival. Well, mammograms is a very good procedure. It's a procedure we're very familiar with, and in developed countries, this is a procedure that can be translated into a disease risk reduction. Here you can see a big and extensive analysis of 100,000 women. 550,000 women. Half of those women will participate in this program, maybe over the course of 10 years, might also receive a false positive result, a biopsy, a procedure that might be unnecessary. Okay, we know that this is also a possibility in the context of a screening program. It's something that cannot be avoided. I will try very briefly to shed some light on what new techniques in digital mammography can give us. We know that this is different compared to the traditional conventional mammography. We know that we no longer have a film record. We have a digital record. It can be better processed. Physicians can zoom in and out. We know that has higher diagnostic accuracy. Of course, sometimes we might also have some false positive results. It is a test that keeps gaining ground, and maybe physicians can choose it instead, prefer it over the traditional mammogram, tomosynthesis, or else 3D mammography, three-dimensional mammography. You might have come across this term. This means that we collect sections of the breast across various angles, meaning that we have a better representations and assessment of images and data obtained. Compared to traditional conventional mammography, it can detect more cancer types, but we don't have survival data. It is a relatively new method. We have some studies that are underway. We hope that we will have, of course, some false positive results, but maybe there will be fewer. This is another test that keeps gaining ground compared to standard mammography. Now, we have the magnetic resonance mammography. Some patients ask, should I opt for MRI mammography? Should I opt for the conventional? Well, actually, I'm afraid that there are no studies making a direct comparison between the two. We can know that it cannot detect the microcalcifications. It is more sensitive, but yet we will still have some false positive results, and literature does not support that in the context of a screening program for women of medium risk. This is more preferred to women at high risk of developing breast cancer. So this means that we know that this conference will discuss this topic later throughout the day, so I will not bore you with more details about that. Now, ultrasound. We don't have studies comparing it to mammography. We know that it cannot be an independent screening method. It has higher cancer detection rates in women with dense breasts. It can detect 4 to 5 more cases per 1,000 women. We know that in that case, we might also have an increased number of false positive results, and we also need to remember that it is a complementary tool in case of, okay, let me give you an example of a lobular carcinoma that cannot be detected through mammography. If a woman sees that there's an induration in her breast, maybe the palpation in combination with ultrasound can give us the diagnosis. So we do realize that it's something used on the side in the case of some gray zones where we need to have more information on the side of the standard mammography. Another thing that I would like to mention is the following. I have come across many cases of women who, receive a negative result from the mammography or any other imaging test, and they don't perform self-testing. Of course, we know that women should consult a specialized breast cancer physician, but in some cases, palpation is key to diagnose a cancer early. So we know that palpation and self-test should complement the mammography and the imaging results. And I'm talking about palpation by a specialized physician. And we know that the clinical examination and self-examination are not part of the screen. We have women who said, okay, I was palpating my breast every month. I was undergoing some tests and palpations. My physician, okay, this is not screening. It's good for women to have an overview of what their breasts look like, how they feel like, but they also need to consult a physician once they come across changes or alterations in their breasts. We always need to remember that in some cases, in order for a breast cancer to become palpable, this might mean that this has been active for more than 2 years since its beginning. So you do realize that in that case, palpation will not do us any good. What we need in that case is an early detection screening program. In women aged more than 40 years old, below 40 years of age, we don't run a screening program because there's not have anything to add, there's no added value. All the guidelines you see here on the screen have to do with the frequency of new guidelines publication per age group in order to discuss how frequent breast cancer incidences per age group with biopsies to give us only false positive results. And this also means that we have those conclusions and guidelines saying that women aged below 40 don't need to have screening. Between the age 40 and 44 can start with an annual mammography. We have a small benefit for the reasons I mentioned before, but women can discuss with their physician, say that, okay, I'm 40 years old, I want to undergo mammography. Women aged between 45 and 54, also an annual check with mammography, and women aged above 55, annual control with mammography. And when we also have a life expectancy of more than 10 years, when we talk about women with morbidities, when we have women with many comorbidities, we will not run screening. Those things are the conclusions of randomized trial. We also have observational studies that go up to 65 years of age among these women. So we know that older women need to discuss the pros and cons of the procedure in order to see whether they actually need to undergo screening. Now, when it comes to the screening program per se, well, all around Europe, we see that there are some organized efforts with the involvement of early breast cancer detection centers and, of course, physicians who are very familiar and experienced in reading mammographies. We say that, indicatively speaking, of course, physicians involved in this program need to interpret for up to 10,000 mammographies per year. So you do realize that it is very important to have groups or physicians rallying their forces in the framework of breast center that can make the difference. And I would also like to say a few things about the high-risk women. I'm not going to bore you with the details about that. We know that there's a dedicated roundtable later throughout the day. Magnetic resonance mammography per year is recommended to women that have a breast cancer development risk of more than 20% on the basis of the GAIL model, women that are healthy but have a BRCA1 and 2 gene mutations, women that have a first-degree relative with a BRCA1 and 2 mutation and they have not undergone genetic screening, or women who have received radiation therapy in the chest between the age of 10 and 30. That's all. Thank you very much for your attention. Thank you very much, Mr. Koteas. I'd like to thank you. It's a pity that we don't have you here with us in order to have a more thorough discussion or interactive discussion about that. I would just like to say, in terms of the guidelines, I don't want to confuse women who attend us. Right now, all around the world, a huge effort is being made in order to opt for the so-called personalized screening on the basis of the risk factors involved in every woman's profile. In that way, we'll be able to offer the best we can through imaging. That's a long discussion, I know. Thank you so much for your input. And I do hope that we will get to meet you physically in our next events. Thank you very much. Thank you. And now, I would like to give the floor to my dear colleague and friend, Mr. Chalazanitis. He is here with us live. He is a coordinating director of the Radiation Laboratory and head of the medical service at Alexandra Hospital. He is going to talk about screening program and what needs to be done in Greece.
Good morning, ladies and gentlemen, and dear colleagues. Now, before I start, I'd like to extend a great thanks for this honoring invitation. You've been honoring me for many years, and I stand by your side for many years, but I'd like to warmly congratulate the organizing committee. Why is that? Because you've been organizing a conference that is of particular interest. And this, well, I've been impressed by this, and I wanted to congratulate you on that one. As you heard, I too am a radiologist, and I have been lucky enough to have been certified in the European screening program. So I'll start my presentation with three findings. They are not that pleasant. The first one pertains to 2003, where we had the first guideline and directive on screening programs 21 years ago. And since in the title of my presentation, you have put what needs to be done, these findings have to be have to refer to that, what needs to be done. So 2007, 2017 and 2022. In 2007, Greece was at least one of the 5 countries without an organized screening program. 1 out of 5. In 2017, Greece was 1 out of the 3 countries without such a program. And in 2022, we have the announcement today that we are going to acquire soon such a program. And a third finding, World Health Organization, keywords, women, health, breast cancer and screening. And the answer? Sorry, no results found. So we are not in the picture vis-a-vis screening. So I'd like to have 2 more minutes for my talk, Ms. Vozzi. Only 2, yeah, of course. So, definitions, why screening, the current European directive, and proposals and recommendations. So, ever since we had this picture, this painting, maybe the first depiction of breast cancer, ever since that time, there was the issue of cancer, but we didn't know the solution. What the solution is prevention. Which kind of prevention are we talking about? Primary, secondary, or tertiary prevention vis-a-vis breast cancer? I remind you, now, primary prevention, adoption of measures, reducing exposure or inhibiting consequences from exposure to factors increasing risk. What is of interest, though, is secondary prevention, preventive screening, adoption of measures by the agencies of healthcare, not on an individual level, that will allow the diagnosis of pre-cancer conditions or diagnosis of cancer at initial stages. And finally, tertiary prevention, which pertains to women who have already manifested cancer and might re-manifest it at some point. So I'll be focusing on secondary prevention vis-a-vis public health care. Regarding this, there are guidelines according to which such tests are quite simple. Screening is quite simple. We're talking about healthy population, which aims at identifying risk factors or unrecognized disease or defects. In any case, the benefit should be much higher than the cost in order for such a program to be successful. Without the definitions, you know, you can't go anywhere. So we have an organized triage or screening program. This is what we are trying to achieve. This is what we're trying to organize, the ministry, I mean, because either through guidelines or special legislation, or this will lead us to the approved screening method, mammogram, etc. We'll see how often it should be done, the target population, the age, of the target population and the means of financing. Regarding the first three, we might rely upon European directives. The last one has to do with the competent ministries. What actually happens in our country nowadays is an occasional screening. There is an individualized approach. It's not stably repeated screening or control. It pertains to younger women in urban centers, so there is no equality in access to services, and it pertains to women with high socioeconomic level. So it is an opportunistic, it is not a massive population screening. Why is screening good? Because we know from literature that the earlier we identify and diagnose breast cancer, the better the results vis-a-vis the reduction of the death rate. The mortality rate. An overall survey from all screening programs in Europe told us that if we have a better coverage, I'm not only referring to geographical coverage, but also population coverage, then the number of deaths due to breast cancer in Europe could significantly drop. And another thing we got from this study told us that countries such as ours, need to do anything possible to start a program. I remind you that back in 2003 we had the first directive of the EU, but even in women where we diagnose advanced or aggressive breast cancers, they too are to benefit from screening programs regardless of the improvement of the therapeutic options that exist. So, timely diagnosis of breast cancer is key to the treatment. And this timely diagnosis, how can we achieve it? So you can see a blue line in the middle. What is it all about? This is the point where we start understanding symptoms. Before it, we have the screening, the preventive mammogram in so-called healthy women. And after the blue line, we have our diagnostic mammogram. In our country, there is no such distinction between preventive and diagnostic control vis-a-vis mammograms. Now, we are talking about preventive screening on the left of the blue line, and then on the right of the blue line we're talking about diagnostic mammogram, but the target is one in the two cases. Now, let's see what happens in the 28 member states. 25 countries have a program, a screening program. They have registries, etc. However, there are differentiations vis-a-vis the age of the screening tests. In 24 member states, there is a special committee. Aside from Belgium and Lithuania, such screening programs are mainly financed by state budgets, and the extra additional diagnostic tests that might be required are also financed by the state budgets. This needs to change here in Greece. In any case, the World Health Organization tells us that you should weigh the benefits as against the risks. So there are many benefits, as you can understand. On the other hand, there are risks such as overdiagnosis. Yes, indeed, there is such a thing. False negative, false positive findings, and the absorption of resources, both human resources as well as financial resources. You're not going to like that, because this is the official current European directive. You'll see why you won't like it. It is based on evidence-based medicine, and it is a guideline which is quite recent. It has been updated, as you can see, in January 2022, and this is the official European guideline for member states. So in this guideline, scientists from many different countries have contributed. Even Greek scientists have contributed to that. And I make this comment particularly today before this specific audience. Now, these guidelines and directives pertain to organized. Oh, I need to take a photo. I do apologize. Yeah, thank you. So we have organized state programs, screening programs pertaining to women with an average or intermediate risk rate. The proposals are for digital mammogram as the main method to diagnose breast cancer, as well as additional proposals regarding ultrasound and magnetic mammogram. There are recommendations vis-à-vis the frequency of tests and the age groups, etc., and recommendations vis-à-vis what we will do later on if we should we come across something suspicious, and recommendations vis-à-vis the special category of women with dense breasts. I'm not talking about customized or individualized prevention. I'm talking about general screening measures for medium risk population. So this is told to us by Europe. Now, in the age group of 40-44 and the age group of 45 to 49, what happens? 40-44, well, there is no participation recommendation in this organized screening program. I'm talking about the cross-cut screening program. From the age of 45 to 49, it is recommended every 2 or 3 years. Why is that? You can take into account the costs, the huge costs that this involves. To age group 50 to 69, each year it is recommended, and from 70 and onwards, every 3 years. There's special invocation in case of recall, in case of suspicious, etc. And there, what is proposed is DBC, tomosynthesis. So when we find that, when I identify a suspicious finding within the population screening, the EU calls for DBT in particularly dense breast patients. Next year or 2 years later, the test should be done using digital breast tomosynthesis. These are official directives and guidelines updated back in January 2022. Now, with regard to magnetic resonance imaging and ultrasound, this method is not recommended for breast tissue, for dense breast tissue. And it's quite strange to see this because this is my daily routine. But reading out why the committee has decided upon that goes to show what has been done. So each recommendation can be either strong or conditional, and this is where they base their recommendations or guidelines. Strength of the recommendation is something completely different vis-à-vis its interpretation by patients, by people in the general population, by experts who are going to design the program, and by researchers. However, this is not set in stone because the American Radiologists College tells us that preventive control should start at the age of 40. This is also said by the Swedish colleagues. There is this difference of opinions. However, I chose to share with you the European guidelines because in a country where there is no such screening program, we need to start from somewhere. Now, I come back to my proposals, which is the last part of my presentation. We do need to have a national program. We have agreed upon that for years now, and we are in need of a national committee that will consist of a specialized body that will undertake both the design, the organization, the supervision, and the training and education of all those participating in this program. What else is required? We need also to have an independent authority that's going to secure and ensure quality and will check the results. This independent authority to the US is the American Radiologists College. They are the ones who check screening programs. So in my view, here too, we should have a medical society dealing with that. Now, at the phase of organization, what plays a very important part, if we want this program to succeed, is to call women, the way we call women, we invite them, because this will play a part in the participation of women. So we need to go along the walking path to avoid mistakes. Now, vis-a-vis management and handling, imaging units, spread all over the place, in hospitals, wherever you have them. These need to be complemented by control units. I'm talking about diagnostic units. But in any case, in order for the program to be a success, we need to have 2 radiologists who are going to give their own independent opinions without knowing each other's opinion. There has to be this double reading. Now, in my view, this cannot be undertaken by the state sector, the public sector, by the public hospitals. We need to have a partnership with the private sector. Now, if women are found negative in this first screening, in this triage, well, they will be returned to the program in 1 or 2 or 3 years' time, depending on the age, etc. If she's found positive, then she'll have to go to a specialized breast center. Another issue here in Greece that we are missing such centers, and in these specialized centers, having had the mammogram, then we have to run all the diagnostic tests and the diagnostic mammogram as well. And in case this test is negative, then she'll go back to the program. If it's positive, then we need to have made provisions before we have started the program where she needs to go in order to avoid having to go from one doctor to another, from one practice to another, with a bag full of tests. What should be the objectives? So the objectives, we need to have main and intermediate operational ones. The main ones should be to reduce mortality rates, better quality of life. The earlier we diagnose cancer, the better the quality of life, not only of the patient herself, but also of her relatives, of her close ones. Doing away or reducing the hospital cost, this would be better for public health. And of course, we'll have much less social problems. Now, let's see intermediate operational objectives. First and foremost, we need to identify those eligible for screening, and then we need to call them. So we need to be well organized before we start the screening program. Those who will be invited need to come to as high numbers as possible to get a mammogram. This mammogram needs to be technically accurate, and doctors who are going to read the tests need to have received special training. There needs to be a follow-up. What will happen afterwards? What kind of tests are they going to have later on, or what kind of treatment are they going to be subject to? I include here issues such as stress, exposure to radiation, etc. We need to minimize all this. What else? We need to have an accurate program. What else? We need to get from this program studies and surveys that will help us improve ourselves. So therefore, there needs to be an audit. There has to be an effective use of both human resources as well as financial resources if we are to have maximum benefit for the general population. We need to encourage women with positive findings in order for them to proceed to treatment, not to lose courage, and this will lead us to the best possible therapeutic outcome. And finally, there needs to be an evaluation. As a director of a program, I've never been evaluated, and this I say because we have people hearing us from the ministry. I've never been evaluated. So, the aim is to identify breast cancer patients as early as possible. You remember the first painting I shared with you, the first depiction of breast cancer, according to Lancet. So in every organized screening program, we need to have systematic mechanisms for the identification of eligible women of the target population and approaching them through personal invitation, personal call to participate in every round of tests. Of these women we will be inviting, not all of them will appear, and of these who will come, only very few will have a suspicious finding, 2 to 3% in some countries, 7 to 8% in other countries, and this goes to show the success of the screening program. Of these women who will be screened, some will present findings. Those with a finding, I'm talking about screening, well, there needs to be a mechanism in place that will help those women deal with the situation afterwards. And there need to be rules of communication to safeguard personal data. In the Netherlands, the letter that we have found something in screening never reaches the patients on Fridays in order to spare their weekend. This goes to show the sensitivity of those who have designed the program. Now, screening programs enhance equality in prevention and anticipated benefits. Unfortunately, in our country, there is no equality in prevention. And this I say with sorrow. The implementation of a screening program does not necessarily exclude the occasional programs because we might have programs that will allow women to participate aside from the screening programs. Let me not get misunderstood. I'm talking about medium risk women, not high risk women. That is the overwhelming majority of women. We need to have a highly specific organizational structure level and possibilities to finance this whole endeavor. This is quite scary. Maybe we can have this partnership between the public and the private sector. This is something I wish for, but I don't think that we can achieve it. And of course, we need to have a continuous control and evaluation of the program. I hope I haven't told you, but did I take 17 minutes? Well, 20. Well, I do apologize. Well, thank you very much. This is my email for any potential questions. Thank you very much for this well-documented presentation and all the points you've touched upon. Thank you.
Dear friends, dear colleagues, we know that breast cancer is a heterogeneous disease. What does it mean? It means that manifests in different forms, in various forms. So across the various imaging tests I'm going to show you, breast cancer is a complex and inhomogeneous disease. It's very complicated because it does not present the same form and characteristics. This means that we're challenged in diagnosing and managing the disease, because apart from the diversity of the disease, we also have a different progression, because we know that not all cancers evolve and progress at the same pace. We don't know who are the women that will manifest the disease and at what age. Our goal and vision is to detect the disease as early as possible, meaning when it is at its early stages, in order to avoid metastatic disease development, meaning that in that case we have clinically palpable findings. We as clinical radiologists have various means in order to detect the disease, and we are part of the generation of radiologists and physicians who have seen wonderful results thanks to technological developments. We have seen throughout the years that since 1970, when we had the screen film mammography, we have now reached the digital mammography. In order to have imaging tests being as effective as possible, we need to combine that with exceptional technique and know the limitations, possibilities of every imaging technique. The physician who reads the mammography, the ultrasound, the MRI needs to be able to correlate the tests between them in order to have the best management of patients and the best possible outcome. We know that we also have European guidelines, as is the case in the United States. The same applies in Europe. We also have a protocol that needs to be followed in the case of mammography. There's a protocol for quality control in the technique of radiological tomosynthesis in order to extract as much information as possible. On this slide, you can see a very small lesion. The laser moves. I don't know why I cannot focus it. Maybe you can help me. So here you can see that. Just a moment, says the speaker. I think now my presentation is frozen. I cannot move to the next slide. Okay, so you can see here in this patient, this is a preventive mammography in a year aged 43. There is a microcalcifications area. You can see how close to the chest it is, very far from the nipple. This is a beginning tactile neoplasia that maybe no one would have seen that if we didn't have the entire breast imaged. Another case of preventive mammography in a 75-year-old woman. Inside the circle, you can see an area that is a small invasive ductal carcinoma that was detected because the quality of the image was very high. So we have some conditions for the excellent top quality, maximum effectiveness of the mammography. The equipment that we have should be up to date. Of course, this equipment needs to undergo preventive maintenance. Our experts need to measure physical parameters. The technique of the mammography needs to follow the specific protocol, proper placement of the breast, proper pressure in order not to have movement artifacts, and of course check the performance of radiologists and those who read those tests. You can see how we started from screen film mammography. Years elapsed, we went to the digital mammography, and now we have the latest aspect of digital mammography, which is tomosynthesis. We need to focus on a very important aspect. I'm talking about the technical equipment. The mammograph needs to be calibrated. We have specific phantoms, the one you can see here on the right. Before starting the mammographies every morning or at least once a week, we need our technician to take some images to see that top quality of the image is preserved. So the radiation dose needs to be monitored. We need those machines to undergo systematic maintenance, and of course, an annual test of the mammograph should be carried out by specialists. We as radiologists, in order to say that an image is of high quality, we need to be able to characterize a mass, as you can see here, to see whether there are any microcalcifications, if there's a distortion in the parenchyma architecture, whether there are any asymmetries, and we always need to be able to compare to previous tests. Well, the mammography protocol needs to be followed strictly. It needs to be strict. We need to have the entire breast included in the section. Here you can see that we have some tissue at the upper part of the breast. This needs to be included in the crown caudal image. Those things are very important, and we, as radiologists who sign those reports, need to see that every mammography that we see not only does not have a finding, but has also been performed properly. I don't want to bore you with too many details. Here you can see preventive mammography in a 50, 70-year-old. You can barely see a lesion on the right breast. This is something that could easily be overlooked by a technician because the other images not reveal that. But although we asked from the technician to pull the breast, here now you can see this malignancy is obvious. In any other case, it wouldn't have been seen. This means that in order to have the best performance, we need to have the best technique possible. Women with silicone pads and implants. We have 4, 5 women that every day that have silicone implants, and many colleagues need to pull the parenchyma, need to press and push the implant backwards in order to have both sections of the breast, with and without the implant being dragged away. We also have AI that can help us to ensure quality control of mammography. We, as physicians, cannot be on top of the head of our technicians. So what do? We have AI supporting us, saying whether this image is of poor, high, or medium quality, whether it's satisfactory, or whether it should be repeated. And of course, we know that risk is different for every woman. Here you can see the risk factors, but I'm not going to focus on that. What is important for you to understand is that every woman has a different profile. Not all women have the same risk, are at the same risk of developing breast cancer. I would like to focus more on women with dense breasts, because women with dense breasts, you can see this white cloud-like mass. When it's cloudy, although the sun is there, we cannot see the sun. So in this mammography with a dense breast, we have a dense breast, a small lesion that cannot be seen, not because the physician is incapable of identifying that, but because the breast does not allow us to see that. You can see that there's also another malignancy in between the fat that can also be identified by you who are not experts. So this is where ultrasounds step in. We have 400,000 cases that have been published with the European Radiology Society, where we detected 2-3 more cancers per 1,000 women. This is a highly affordable test. Of course, there are some conditions that need to be met. We need to have the right technique of the technician. We need to follow the guidelines of all the competent bodies and societies. The American College of Radiology proposes that ultrasound needs to be implemented in women with dense breasts, and we also have a European guideline by the European Society. It is a European Society of Radiology, and according to those guidelines, it is proposed to have every 2 to 4 years MRI performed on women with dense breasts, or ultrasound in women that cannot undergo digital MRI mammography in combination with the conventional standard mammography. And we also have the automated ultrasound. Well, this has a more different form, more stable image that can offer us 3-dimensional imaging of the breast across a very broad field, as you can see here on the slide. And of course, guidelines also exist in order to guide the technicians in order to perform that. Now, high-risk women are an entirely different group. Those women need to undergo mammography every year, and MRI mammography every year, as supplementing the conventional mammography as of the age of 30. And those women are not covered by a simple ultrasound or simple mammography. Here you can see 63-year-old woman with a positive BRCA1 mutation. You can see the malignancy that was apparent there. And in the case of the magnet, we also have very strict guidelines that we need to follow. A few words about how we can check the performance of radiologists. We have the tools in our disposal. We have this technology and this support. You need to be able to use it. It's like you have a wonderful car, but you're not a good driver. This is where you need to have the right conditions at the test room, ongoing training, lifelong training, specialization, etc. And of course, we cannot be disturbed when we read the test. It's not like what we have in hospitals. Everyone might step in interrupting us because they want to ask us something for their patients. This is very tiring. This means that our attention is distracted. We might miss something that might be harmful. So all those things have been addressed in Europe. Here in Greece, as Mr. Hellenic said before, we don't have a competent institutional body for quality control. We don't have certification. We don't have specialization. We don't have vocational and ongoing continuous training because those things are optional. No one asks us what we did, what we learned, what conferences we attended every year. And I would like to share with you a very recent mammography. We received that 2 weeks ago, a woman from Patras. You can see that she had a malignancy on her left breast. You can see we have the biopsy. This woman has undergone surgery, but the lymph node, the sentinel lymph node, had not undergone any testing, and in the ultrasound, no one had recorded the armpit situation. So we repeated that, and can you see here the mammography? You can see here the left breast. This is the part that we operated on. You can see the armpit lymph nodes and the ultrasound, how they're positive. So this woman needs to undergo again surgery in order to have the right staging, because a woman came here, she did her research, and she obtained this information, something that should have been given to her before she even asked. And this is something I'm very proud of. In the Hellenic Breast Imaging Society, we have some recent guidelines that we had submitted at the Central Council for Health that now have been acknowledged as guidelines that are relevant to breast imaging in our country. And this has been acknowledged and approved by the alternate Minister for Health. That's a very promising decision that does justice to our efforts. Those are the proposed actions that will upgrade the quality of mammography labs. We need to have the right certification and accreditation of breast laboratories. We need to establish a training program, lifelong training, continuous training, and according to our society, apart from the Ministry of Health, we also need to involve all the medical societies that are familiar with the topic and can contribute with their knowledge. Democrats should also be involved in this effort, along with other experts and specialists of the topic. I'm talking about the Hellenic Society of Mammography Technicians. Like I said, certification and accreditation is very important. We need to follow the guidelines and the instructions for quality control as dictated by EUREF. And now, training in breast imaging. We cannot have general radiologists with not specialized knowledge be reading mammographies. This is quite burdensome for the women. Here you can see the ESOMA requirements for breast radiology. Every breast radiologist should read 5,000 cases per year for those participating in a screening program. Here you can see some fluctuations regarding the required number of screens across various countries. It starts from 960 mammographies per year, every 2 years, excuse me, says the speaker, and it can reach up to 5,000 mammographies over 1 year in the United Kingdom. Now, audit indices. How do we perform? Are we doing well? Are we not doing that well? There are some markers that can show the sensitivity, the specificity, recall rate of the patients. Artificial intelligence is the future in breast cancer diagnosis, but it's not ready. We're not there yet. We need to be cautious, and of course we need to ensure the continuous training of our staff. At this point, I would like to thank you for your attention, and I would like to say that it is up to us to raise awareness among everyone in order to offer Greek women the best possible. Thank you very much.
Now I have the honor and pleasure to call upon the floor my dear colleague Eleni Faliakou. Ms. Faliakou is a breast surgeon, and I'd like to congratulate her for caring for her patients. You know that, we know that. She is the director of the second breast clinic with the Mitera Hospital. Eleni, you have the floor. Good morning from me as well, and I'd like to thank you for this honorary invitation to give a presentation. My topic is the patient's registry, difficulties and obstacles to its application and implementation. Why is it necessary? First, I'd like to start by saying why it is necessary. In Greece, unfortunately, as you've already heard, there is no patient e-file, there is no patient registry, that is, there is no recording of the number of patients suffering from cancer. And these rates that you heard of, we have 7,700 women per year. These come from statistics and extrapolations on the basis of mathematical models from diagnosed women with breast cancer in southern countries. There is no recording of the result and outcome of our therapeutic treatment. The only information we have is the number of women and men dying to breast cancer. The main aim of the registry is to collect reliable data on patients with neoplasias, aiming at designing a targeted policy. The registry will collect information systematically from multiple sources on neoplasias for a specific type of population, on the type of cancer, morbidity, mortality rates, the geographic allocation and distribution of cases, and monitoring the survival of patients. This allows us to identify the same individual through multiple registries. The sources are usually hospitals and clinics, laboratories, pathology clinics, hematology clinics, and death certificates. Now you'll see that the neoplasias records on the basis of hospitals collect information on patients who have been treated in specific hospitals. They assess the quality of the services provided, but they are not appropriate in order to design plans of anti-cancer patient policy because they do not represent, they do not respond to a representative sample of the population, and they are based on the mechanism of referrals of patients and the specialization of each hospital. Neoplasia records based on pathology labs, they do collect information on patients with a histology identification of malignancy. This is seen in a snapshot, and this does not form a representative sample of the population because they pertain to patients who have had an histological diagnosis of the malignancy. The correct neoplasia records are the ones based on general population, where we collect systematically information from multiple sources for patients with cancer living in a specific geographic location. They can support the selection of actions and are appropriate for a screening program. We need to have such a registry to follow up the impact of the disease, to define priorities, and they serve as a necessary tool for the design and planning of screening programs and for the assessment of the outcomes of such screening programs to see whether we are good enough in what we want to achieve. The Patients Registry contributes greatly to public health because it describes the extent and the nature of the cancer load and burden in a community. It helps us follow up and evaluate the efficacy of screening. Through that, we are able to evaluate the quality of diagnosis and care. Also, this provides us with clinical studies material. Also, it contributes to epidemiology of cancer because we get information on the allocation and distribution of cancer on specific targets. We get to have information on cancer depending on the age, gender, the place of birth, and the residence. And in this way, we can have interventional studies. For instance, we can find out that children vaccinated in Gambia, where we had the vaccination of 60,000 children, had a much lower rates of hepatocellular cancer later on. This intervention helped us find this information, and it was cost effective. Also, it contributes to identifying the incidence of cancer. We assess what the burden of cancer is on the health system, and we identify geographical differences, and we can also identify potential causes. This allows for the development and implementation of policies on health following a rational planning and design vis-a-vis screening programs or primary and secondary prevention. There can also be an evaluation of the achievement of the policy on health goals. The information we get from the patient registry might be fed to involved bodies. The identification of the diagnosis stage for primary cancer is associated with awareness of the population on cancer, the available diagnostic services, the accessibility to diagnostic services, and the existence of required resources for treatments. Also, this incidence assessment helps us develop long-term screening programs and research programs against cancer. Also, it contributes to primary prevention because there is an assessment and evaluation of the efficacy of primary prevention measures, thus allowing us to avoid exposure to harmful factors associated with cancer. For instance, avoid smoking, vaccination for hepatitis B, again in Taiwan, where we saw that there was a reduction of the incidence of children's hepatocellular carcinoma. Also, it contributes to secondary prevention through evaluation and follow-up of programs of screening programs. What are the obstacles to its application and implementation? The registering of patients with cancer from their treating physicians is obligatory. There has been an old law regarding the organization of anti-cancer battle. Now, we are obliged to record them. There has been an effort to develop the national neoplasias record in the operational program 2007-2013. It had been financed through the National Strategic Reference Framework. The National Action Plan on Cancer, we're talking about 2011-2015. So through this National Action Plan, we identified certain lacunes in the health system. Lack of integrated and cohesive intervention, fragmentation of services, fragmented programs, and islets of excellence in Greece. There was lack of reliable data to allow us to depict the actual size of the problem, something that is going to be solved by the Patients Registry. There was no national design and planning of screening programs. There was lack of specialized centers, and there was a significant lack of palliative medicine. So there was this first effort to operate the National Neoplasia Archives through the Greek CDC using finance from the EU. So in December 2011, we had a systematic upgrade with a collection of necessary data. As a member of the board of a non-for-profit organization, I took part together with Alma Zois in this effort. Of course, this led nowhere. The collection of data was done through recorders, and in it participated all the private and public hospitals. Obstacles. Well, the collection of the necessary information called for know-how and time. There was lack of automation in hospitals, the non-updating of the patient's medical files, even hospitals that did have IT systems. And back then, we didn't take down fully the social security number of patients, something which we have corrected through e-prescription. Nowadays, the problems identified in an event taking stock of the efforts back in 2015. There were difficulties pertaining to political leadership. There was no constant commitment vis-à-vis the operation of the National Archive. There were no sanctions for non-abiding by the regulations. Now, from the part of the hospital administrations, they wouldn't apply circulars, they wouldn't abide by the procedures to record cases. There was lack of electronic files. They wouldn't update the e-files wherever they existed. There was lack of procedures to call for further tests. They would assign other tasks to those responsible to record the data. And vis-à-vis the medical staff, unfortunately, it was found that there was lack of registering of basic information. The doctors would not take part in oncology committees, and there was lack of organization of individual responsibility. Vis-à-vis the recorders, there was a lack of individual responsibility, lack of target setting, and unfortunately, they didn't have the necessary qualifications. And it was found that there was a lack of cooperation between the medical community and the National Neoplasias Archive. The World Health Organization reports that the success of a patient's registry depends on its support by agencies such as those specialists who were involved in diagnosis and treatment, hospital administrations, services registering deaths, statistical services, the Ministry for Health, and the local governments. Concluding, I'd like to point out, this is from the website of the Ministry for Health. This is the National Action Plan for Public Health 2021-2025. Trying to look hard, I found in one point that they aim at having an IT upgrade of the central services of the Ministry, and an IT systems upgrade of the public health services. And there is the intent to have an e-management, electronic management. In fact, what they mean is that they'll be using internet access to get information on patients and patients' diagnosis. This shows the timetable for the budgets, as we can find it in the website of the Ministry for Health, and the very high amounts of multiple millions of euros that will be allocated to the Spiros Doxiadis National Prevention Program. Unfortunately, making a research on the strategic axis, we can see that in under axis 4 we have an amount of 24,000 euros only for the National Archive. And you can see here the amount 0. I think that they are going to change that. I hope that they're going to change that. This is one of the reasons why we meet here today. So finally, I'd say that there are indeed difficulties and obstacles. However, the patients registry is a necessity to public health and should become a priority. We're one of the very few European countries who do not have such a registry. Let me remind you that this has already started since 1930. The automation in hospitals is necessary and is a requirement for the creation of the patients registry. We need to utilize and tap into the knowledge of specialized personnel, and of course the aim is always to provide better care. Thank you.
Thank you very much, Ms. Faliakou. And now we will listen to our last speaker for this session. It's Mr. Kotskiopoulos Ioannis. He's the Secretary General of Health Services at the Ministry of Health, and he's going to talk on behalf of the political leadership. He's going to talk about the patient registry and what's the current status in Greece. Good morning. I hope you can hear me all right. Yes, we can. Thank you. First of all, I would like to apologize for not being able to attend physically, but I'm afraid my agenda is extremely busy. So before starting with my presentation, I would like to thank the president of Alma Zois, Ms. Michalopoulou, for honoring me with this invitation to address you in the first conference of breast cancer patients. I mean every word I say, because Alma Zois is an association has been claiming the rights of patients for so many years, and they joined their forces with ours in the long-lasting battle against cancer. This association gives an added value to the policies we're implementing. This year, European Union has highlighted that this year is a year of cancer, discussing the need to join forces in the battle against cancer. And the Prime Minister, Kyriakos Mitsotakis, has included this endeavor as a priority in our agenda. I'm afraid that due to the pandemic, we had to focus our design and strategy on COVID management. Instead, it is true that considering this unprecedented medical emergency we're experiencing, some generous transformations and reforms we wanted to implement have not progressed as anticipated. However, there are some developments in the case of patient registries. I'm talking about cancer patients registries. At this point, I would like to say that cancer could be characterized as a pandemic running in parallel. 1 out of 4 deaths all around Europe is due to cancer. It's the second cause of death all around the world following cardiovascular diseases. So everyone needs to have equal rights to access to care, diagnosis, and high-quality treatment. Everyone should have equal access to medicines in the same hope for survival, regardless of where we live. Otherwise, all the ominous predictions of experts will become a reality when they said that the new cancer diagnosis will double by 2035 unless the state adopts new measures. It is in this framework that I would like to focus on the European Beating the Cancer Plan. That is the main political commitment in order to reverse the situation in terms of cancer. And we know that this is another key milestone in order for us to be better prepared, more resilient in European Union to address health-related issues. This is a cancer plan that will be funded with €4 million, and part of that financing will come from the EU4Health Fund. We participate there as a country. Over the past years, apart from the extremely difficult and unprecedented reality brought forward by COVID-19 pandemic that we had to tackle, we also took the very first small but important steps in patient registries creation. At this point, I would like to congratulate the previous speaker who talked about patient registries, because she made an in-depth analysis of what's happened in the case of patient registries. I believe that everything that has been mentioned is, of course, accurate and correct, with the exception of what we do. And by we, I mean the state. So, what have we done? I would like to remind you that we have put in place the child cancer, the pediatric cancer registry, which has been implemented during the pandemic. It started operating in January 2021, and we also have another registry for leukemia patients that started running from AOP in February 2018. And I would like to remind you that this is a compulsory and prerequisite in order for those patients to prescribe their medication. We also have the COVID-19 patient registry that was brought forward, was set up and started running as soon as the pandemic emerged. So we do have the know-how that makes us optimistic that we'll be able to move forward and create all the other patients' registries. On this occasion, I would like to publicly thank the head of the Ministry of Health Patient Registries, Ms. Micha. She has been one of my associates for the past 3 years. She has been struggling to help us develop patient registries in Greece. I would also like to talk about the contribution of my predecessor, Mr. Giannopoulos, who launched this initiative, and now I'm building on his work. I would also like to say that various members of the academia and scientific societies take initiatives in order to record those patients for research purposes, but those things are fragmented, scattered, and they're time limited, despite the fact that all scientists contribute the best they can. As the previous speaker said, we don't have an official registration of adult cancers either at national or local level. The result is that we cannot keep track of the main epidemiological indices, and on the other hand, our country cannot be represented as it should in before the European bodies. If you make a search of the cancer epidemiology in Greece and WHO website, you can see that they only have estimates on the basis of the local registers or the registries of neighboring countries. Greece is one of the few countries that does not have the elementary epidemiological data that could support research and evidence-based research. Now, when it comes to the cancer patients registry, I can tell you that this is the top priority for our ministry and the main component of the digital transformation of the health sector. Let us not forget that today we have international experience. European Rare Cancers Network guidelines, and we also have, of course, the Greek contribution that has been developed on the basis of the registries I mentioned before. So, capitalizing on these factors, and amidst the pandemic, a few months ago, the Secretary General for Health Services, we drafted an ambitious plan for digital health. It runs in parallel with what was mentioned before, the Spiros Doxiadis program. It has been submitted. It relies on 4 pillars that are the prerequisite in order for us to develop the necessary infrastructure for patient registers creation. So those 4 pillars are the electronic health record, the digital upgrade of hospitals in order for them to be able to provide data and have their systems upgraded, remote medicine, telemedicine, and the 4th pillar is the digital program for cancer management. This is one of the 4 pillars of the digital transformation of our country. This program, in collaboration with the Ministry of Digital Governance, has been submitted to the European Recovery and Resilience Fund, and today we're in the first phase of implementation, meaning that we're preparing the technical bulletins that need to be approved in order to start the tender process. The main goal of this program is to offer valuable tools to all healthcare professionals who are responsible to look after cancer patients. We want those digital tools to be the assistant of both physicians and nurses in order to create an environment where our patients will receive safer and better care. We try to promote standardized processes and protocols, not to limit the judgments of the physicians, but we want to ensure that all clinical decisions are being made on the basis of the right evidence. Patients should also be involved because it is thanks to those tools that they will be able to better manage their health-related data. It is clear that now patients have the right to easily have access to the health data through an official application system in order for them to receive support throughout their journey. On top of that, it's very important for us to collect more and better clinical practice data for cancer. We will use that in order to draft health policies, conduct scientific research, and guide the pharmaceutical developments to this direction. I believe that apart from the implementation of this ambitious program, now we're in a position to launch scientific debates in order to capitalize on the knowledge of the pharmaceutical industry and the academia. The National Cancer Registry will be one out of the 3 digital cancer management programs. I would like to remind you that we also have the oncology hematology IT system that will actually support the interdisciplinary boards, and the third is digital applications that will support the patients. We have already the RRF, the Recovery and Resilience Fund, that has given us hundreds of millions of euros in order to implement this program. This is very valuable resource in order for us to implement that. The National Cancer Patients Registry will be a valuable database for research, but in order to do that, it needs to be supported by modern technological solutions and the properly trained experts and professionals, as it has already been mentioned in the previous speech. It should be easy to use, it should be supported by the right resources, and it should be aligned with European guidelines in order to be the timely data extraction resource in Greece. So a few days ago, I have created a working group for the preparation of this project, and I would like on this occasion to congratulate all the members of the working group and, of course, the scientific societies, for example, the Medical Oncology Association, the Hellenic Hematology Society, and all the experienced members of staff of the health sector coming from all the stakeholders and relevant competent bodies to support us in submitting this all that has been submitted 2 days ago to the Minister for signature and further consultation. I don't know if I have more time to say a couple of things about the technical bulletin in order to guide you through the digital cancer program in Greece. The goals of the National Cancer Patients Registry is to systematically collect data for morbidities and mortality in cancer. We want to monitor the development of cancer over time, the determination of population groups that run higher risk of developing cancer, the conduct of epidemiological and research studies, and of course the anonymized data collection that can be compared to other European registries. This registry will collect data across all health sectors, both for the private and the public sector. Data collection will happen online, and of course the structure and the content of this registry will be specified by the scientific committee that will be established over the next months. Apparently, like I said before, we're also going to consider the guidelines proposed by the European Network of Cancer Registries, and we would like to keep the same pace with the European community in terms of data. In conclusion, I would like to add a couple of things more. The previous speaker also mentioned that when we talk about data, we should not focus only on technology. Okay, technology is one factor, but people is another more important factor. People will make the difference, and by people I mean healthcare professionals, nurses, physicians, experts and specialists in the hospital. They all need to be on the same page. They all need to join the forces in order to have properly filled in-patient registries in Greece with high quality data. Of course, there are staffing problems compared to other systems abroad. My personal example is that in an average hospital I was working in United Kingdom, I had 100 members of staff focusing on the e-health aspect. The biggest hospital of our country, in Greece, I'm talking about our country, Evangelismos, only has 4 IT experts. So it is under this perspective that we need to consider the development of patient registers in our country. Apparently, we need more trained officials in order to ensure the better update and data collection in those systems, and physicians cannot be the only ones competent to fill in these patient registries. They have 1,000 more other tasks to fulfill throughout the day. So we need to take this a step further, and as soon as this project matures, we need to look into the big picture. I'm not only talking about technology, we also need to look into the people and the operations in the hospital, the operations underlying the patient registers. All these things need to be carefully considered along with the scientific community. They need to be co-designed, because we have seen other efforts in the past that remained incomplete. And so we need to learn from mistakes in the past, and we need to be optimistic, move forward. Now it's the right time, because we have the know-how, we have the expertise, and the financial resources in order to put together the structures that we're truly missing and can make a vast difference for our patients. In conclusion, I am optimistic. I believe that over the next month we will be lucky enough to collaborate with all stakeholders in order to further specialize those technical bulletins. This is a very promising field for collaboration, because we are called upon to co-shape those documents. Again, before I rest my case, I would like to thank you once more for this wonderful conference. And I promise that I will stand by your side in all your future endeavors. Thank you very much. Thank you very much, Mr. Kotsiopoulos, for this very optimistic update. Thank you.
So we have 15 minutes at our disposal. Can we take time from the break? Yes, thank you. So we have Ms. Adieri next to us. We'll start with the questions and comments. And of course, we have the honor to have with us on the internet the former Deputy Minister, Minister for Health, Mr. Xanthos. Good morning. We'd like to thank you for being here with us today, either through physical presence or through the internet. Now, I heard attentively what was developed by our distinguished speakers, and I will start by the screening. So we welcome this prospect that was presented to us by the Secretary General for Public Health, and we hope that this is going to be implemented successfully. We're talking about a prevention program that, as we heard, will have the name of the late Fofian Madame. Since Greece is amongst the 2 last countries in the EU not having an organized screening national program, which leads to us being deprived of an instrument for timely diagnosis and treatment of breast cancer. Now, summing up what we have all heard, the notification for a free examination of women by digital mammogram, by sending them texts and their mobile phone, does not on its own constitute an integrated screening program. The program is a whole procedure that needs to make sure that there is broad participation in operation of a screening registry and the appropriate quality quality assurance. Of course, it also has to have a well-fixed and determined path that women are to follow following a positive or suspicious result in mammogram to further evaluate the findings, further have clinical examinations or diagnostic tests at a specialized breast center. This program should also be supported by the appropriate information and awareness campaigns for women, talking about adult women, particularly in remote areas and vulnerable groups. We need to make sure that everyone understands the benefit from the optional participation of women in this program. Of course, this benefit is well recognized and acknowledged, and it pertains to multiple levels: individual level, family level, and socio-economic level. But we need to have clarifications on some key points. As Ms. Agapidaki mentioned, the age range is recommended for 50 to 69-year-old women in Greece. Most countries in the EU apply such a program for this age group already since 1986. However, on the basis of more recent feasibility and security and safety studies, some countries expand the age group from the age of 45 to 49 and up to the age of 74, which is something required in Greece as well. A second point identified is the pathway followed after mammogram. Which specialty will the women be referred to in case of positive or suspicious findings in their examinations and tests? What if further diagnostic tests are required? Will the public health system cover such expenses? There needs to be such a provision. Where will these tests be run? Who is going to be evaluating the patients? Will women be able to have access to diagnosis through public hospitals, breast clinics? Under which procedure and under which priority? How is there going to be a certification of radio diagnosticians? As Ms. Voce mentioned it already, they need to have appropriate training, experience, and know-how. In 2021, the European Commission Initiative on Breast Cancer published guidelines and the procedure together with the age range for breast cancer screening programs in the EU countries, as well as the specifications of a quality assurance program or system that will cover the entire path from identification, diagnosis to palliative care. It is important to have an association between the registry of the screening program and the registry of breast cancer patients if we are to draw significant information, valuable information with regard to the quality and the impact of the program, documenting the trends of incidence of the disease and of the mortality rate. Despite promises by the Ministry for Health, so far we haven't been invited to discuss on screening programs. We believe that the cooperation of patients associations already in the phase of planning and design, particularly when we're talking about digital health applications, is significant because they can tap into the vast experience of patients' representatives, making sure that the systems to be set will operate successfully. Now, with regard to the Secretary General for Health Services presentation on the patient's registry. There is this mobility, and we are happy to see that there's a will to do away with the inadequacies of the past in order for our country to acquire, amongst the last ones to do so, a patient registry. There is experience and best practices from a patient's registries already there in place for many years, as well as screening programs. There is recent experience from national patients' registries. Let's remember the COVID registry or child neoplasia registries. We understand that we need to have a coordination at many levels, but we hope that the timetable set will be realistic and that the registry for breast cancer patients will become a reality, will be applied, and will be functional and operational in the near future. In brief, there is a need to also register relapse in this registry, something which does not take place in any registry in any country. If we can't tell how many women have the condition, what stage of the disease are they in, how many are the survivors after treatment? How many present metastases? Where are they in the country? What is their age? Who among them are high risk? Well, we won't be able to assess and evaluate the prevalence of the disease, the mortality rates, and the morbidity rates, and there won't be any national strategy and targeted health policy to manage breast cancer in our country. Our associations remain at the disposal of the ministry to cooperate on the above issues in order to be able to cover the needs for quality services of timely identification, diagnosis, and registering of breast cancer patients in Greek population. Thank you very much for your attention. Well, thank you, Ms. Arieri. Thank you very much for your comments and the points that you shared with us. And now I'll give the floor to Mr. Andreas Xanthos, who is going to join us on the internet. I hope you can hear me. Yes. Okay. Yes. Yes. So I'd like to thank you too. I'd like to thank Alma Zois and the scientific committee of this conference for the invitation and the possibility to contribute to this public debate on cancer policy in the country. I think that this is the most important subject that Ms. Arieri touched upon the critical and crucial priorities vis-à-vis a holistic approach of policy on cancer, starting from prevention, timely diagnosis, up to palliative care. Now, I believe that we are currently at a crucial and difficult conjuncture. Health global crisis is still with us, and this has unfortunately created an impact on the operation of the public health system and of the care regarding all other conditions and diseases other than COVID. This COVIDization, as has been mentioned, of the public health system has greatly affected the follow-up and care of vulnerable patient groups such as cancer patients. And I think that this is a top priority to have the public health system return to a fundamentally sound operation. We need to go back to normalcy. We cannot refer to a return to normalcy in economy, in leisure, or elsewhere without us referring to the return to normalcy in the healthcare system and the recovery from the wounds we've suffered in the past few years. Secondly, we need to have a more systematic intervention vis-à-vis human resources in the system. Obviously, infrastructure, equipment, digital transformation and upgrade of the system, the new digital tools, patient registries, all these are crucial and critical requirements, sine qua non. However, the biggest problem with the whole system nowadays is the understaffing and the staffing crisis. We have a huge wound due to brain drain, which still goes on. We see trends to move abroad, and this needs to be reversed. Following a more holistic intervention that might pertain to labor conditions, payroll conditions, continuous training, scientific development, and a plexus of incentives that will allow us to retain our scientific resources. And specifically for concept policy, I think that we need to take reform steps that have been initiated in the previous period but have stagnated. There is invocation of the excuse of the pandemic, but I don't think that this is only owed to that. There needs to be a continuity in state interventions. Mr. Kotsiopoulos has mentioned the positive contribution of his predecessor, but there have been important steps that have been taken in the previous period. We had the special registry for neoplasias. The ambition or the aspiration was to have this as an institutional umbrella set by the state for an integrated intervention in cancer, but unfortunately it's stagnating. Also, we have had the network of services and precision medicine centers. This too is crucial. Personalized medicine, biomarkers, all this incorporation of modern scientific knowledge and advances should be part of a targeted intervention by the state. All this in combination, together with the crucial priority of a new public health system and a new organization, a setting up of public health services in the country, that would be the legacy after this prolonged and painful pandemic. So within such a perspective of overall upgrading of the health system, of the structures and of the resources, this would be required. And I think that within this, cancer patient care should have the points that are missing, offering dignity. Thank you very much for the intervention. Thank you, Mr. Xanthos, for everything that you shared with us. Indeed, the science or health has no borders, knows no border, knows no color, so we need all to contribute for the best. Thank you. And this brings us to the end of this session. We'd like to warmly thank Ms. Michalopoulou. No questions? Well, I'll let you know. We'd like to thank all the board members, Ms. Mitzi, all our speakers, all of you who are with us here, and those of you who are attending on the internet. Thank you for your time. Now we'll get a break, a 10 minutes break. Now, any questions, please submit them to Ms. Christiana Mitzi, and we'll make sure that we will answer you. Thank you.
Ευχαριστούμε.
Good morning, everyone. I welcome the first breast cancer patients conference organized by Alma Zois, and now we continue with the second session of this conference, focusing on breast centers. I would like to thank you for the invitation. I would also like to congratulate Ms. Michalopoulou, Ms. Mitzi, and the board of Alma Zois Association for this effort they are making. It is very important to have such initiatives, and it is important that Alma Zois has brought forward a couple of issues that scientific societies have been discussing only superficially. Of course, I'm talking about the integrated, comprehensive management of breast cancer patients, breast centers, and we have seen the answers of the state as well as the patients' registries. Thank you very much, Ms. Michalopoulou. Congratulations once more for this initiative of yours. I don't want to bore you anymore. With no further ado, I would like to give the floor to our first speaker, who is Mr. Yannis Flessas. He's a breast surgeon, and he's director of the breast surgery clinic at Erikos Dinan Hospital Center. He's going to talk about the integrated care of breast centers. And I would like to ask our speakers, please, to stick to their time. Thank you. Okay, good morning from me as well, Ms. President of the Breast Surgery Society, ladies and gentlemen. I would also like to thank the organizing committee and Ms. Michalopoulou for this wonderful initiative to bring us all together around the same table in order to discuss all those problems that we come across in our daily life. And now it's high time we did something for that. I would like to talk about what an organized breast center is. Now, what is a specialist breast center? I would like to say that in developed countries, all these things have been extensively studied, organized, and structured. Here you can see a paper. All the EUSOMA members have extensively discussed and come up with the requirements of a specialist breast center. So, which are the things that we know? We know that we need to lay special emphasis on increasing quality of organizations and optimizing the results for the patients. European Cancer Concord is a patients' partnership, and it's also a partnership of patients, health supporters and professionals, because they have seen that there are huge inequalities as to the quality of cancer management and the extent of financing in Europe. EUSOMA, since 2000, and in particular since the first European Breast Cancer Conference in Florence in 1998, published a study entitled The Requirements of a Specialist Breast Unit. This also included a more recent study that analyzed all the topics of concern that need to be developed so that those who are responsible to organize and finance breast cancer care ensure that all women have access to fully equipped interdisciplinary and specialist breast clinics on the basis of the population. And I will explain what I mean by that. First of all, what is a breast center or breast unit? It is the place where breast cancer is diagnosed and treated. They need to provide all the necessary services, including both prevention, genetics, diagnosis, the treatment of the primary tumor, the care provided in cases of advanced disease, as well as the supportive and palliative care of patients. All those things, I'm afraid, are things that, given the rush and the craziness of the public system, are missed or overlooked, and they're very important. A breast center includes a team of specialists on breast cancer. They operate as a multidisciplinary team, providing access to all the facilities that are necessary in order to provide high-quality care throughout the breast cancer pathway, throughout the stages, because we know that management does not end at the time of the diagnosis or the surgery. Breast centers should be organized in one location. However, if this is not feasible for organizational reasons, then some services can be located in the broader geographic area. This is a EUSOMA proposal, and if we consider that for Greece, we do realize that it's something that can be easily implemented in the big cities. But if you consider remote areas, islands, we all know that access is limited and difficult, and many women change their treatment. For example, in order for a resident at Limnos Island to undergo radiation therapy, she needs to move to the capital. Those breast centers operate on the basis of specific guidelines, protocols, and criteria. So by protocols, I'm talking about the official procedures or sets of rules, including local organizational aspects for the diagnosis and management of breast cancer across all its stages, including the long-term follow-up. And we also try to have the breast data audit in order to assess the quality markers to identify throughout all stages of breast cancer all the corrective actions that are required. So we need to revisit all those things to see whether they function properly. Now, in an organized breast center, we need to have a regularly held multidisciplinary teams meeting, the MDM meeting, as we call it. It is a board where the main MD team convenes to assess and schedule the next steps of the patient's care at any stage of the diagnostic and treatment procedure. So they need to convene before the surgery so that all the specialists can make their proposals regarding the management handling of this patient. And then those members that I will elaborate on straight away include the breast surgeon specialist, who is a person that is fully certified and trained in managing breast cancer and oncoplastic techniques and methods. And as you can see here on the image on the left, this team includes numerous members, and they need to be part of this board of this team. The next speakers will explain how they need to collaborate, always on the basis of ensuring the best outcome for the patient. Like I said before, we have the breast surgeon, the pathologist who is specialized in breast cancer diagnosis, medical oncologists who need to be a certified medical oncologist specialized in breast cancer. It is very important for every specialist that offers a systemic treatment to have received training as set forth by European or global programs. We also have breast radiologists, and we have already heard things by the previous speakers and Mr. Halazanitis. They are certified experts in imaging, and they're specialized in diagnosing breast cancer, including all the diagnostic invasive procedures. Just like the secretary of the association said before, it's not enough to diagnose the problem. You need to know what the next step is, who will deal with it. Will it go to the radiologist, and the biopsy will be obtained? And then we also have the radio technicians, who are technicians specialized in breast imaging. We also have psychologists. They are professionals who can identify the stress and mental morbidity in order to step in breast cancer patients and their families. At this point, I would like to congratulate Alma Zois, because they have also developed the hotline that has truly helped many of our patients. We also have the pharmacists, specialized pharmacists who specialize in dispensing cancer treatments. We have nuclear medicine physicians They need to be certified experts trained to manage breast cancer patients, including the sentinel lymph node and molecular imaging techniques, and of course physical therapists who are professionals who can be very helpful during the recovery after the surgery or long-term in case of lymphedema. And we also have specialized breast nurses. They need to be specially trained in how they can provide this nurse care in breast cancer. Breast data responsible, who is responsible to ensure that the health record is kept as it should be. Plastic surgeon, the invasive radiologist, who is a certified specialist performing invasive radiology techniques, such as in cases where we have remote metastasis and foci, where we need also to have other types of biopsies, either through ultrasound, guidance, etc. And we also have the palliative care experts. They need to provide physical, psychosocial, and mental care to patients who are facing severe symptoms. We also have clinical geneticists, and they are the physicians who can highlight the genetic background risk with some percentages in some women. They can advise women to undergo specific genetic panel testing, etc. As you can see, we have numerous colleagues who need to collaborate to ensure the best possible outcome. However, in order to be able to say that a breast cancer operates as per the standards set, they need to serve a minimum number of patients. I would just like to say that this breast center needs to address at least 150 newly diagnosed cases of breast cancer, 50 cases of breast cancer, of metastatic breast cancer actually, and this minimum number is necessary in order to ensure the technical expertise and adequacy of the center, as well as to ensure the viability of this structure. Breast oncologists, they need to have at least 50 early and 25 metastatic breast cancer cases. The radiologist should address 50 early breast cancer patients. The radiologists need to have diagnosed 1,000 mammographies, 200 ultrasounds, and 50 MRI mammographies, as well as 50 minor breast cancer diagnosis procedures with core needle. And of course, the same applies to technicians, the pathologists. They need to have seen at least 50 pre-surgery, pre-operative samples and 50 primary cancer resections. I would also like to highlight a couple of things that I saw in terms of the priorities of the center. Diagnosis should be communicated to the patient in a face-to-face meeting as soon as possible. It should not take place through a letter or over the phone, unless there are special circumstances that require that, because we have patients coming to us all around Greece, and we do realize that we cannot have someone jumping on board of a ship to come to Athens to get their result. However, we need to communicate the results properly and adequately, and every patient needs to be informed about every step of their diagnostic and treatment pathway. They need to be given time to explore alternatives or choices and make an informed decision. We cannot exercise more pressure to those patients. We need to give them time. And they need to feel free to ask for a second opinion without them being punished in any way. The last point I would like to highlight is that on the basis of the rules and guidelines, patients need to start with primary treatment within 4 up to 6 weeks maximum as of the first diagnostic test at the breast center or the first visit to the physician. I'm afraid that numbers in Greece are not bad. They are longer for the initiation of radiation therapy and surgeries. And I would like to conclude by saying that an organized breast center needs to focus on research, papers, research protocols, run a quality control scheme. I believe that the next speaker will talk about that. But on top of that, the most important aspect is to ensure the multidisciplinary collaboration. Thank you for your attention. Thank you very much, Mr. Flessers, for this presentation. Thank you for giving your time. Now, we know that thanks to Ms. Michalopoulou and Alma Zois and Ms. Mitsi, we have already initiated a discussion with the Ministry of Health in order to map and set the conditions for the creation of breast centers in Greece. As you can see through this presentation made by Mr. Flessers, this is a very important initiative, and I would like to congratulate Alma Zois because it was the first time that they contacted the ministry for and advocated for the creation of a breast center. I believe that Ms. Michalopoulou, that the benefit for the patients will be tremendous. Let's hope that this initiative will move forward. We will discuss it at the end. Now, I would like to give the floor to our second speaker, who is Mr. Anastasios Boutis. He is a medical oncologist at Hellenic Hospital. Hello, welcome in Athens. He's going to talk about the Integrated Care Breast Center and the benefits from a multidisciplinary collaboration.
Good morning. Thank you for the introduction, and I'd like to thank the Alma Zois Association for the invitation. Now, Mr. Flessers' presentation indeed covered most of the points I would like to touch upon. It's quite obvious to me, only on the basis of what he himself described, we can identify the benefits of treating breast cancer patients in specialized breast centers where they can enjoy the entire care of this journey, starting from prevention, diagnosis, treatment, and of course, in the cases of advanced disease, even palliative care when needed. Three are the main benefits of treating holistically such patients within a breast center. One has to do with the clinical benefit, what we actually gain in treating the disease. Secondly, we are talking about the absolute specialization of the staff. Mr. Flessers elaborated on that in detail. Note the multi-fragmentation in many different specialties and subspecialties. And the third one has to do with the impact on patients, how this is interpreted by patients themselves, who, well, obviously this is translated into higher degree of satisfaction in dealing with this journey, in this adventure. Now, speaking as an oncologist, there are respective concerns and efforts we are trying to implement for other entities such as lung cancer or gastrointestinal cancer or prostate cancer, etc. Of course, breast cancer is primary here, and the experience of treating breast cancer within one breast cancer center by a single multidisciplinary team has been shown already 15 years earlier. So when I was given the topic of this presentation, the first thing that crossed my mind was that I need not speak about that. We need to challenge people, to find an argument against the establishment of specialized breast cancer centers, or even identify any negative point in that, which is not there. Vis-a-vis the clinical benefit, well, we are all familiar with all these stories 20 years ago, scientific studies that either retrospectively or prospectively gathered data and meta-analysis in 2000 and onwards have shown that breast cancer patients who are dealt with holistically by a specialized multidisciplinary team demonstrate an overall survival benefit. We're not only talking about theoretical benefits, we're talking about specific figures. In the most important meta-analysis, the absolute benefit in survival reaches 18%, which is a much higher figure of better outcomes in the disease in cases patients are treated holistically. Now there are too many data. I don't think that there's any point in me categorizing them and referring to all these studies, but I'd like to share with you the results of such studies. When breast cancer patients are treated by a multidisciplinary team in specialized centers whereby breast surgeons have been specialized on treating breast cancer, oncologists, radiologists, and other practitioners have been specialized on breast cancer. What does this actually mean? We need to take into consideration that we're living in a country where the particularities in population as well as in the public health, the organization of the state are so many that many times it is not feasible to achieve results we see in other countries. At least we can keep the figures that Mr. Flesser shared with us in mind, which go to show what it means to be experienced in breast cancer surgery or breast cancer oncology. These are figures that at least show a specific level of experience that enables us to deal with such cases. Secondly, we have, of course, improvement of the quality of life of patients. It's clearly much better when such patients are treated in specialized centers. All questionnaires and measurements of the patient satisfaction are higher when patients are treated that way. And of course, we have indirect benefits for the health system because there are many less complications, fewer problems that will force patients to visit other specialized centers with whatever this means vis-a-vis the public health system. Regarding the second part that has to do with specialized staff, Mr. Flesser talked about it regarding specialized breast cancer centers or units. I want to insist on other typical things that we usually say regarding surgeons, oncologists, radiologists, etc. I'll mention simply what it means to be certified on breast cancer as a nurse. This, in fact, sounds a bit excessive for our country, an exaggeration, but it seems that abroad they've seen that it's much better to have certified breast care nurses. I'm talking about the part pertaining to diagnosis, biopsy, surgical treatments, as well as about the part that pertains to therapeutic options, chemotherapies, IV treatments, etc., or rehabilitation particularities of operated on women or centers for lymphedema or special care, etc. Well, in Greece, we have quite a good level vis-a-vis oncology nursing. There have been efforts to avail specialties there as well, whereby staff will undertake such roles and will be employed in such breast cancer centers. Something that Mr. Fless has also shared with us. On top, you can see what is assured in big hospitals. We have the basic medical specialties. There is a specialized nurse, imaging experts, etc. So the top part is there, more or less. The second part, the second category is something which is difficult to create. We are making efforts, but I'll share with you my public hospital experience to have access to fertility specialists or reproduction specialists or geneticists or plastic surgery specialists for breast cancer. Well, although we do have some possibilities, well, in practice, as a routine, patients will be forced to seek advice elsewhere for such type of services. So these involve the pathogenicities of the public health system, which we need to try to overcome. And at the lower part, we have other things such as departments for counseling, support, dietitians. This is a whole underrated in Greece, particularly in the public healthcare system. Now, these are the excuses and justifications. So these two have been touched upon. There is, well, we are laggards vis-à-vis public health. I'm not referring to the public element of health. I'm talking about population health, which involves both the private as well as the public sector. So the state actually started to deal with that now after the pandemic, because they only now grasped what public health is all about. We had a huge pandemic crisis. The public health system went through what it went through, but of course this had repercussions for the private health care system as well. Public health in Greece, particularly vis-à-vis cancer, presented many gaps. We heard about it by the Secretary General, the issue of registries, the issue of palliative care, the issue of prevention, etc. With the pandemic in the past 2 years, so these were brought to surface so emphatically, and we suddenly grasped the fact that as soon as the pandemic is over, we need to deal with that issue. There are also issues of public administration. There is also a part pertaining to the population itself. There is lack of medical culture and education and awareness. The Greek population is not trained enough to know how to claim its rights. So the fact that they are entitled to have access to people who are specializing on breast cancer, the fact that they have a right to have access to breast cancer surgeons, to breast cancer oncologists, not let the fact that they are living in remote islands or areas, etc., should not prohibit them from receiving such services. There are, of course, geographic location issues, etc., and, of course, a very thorny issue which we dislike as healthcare professionals is that there is an absolute lack of control and evaluation. For instance, patients go to a X doctor of a public or private sector without being referred to the required specialties. This leads to a point where patients treat themselves there, and this is not evaluated by anyone. It is not assessed by anyone, etc. And let me also include some proposed solutions in order to avoid being too pessimistic. And now, at least we now have a few reference centers. The state needs to enhance and strengthen them. There are both public as well as private such centers. Private centers should be acknowledged, recognized, and supported, and public ones need to be strengthened and staffed, at least vis-à-vis the main specialties and disciplines that are missing even in major hospitals in Athens and Thessaloniki, etc. We can tap into digital technology wherever there are gaps and lacks. Having had the experience of the pandemic, some of these gaps can be covered even temporarily. Simple examples: if there is no geneticist available, you can have an agreement to have a remote conference call with a geneticist once a week. We had proposed this for our own hospital. We need to have networks to guide women in their journey with cancer. This has already been mentioned. We have said that, particularly if you see it from the perspective of the public sector, it is not enough for us to focus only on prevention or on treatment or on palliative care. The state needs to focus equally on all these sectors, and we, respectively, healthcare professionals, patients associations, pharma industry, etc., need to lend a helping hand. And, of course, we need to increase awareness and inform people. This pertains to us all, both patients as well as doctors. Thank you. Thank you very much, Mr. Boutis. Excellent presentation. I think that you have introduced 2 or 3 points for discussion. I'd like to focus on 2 or 3 points. Well, you talked about breast cancer. Doing the accreditation for Zoma with requirements, the breast care nurse should be with the breast care unit. This is necessary, absolutely necessary. We need to have many breast care nurses. And secondly, I don't think that in 2022 we should have a breast cancer center or unit without it being able to offer plastic rehabilitation and immediate rehabilitation and recovery. I am not in favor of a mastectomy without any rehabilitation measures. Hospitals need to be able to offer that. Otherwise, patients need to move elsewhere. If we ask women, well, they have the right to get the optimum of services provided. So the issue of plastic surgery is really important. It has already been discussed with the ministry. I don't know where will this discussion end, but definitely, well, in the private sector things might be a little bit easier, but in the public sector there is lack of flexibility. We cannot have women undergo any type of mastectomy without any type of rehabilitation. This needs to be taken care of. It's really important, and I'm sure that Alma Zois will make sure it is discussed with the ministry. So thank you very much. Very interesting. Now we move on to the Greek experience, or the Greek reality, presented by a person who has both the experience as well as the knowledge. He has traveled through Greece. He has had a breast cancer center in Agios Savas Hospital. We're talking about Mr. Philopoulos, and he is experts in describing the situation in Greece. Mr. Philopoulos, good morning. Thank you very much for joining.
Mr. Philopoulos, please unmute your microphone because we cannot hear you. Thank you very much. I would like to thank the organizers of this conference. I would also like to thank the president. And I'm here to talk about a challenging issue because this is what I do. So I'm here to talk about the breast centers and units in Greece, what we have, what we don't have. I believe that some of the previous speakers have already brought forward what such a unit should include. Here you can see. Here you can see that when we talk about a breast center, we talk about a truly comprehensive and integrated care that expands across the entire stage of cancer. It doesn't really have to do with surgery and treatment. You can see that in order for those centers to be certified as comprehensive cancer centers, they have to undergo specific testing. We start from the bottom of the pyramid where we have the organ cancer centers. We move upwards, having the oncology centers, and then we have the comprehensive cancer center, which is the major aspect that focuses on both rare and regular cancer diseases. And those are the centers that generally guide the organization of that. Here you can see the preconditions. Well, like you mentioned before, it has to do with the USOMA. You see what are the specialties that should be included in such a center. Here you can see all the specialists who need to be specialized in breast cancer, all the requirements, the number they should have, the experience they should have, and how it should be maintained. All the requirements are described and set out properly. And here you can see that when we talk about integrative medicine in the United States, this is what is needed. And this type of medicine goes beyond the purely medical aspect. We also have the psycho-oncology, we have psychology, we have palliative care, genetics, prevention. You can see here the various protocols, the pathway of the patients, the MDT meetings, and so on and so forth. Those things play a decisive role, and if those things are available, then you can see all the medical specializations that should be included in a breast center. Gynecologists play a key role in Germany. Here in Greece, we mainly have breast surgeons. But in any case, we need a multidisciplinary approach. Here you see that all those people need to come together, collaborate in order to better address the cases. So in Greece, on the basis of our research, we came across those public breast units that are now available across the various hospitals all around Greece. The main characteristic of all those units, centers, call them what you like, is that they don't have specialized either oncologists or breast surgeons, meaning that they're not there, they're not on call. They actually exist just to run some tests. Okay, there is a referral physician, so the test, once issued, goes back to that referral physician in order for the patient to continue the treatment. 2 of those centers don't even have an ultrasound, so that they cannot perform this test. 13 out of them have. When it comes to the mammography, only 1 breast center cannot conduct mammography, so patients are referred to other departments, either inside the hospital if it is working, or outside the hospital. I don't want to mention the exact geographic regions I'm talking about because I don't want to be racist. Now, when it comes to the fine needle aspiration, well, this is not available in most of the breast centers. And even if it is available, waiting is very long, meaning having a one-stop center, having the patient coming in for both testing, FNA, etc. This is not common. I would like to remind you that we're talking about the public hospitals. Here we have the core needle biopsy, and the majority of this is not performed. Women are referred elsewhere to undergo this procedure. You can see here the number of patients per week. 0 means that we didn't have any data, and I was impressed by that. I was surprised that we were not able to come across any data. Anyway, I contacted the director, and I saw that at Hellenic they have 400 patients at the outpatient ward and 300 patients in the prevention ward. That's a very big, because we know Hellenic is a reference center for all northern Greece. So you can see that when we talk about quality problems, all those things should be available. That's why we need registries. What you do, when you do it, everything should be available to everyone. Everything should be accessed easily. We cannot capitalize on our personal acquaintances in order to find out specifically what happens in a nurse unit. So the conclusion for public hospitals is that most of them don't offer the service of an organized breast center. They are, breast practices. They offer imaging tests. A breast surgeon or someone else might refer women there, or a gynecologist might refer women there. Then the patients are referred back to their physician or the referral physician after the test. So you do realize that this is not very effective. Now, when it comes to the private sector, of course, things are better there. Here you can see all the breast centers that we contacted, both in Athens and the regions. I don't know why some things are marked in blue. I'm sorry, that's a problem of the Excel I created. A good thing is that if you look into the work undertaken by those centers, you will see that they don't have waiting time. They have oncologists, they offer mammography, ultrasound, they carry out all the needle biopsies. They can refer the patient within the same hospital and other structures. So you do realize that this private sector is better organized. Apart from the public cancer centers that are organized in general, I might have forgotten something, bear with me. I would like to continue and say that it's true that organized centers perform better. It's something that we see in all the studies that have been carried out. Here you can see that, apart from all the other factors, women that are referred to a breast center have better outcomes. If you consider liver, pancreas, esophagus, you do realize that they need to be referred to a specialized center. But apart from that, given that breast cancer is a very frequent type of cancer, we should have specially dedicated centers for breast. And I would like to say to my fellow surgeons that either we like it or not, our involvement is lower, meaning that now we have a broader range of actions and interventions. We have more complementary and supplementary treatments. And medical oncologists step in at this time, because we have some oncologists who have been specialized in breast or liver cancer. Maybe at some point medical oncologists will also need to specialize on a specific type of cancer and the provision of care there, because centers abroad have dedicated medical oncologists specialized in treating breast cancer. Here you can see the satisfaction rates of the providers regarding the breast cancer centers. We have 56% satisfaction. The same applies in the case of colorectal cancer centers. You do realize that specialization is of essence here. Now, again, in Germany, you can see the breast centers and how many of them have received certification for breast cancer management as per the guidelines. And I'd like to remind you that those guidelines are extremely strict. It's not just a routine check. They follow a very specific protocol. In Greece, we have the breast centers network. We also have some Greek departments participating there. Here you can see the requirements of membership. They need to have, okay, they're more lenient compared to the German Cancer Association guidelines that are more strict, and they are compulsory all around the German territory. Here you can see that things are more flexible here. However, the operation framework is still right. You can see here the members in Greece. We have Alexandra Public Hospital, the Athens Medical Center, Rhea Maternity Hospital that had not been included in our review. We have ESO, Metaxa Public Hospital. I don't know what has happened with Metropolitan and other centers. Anyway, this goes in line with what I mentioned before. Given that we have discussed extensively how we can better organize all these things with breast centers, I believe that now we live in our own parallel reality. We have the clinics abroad on the one hand and the situation in Greece here. I'm afraid that here in Greece we have a system that is subject to political fluctuations. And you do realize that this does not allow us to ensure the consistency of the system. We have favoritism, we have clientelism, and for example, when we have a reference breast center, normally they should have been in Agiosavas Hospital, which is a traditional cancer hospital. But instead of having this breast center in the cancer hospital, we had that created in another separate independent hospital. This is due to various acquaintances, interests, and lobbying. We don't have robust assessment and evaluation systems in place. We know that health financing is not consistent either, and of course we're missing evaluation. And why is that? Because you do realize that many distortions exist. If I am in favor of the current administration, the current government, then things will go better. No one will hold me accountable. In the public sector, in the private sector, there is competition that leads to some improvements. I'm afraid that normally the public sector should be held accountable more compared to the private sector, and I'm afraid that those evaluations are not in place, will never be established. Many interventions and lobbying will step in. We have physicians who do not have the same collaboration culture. It's everyone out there on their own. You do realize how difficult that is. We know that when we discuss breast cancer, collaboration is key. Like Tsarouki said, in Greece you are what you state. You say that you're an expert there, okay, no one will bother to check unless, okay, you do a very conspicuous error. But the same applies to medicine as well, I'm afraid. The same applies to the specialization in synology, because at some point, okay, we might not have a specialization that's called synology, because we might have the breast surgeons and gynecologists stepping in, but normally we should have that medical specialty, because if you build your career on breast and then you want to be able to pursue another position in the public healthcare system, no one will bother. No one will hire you in clinics that are specialized in colorectal and other cases. And I believe that the responsibility there lies in the hands of medical societies, because they are there to give the guidelines, to see what's happening abroad, to highlight the right ways to organize medicine in order not to have patients in the middle of this puzzle, not knowing where to go, not knowing what to ask. Because we want to ensure that this is remedied. It will be to the benefit of both the patients, the state, insurance companies, etc. So the reality in Greece here, okay, might be compared to examples abroad, but I'm afraid that when we talk about the practice in Greece, and Greece only, we as physicians are also to be held accountable. Because maybe we don't lobby enough for some things to happen. I don't know why is that. This might get us out of our own comfort zone. I don't know why. But I'm afraid we're not exactly a role model here in Greece. The electronic health record is over there. It's lagging behind. There's no such thing in Greece, and that's why we have patients coming to us with tons of paper tests. We don't have an organized provision of holistic, comprehensive care. And holistic care should also include simple ways to address side effects, empowerment of the patients. There's no such thing. We don't have supportive or palliative, call it what you like, care. You can see the huge geographic discrepancies. So you can see that we have breast centers, in Athens, Salonica, okay, in Patras or Crete, but we have extended geographic areas in Greece that are not covered. This also means that we also don't have the means to upgrade our equipment, etc. Things have improved, but still there are deficits there. And lastly, we also have the public healthcare sector that needs to be resilient. They already carry a huge burden. And if the existing breast units or breast centers also has to implement the screening program, this will not be a reality. This cannot be performed. The hospitals are understaffed, people are not satisfied with their job. Nothing will be effective. Okay, so I think I tried very briefly to describe things and call a spade a spade. I'm not very optimistic. I'm afraid that we won't be able to organize ourselves as we should because our state is challenged by distortions that prevent us from improving. Maybe technology will help, but my advice would be not to dream big. Start small, build main basic structures, and then you will grow and maybe be able to bring the practice from abroad in Greece. And we know that physicians, either practice in the public or the private sector, have helped many lives, have filled many gaps. We have good physicians. And some people call us saviors, okay? We have many saviors, we know that. We don't have only one savior, but the savior is not a single person, it's the team. The team saves lives, and maybe this is what saves the day. Because we should not forget the nurses and how they outperform themselves. And we know that when they are trained in a specialized breast center, they can obtain the necessary education. I will stop here. I hope that you have understood everything. If you have any questions, feel free to ask. Thank you. Thank you, Mr. Philopoulos. Will you stay with us, or can we ask you the question that we have for you? Well, actually, I have another obligation at 4. No, I was wondering whether you will stay with us for another 30 minutes. Yes, of course. Yes, why not? Of course. Okay, thank you so much. Okay, so if we have any questions for Mr. Philopoulos, so we will ask them later.
Terry Corrado, he is a breast surgeon. He is the head of department at the University of Humanitas, and he is going to speak about Breast Cancer Network, the Italian experience. Dr. Corrado.
Thank you to the discussant. I'm very happy to stay here, and it's a pleasure to know Alma Zois organization, especially Cristiana Mizzi, that it's a pleasure to know. the story of the program of breast centers in Italy started in 2010 when with the Health Commission of Senate and some specialists like me or Alberto Costa start a special survey in Italy on breast cancer. The aims of this survey was photographing the situation in Italy with verification, especially of the screening paths, analyze the social problem of breast cancer in the aspect of quality of care with the aim of the European recommendation of the breast unit constitution. But remember that at that time, in 2012, in Italy, only 12% of hospital admission for breast cancer involving in care that reach 150 cases of breast cancer. Remember this data. They proposed, the programmatic proposed that this survey defined was the socioeconomic impact of cancer, the prevention program adapted to age group, a specific health program for breast cancer, development of network of excellence in the area with the general practitioner, but at last but not least, the realization of certified breast centers in the health system in Italy. We all know that the odds of healing of a patient are proportional to the level of competence of the hospital from which are treated. There is a clear relationship between the overall survival and quality of care. All we know this famous slide of the European Commission, and you can see the difference in terms of survival in the European member state. In that time, the European Parliament launched a famous motion for action with special attention to women with breast cancer, with surveillance for high-risk women, familial and genetic women, young women dedicated screening, this is a really hot spot, attention to employment, financial and life plan patient, and the role of nutrition, lifestyle, genetics, and other, but especially establishment of multidisciplinary breast unit. My previous colleague cleared this famous study, Scottish study, that defined an evidence-based medicine that the introduction of multidisciplinary breast care changed the survival in women with breast cancer. There is no drugs that change the probability of survival like this kind of care. The roadmap of the law in Italy of breast cancer changed with approval, with the document of breast center in Healthcare Commission, and after with the approval of this document in Senate. In the same time, there was an official commitment of the European Commission for Health in setting up a work group for activation of breast unit in Europe. The 12th of July, there was a definitive approval of Ministry of Health and startup of realization of the General Directorate of Health Planning. This is the historical decree with the Ministry of Health establish a work group for identify the guideline for define the breast unit in Italy. The purpose of this work group was drafting a document of breast centers network in Italy and the technical annex for a state-region agreement. In Italy, the health system is defined region by region, but the Ministry of Health define a life plan for all the region, and this is the working group. The objective of this technical document was define a guideline for implementation of breast cancer network, address the system resources of the region and of the Minister of Economy and Finance, and the product of this working group constitute a general framework and address which comply for the health system, so it was very important. The implementing proposal for health governor were avoid the spread of few cases in many hospitals, reorganize the devolution of skills, offers health models to the region, and allocation the resources. The clinical aims of this document of the network were prevention activities and screening programs specific for breast cancer, integration with the diagnostic and clinical pathway of the subject with heredofamilial risk of breast and ovarian cancer. Remember that to date, the 8% of breast cancer are hereditary or genetical. Appropriateness of the diagnostic and clinical pathway and the best treatment based on the scientific evidence, but the real revolution was the communication and information to the patient and her participation in the program of prevention, treatment, and rehabilitation. My colleagues speaks clearly that it's strongly recommended to ensure multidisciplinarity to obtain the really good result. And so this is the core theme of the breast unit. The patient is at the middle of the debate. This is, I think, a change of the vision of the health system, not only for the breast. And you can see at a reorganization in a single integrated center with all the specialists that the patient needs. Definition of quantitative and qualitative requirements like EUSOMA. One of the most important requirements was the volume, the case volume of the breast unit, minimum 150 cases for any breast center, and also adopt guidelines for the diagnosis and treatment of breast cancer at all stages, and the psychophysical rehabilitation of the patient. This law was very appreciated for the Ministry of Health that in the 2014 we present this law in the semester of the presidency of the Council of the Italian and at the European Union. So it was a really better idea of the Council of the Ministry. And this is the definitive law of breast unit in Italy, and this is a historical change of view by the health political system in Italy. Breast center of a new model of health care, from diagnosis to therapy, from screening to advanced disease, with the clear multidisciplinarity for the specialist, with the EUSOMA requirement, and with an adequate health system reimbursement for the breast unit, and dedicated equipe. It's also, I think, a best of training model because there are a definition of new health roles with opportunity of career, like nursing, like psycho-oncologist or other. Home of training and clinical pathway, partnership with the university and graduate school, and develop translational research that is very important for breast cancer. There are clearly advantages like a centralization of pathways, rationalization of cost of health system, standardization of therapies, reduction of the social cost. Remember that the 7% of the cost of breast cancer are for the patient and the family. Improvement of outcome through evaluation of specific indicator and improvement of survival. This is today the distribution of breast unit in Italy that it's really, they treat the 95% of the breast cancer in Italy. So it's really important. Remember the 12% of the 2010. But unfortunately, there isn't the same distribution of this center in all the region. The political now are a clear idea about the necessity of multidisciplinarity, like team advantages. And this is the position of Ministry of Health, so a welfare model of the breast unit network, but this model is not only today for the breast cancer, but probably for all the cancer. with the path of diagnosis and treatment, multidisciplinary value, but it's important a case volume for this center. In Italy, one of the most important definition of reimbursement for the health system is LIA. LIA is essential level of assistance, and today in Italy the breast center network represents a LIA, and the region are obliged to implement them under penalty of a reduction in terms of economic reimbursement by the government and the Ministry of Economy and Finance. And this is the questionnaire, the LIA questionnaire, that all the regions are obliged to define penalty, the reimbursement by the Ministry of Health. This kind of questionnaires regard the volume of cases that any breast unit in the region define, and it's obligated the region to define. I conclude my presentation with this take-home message that I think it's very, very important. Remember that the breast unit represents an average reduction of 80%, and today in Italy still dead 12,000 of women. So think how many lives we can save. Thank you.
Thank you very much, Professor Corrado. I hope we'll have the opportunity to discuss some questions later on. Thank you very much indeed for your presentation.
I would like now to give the floor to Ms. Michalopoulou, the President of Alma Zois Association, in order to share her comments and updates regarding the breast centers. We're looking forward to listening to her because I believe that she is a pioneer, at least at this moment when this discussion is ongoing, and we hope that we will be able to have tangible breast centers in Greece. Thank you, Mr. Venizelos, for your kind words. We are all interested in breast cancer, and this is why we're here today. We have heard wonderful things. Of course, we listened to the rules regarding the operation of breast centers. Mr. Philopoulos shared with us the reality regarding breast centers. Mr. Tinteri showed another mindset that they have in Italy. I would like to say a few things about what happens in Greece and share the perspective of the female patient. When a woman, either through a routine check or a regular check, comes across a suspicious finding, what is she going to do? She's going to pick up the phone and call any friend she might know that might had this disease in the past, or another patient, and she will start asking question. What was your physician? Where should I go? Is he good? Where is he? So she visits the doctor. If she's not satisfied, she will start a new round of telephone calls in order to find another physician to consult. That's the situation here in Greece. Breast center. Well, have you ever heard of a woman saying that I will go to this breast center? Personally, I haven't heard of anyone. So once the woman comes across the physician, she will go where the physician is. And then what starts? A struggle. We're all very familiar with that. The diagnosis will take place in one place. The surgery will take place elsewhere. The chemotherapy will take place elsewhere. Radiation therapy, of course, will take place elsewhere. So not full up to 6 weeks. Most possibly, the time lapse between diagnosis and the first treatment is more than that. So you all know that although how well you mentioned how important it is to have this breast center, what their role is, how their role increases survival, I'm afraid that reality is very far away. And although we are in the era of personalized medicine, I cannot help but wonder, does personalized medicine have to do with medicines alone? When we talk about medicine, we talk about all the needs of a woman comprehensively. So what we need is to have a breast center, and that's the foundation, the cornerstone for high quality, effective and comprehensive breast cancer care. We keep talking about reference centers. Does this model refer to a reference center? No. And needless to say how important it is to have a breast center. This has been highlighted by your presentations. You can see that in the eyes of women, going from doctor to doctor, from center to center. I cannot stress enough how important it is to organize ourselves and translate all those theoretical discussions in practice. We need to take a step further. It is true that the alternate Minister for Health, when we visited her, today, of course, she had a prior obligation, so she couldn't join us today. So when we went there, we forwarded our proposals on those topics, but we have not heard back from her. So, Mr. Venizelos, I hope that this discussion will not stay here, okay? We're here, we discussed, and the end. No. I would like to talk about your proposal, the proposal that we have submitted to the alternate minister, and I hope that a committee will be established, including all the stakeholders of breast cancer centers. We need to establish such a committee that will help us take this issue a step further. Discussing it in theory in conference is not enough. Okay, it's important to raise awareness, but it's equally important to agree that we will translate those discussions into a tangible proposal, a proposal that will be consistently forwarded and promoted. Thank you. Thank you very much, Ms. Michalopoulou. I would just like to give you an update and say that a meeting has been arranged, next meeting, with Mr. Kotsiopoulos. And we will be discussing breast centers and some other topics. For example, the services that AOP can buy from the private sector. So you do realize that there are some things happening. I will send you an update after our meeting on Tuesday. So let's organize it, let's keep it moving, let's promote and bring this issue further forward. Now, I would like now to ask the representative of ELOC, Ms. Deliopoulou, to share a few comments about today's discussion on breast centers. Hello, everyone. First of all, I would like to congratulate Alma Zois for organizing this first breast cancer patients conference in Greece. I know that this is a very concrete first step in order to reclaim, step by step, some of the things we're missing. It is true that we're missing a lot. Let me start by saying a few things about what our first speaker said, but I would like to congratulate all the speakers. They have been exceptional. The speakers of the first session, the speakers of the second session, congratulations to all. Now, Mr. Flessas talked about the requirements that a comprehensive breast care center should meet, and I would like to focus on the team. We're so much used to the mask that does not longer bother us. So the team, either in public or private hospitals or breast centers, should include all the main medical specialties. We know that there are more specialties that should be included in such centers. And further, to our discussions and communication with patients and hospitals, we see that Now there is a need like the one brought forward by Mr. Venizelos. Now we talk about a cancer that leaves room for breast reconstruction. So it's very important to have a plastic surgeon consulted prior to the surgery. We also have the medical oncology specialty. Specialty oncology nursing is equally important and should be included. We have the Hellenic and Association hospitals. We know that nurses have a huge and extensive experience, and it is highly helpful for the patient to be treated by specialist nurses, not only in the case of treatment, but also in the case of the routine tasks that should be performed. We also have new specialties, geneticists, consultants regarding fertility preservation. Those are things that cannot happen here at one place. So maybe I could propose to have the online communication option offered to those patients, because we talk about needs that should be addressed. Then Mr. Boutes talked about the benefits of the multidisciplinary collaboration. Okay, we know that they are numerous, and all the speakers talked about the survival and increased survival by 18% of those patients, thanks to breast centers. We know that this is very important. Like we already said, we see the direct impact on patient satisfaction where those breast centers exist and operate. Another thing that I heard, and I was very happy to hear that from our physicians, is that the assessment and the evaluation of healthcare services should be in place on a regular basis. We have public hospitals, and Mr. Philopoulos said very accurately that political lobbying is always present there, but this does not mean that we should let the evaluation subject aside. I would like to give you an example from another medical specialty. I believe that it's very important to train surgeons, and I'm talking about surgeons operating in the regions. It is very important to have surgical training centers, and this training should be delivered within the context of the cancer hospitals. Okay, Mr. Philopoulos talked about Hellenic Hospital. I know that Hellenic treats many patients, and this is a reference center for all northern Greece. We cannot have a patient undergoing surgery and then going to Hellenic, or even for the pre-operative adjuvant chemotherapy that they need to undergo, and that not being to the benefit of the patient or being prioritized over other patients. I believe that we can do some things towards this direction. When it comes to the reinforcement and support of the private centers, yes, of course we should do that, and we want them to be role models, and we want them to inspire healthy competition towards vis-à-vis the public hospitals. We know that staffing and specialization and nurses and administrative staff should be strengthened in the public hospitals. When it comes to the staff training, and I'm talking about the medical staff, I would also like to talk about geriatrics. We know that cancer sometimes develops in the elderly, And of course, we cannot address or treat a 40 or 50-year-old woman with an 80-year-old woman. So we need to make some adjustments and take the right steps in that case. We talked about cosmetic surgery and plastic surgery. This is very important for women. I would also like to share the example of pain relief practices, pain relief centers. It's true that palliative care has improved through the pain relief centers. On the basis of the feasibility study, we know that the creation of so many teams, so many beds in hospitals entails a huge cost. But we, as patients, know that many other fellow patients were no longer in pain. And this is very important. And at this point, I would like to say that patients do not receive information about the pain relief centers or the other palliative structures. For example, in a survey carried out by a LOC in 2019, we had the involvement of 16 patients. 42% of patients were informed from family or friends about the fact that there are some pain relief practices. Another 40% was informed by the internet, and only 16% of them was informed by the healthcare professionals. So there are some things that should not just be heard in the context of a conference. We need to join forces, take small steps, baby steps, to make a difference. Thank you very much.
I'd like to add something that I forgot about, and fortunately Mr. Leopoulou mentioned it already. In these breast centers, there's a paragraph that no one mentioned. Such breast centers should be connected and inform women on the existence of patients' associations. There has to be a link between the breast center and the association. Now, let me point out that Alma Zois provides such services for many years, and I'd like to thank the centers where in Athens offer such services with 3 hospitals in Athens and 2 in Thessaloniki and Patras. Well, it is important. It's not us just saying it. There are studies demonstrating the benefit of women coming in contact with their peers. You all want us to speak in such events, etc. But when women come to see you, you don't refer them to the patients' associations, although you know that patients' associations are really helpful in their empowerment. So, well, people often say, well, we forget to tell her about it. Well, she suffers from a shock, and this will help her get over the shock if she comes in contact with women who have already been there, done that. So I'd like to see what we often say in conferences become a reality, become true. We need to offer them help by linking them to the patients' associations. Yeah, I think that you're absolutely right. We doctors need to inform them on the existence of Alma Zois and the assistance that you provide yourselves. Personally, I've seen this thanks to your volunteers who are a great help and support to such patients. Any questions pertaining to breast cancer centers? Ms. Mitzi. Well, we warmly thank you for these excellent presentations. My question goes to Mr. Tintori. I'll be speaking in English.
ask you about, you presented a very clear way and very clear overview of the way you managed to create a network of breast clinics in Italy. And I would like to ask you, since you've heard about what happens here in Greece, what's the problems, what's the issues that we usually face, I would like to ask you what obstacles and problems and issues you had to face during the process and how you managed to overcome those obstacles. And I'm asking that in order to give us an idea and some ways for us to help us to overcome our own issues here locally, as long as we can have an analogy, but anyway, as far as we can do it. Thank you.
But in our experience, I think it's very important the help of the politician, because in Italy, we must change the administration, the bureaucracy, and it's important to define a pathway for the patient and convince the specialists that it's better work together, not one hospital and one hospital. And this is a change, it's a revolution of mind. And I think that start from the administration of the health. Because I think that the change of reimbursement in Italy has really changed completely the pathway. So I think that the Women Association and the convincement by the politician was the key. And after, it's very important that our specialists think that it's really important working together for a better result.
Are they private or are they in the public sector? Your breast cancer units, the ones that you created so successfully?
Yes, there is no today in Italy only a private health. Because if you want to treat breast cancer with the health system, you need to accreditation with the health system. So all this breast unit, someone is private, but they have accreditation with the public system. So only in this case you have the reimbursement from the health system, yes.
Pay, or they're not self-paid?
Yes, if the patient can pay. But in all this breast unit, we control the time for surgery, the time for start the neoadjuvant therapy with the public system. So we have the indicator of starting therapy, of waiting list. Maybe we control the waiting list. If some women want a private pathway, she can. But the health system guarantee today this waiting time in this breast center.
Thank you.
Can I ask you, can you clarify a bit more the use of LIA?
Yes.
LIA.
LIA, it's a special organization by the health system and represent some aspect of the health system that is very, very important and any region can treat. So when a pathology or any intervention is a LEA, it's important and any region are obliged to represent to the patient and have a special reimbursement for the region.
Thank you. Anne,
First of all, I'd like to congratulate Alma Zois for this very interesting meeting today. Now, I have two practical questions. Since you're all younger, when was in Greece the first organized breast cancer unit that involved whatever our friend from Italy mentioned? When was the second one established? And thirdly, how was Alma Zois created? At first, its name was not Alma Zois, it was Zysopos Prota, live as before. Just to get some history points. Can you answer, please? So, in 1980, under the Public Social Security Fund, so the Public Social Security Fund abolished it, and this was illegal, and Greece was condemned by the European Court. The second one was established in Lito Hospital in 1986, and Alma Zois was established in 1980 after the visit to Greece following my invitation of Madame Timothy from France, who had the Association of Vivre comme Enfant, and she had come here with Dora Papadopoulou, and she established our association, and then we changed the name. That's for history. Thank you, Ms. Mozaka, for this piece of information. Some of you might not know it. Alma Zois was established in 1988, and the first seat was Mozaka, Metaxa, excuse me, Center. Now, to conclude with this discussion, an important issue has to do with the reimbursement. So currently, let us not separate the private from the public sector. I think that there is a will, and that we will all agree that all patients should address themselves to organized centers meeting specific requirements and conditions. So this is the position and the obligation and the duty of the ministry, be them excellence centers or other types of centers. These will be the breast cancer centers. Let us not be scared. We need to take some steps forward. Which are these centers in Greece meeting such requirements? Not even 20% of them. Mr. Philopoulos talked about that. So such centers should be excellence centers, centers of excellence. They need to be able to provide services to patients, and the state has the obligation to do two things. One is to improve the rest of the centers so that they all reach the same level, take into account the difficulties of the country areas, etc. And secondly, it needs to be able to buy health services from private centers if they are excellent centers. Patients should not be paying for that. Well, I'm a director of a private hospital, with a private hospital rather, but I have to tell you that despite that, patients who have a long waiting list need to be able to visit such centers without them having to pay anything for that. I think that this is something that the ministry gradually starts considering. This reimbursement that everyone talks about regarding patients should be covered by the national health system and not out of pockets of the patients, in order for all patients, be them in the private or public sector, have access to excellence centers. They could be 150, 200, or even 10 in Greece. As many as they could be. We need to take things gradually. We don't need to take leaps ahead, but let's start from some point. Mr. Philopoulos, I don't know if you're with us.
Yes, of course, I can hear you. Do you have any comments to make about today's discussion? Well, I believe that all the comments have been to the point. I would just like to clarify this. The entry for Thegenio was 0 on the slide, but I said that was a mistake because they address 700 cases per year, and of course they need to be congratulated. I also agree with you that we should go step by step. We have had enough discussing ambitious cancer registries that were never implemented. And I remember at the Greek Parliament I had said that, okay, if you call me again, let's make sure that the next bill of law will be actually implemented, not just discussed in theory. So we know that this should be in place, should be timely, should be properly structured, but we should not have any prejudice and bias towards the patients when they resort to private hospitals and not come to the public hospitals, because we know that over the past years, private hospitals have made substantial investments in staff and equipment, and patients can't be helped. What I would like to say that in general, all patient associations are rather cautious because everyone has seen a lot being discussed but never implemented. And we know that not all patient associations are the same, but all of them are doing a wonderful job. There's some that all fellow physicians can confirm. So we need to ensure that there is a trend, and mark my word, soon we will have numerous associations and societies that can be funded by European funds that will start being more active. If we don't have organized breast cancer centers, then we won't be able to adequately address the most frequent malignancy among women. Thank you very much, Mr. Philopoulos. The comment from the audience is off the microphone. The comment is still off the microphone. We cannot hear her. Now we can hear the lady. Well, I think that we need to focus on the combination of what Mr. Venizelos said, both the private and the public sector, and mostly in the public sector, but breast centers do not only comprise upgraded machinery. It is equally important to ensure that those centers are staffed sufficiently and adequately by specialists. It's what our friend from Italy said. If there is reimbursement and right, fair payment, some that can attract people from abroad, because we know that we have very well-trained breast surgeons, oncologists, etc. We do have the human resources. So maybe we can re-attract those people from abroad in order to stop this brain drain, in order to staff those breast centers, because breast centers are more than just machines. Breast centers are all about collaboration among all those specialists. It is on this rationale of reimbursement, and if the reimbursement is based and relies only on those requirements, we're talking about high-quality EUSOMA requirements. Mr. Venizelos and we have also tried to receive accreditation, but we see that the standards are extremely high. So if a similar thing like Italy happens here in Greece, I believe that we can do that. We will get there. Yes, last question from you. The microphone is off, I'm afraid. We cannot hear the lady. So, I am experiencing breast cancer, and I had recently experienced lung cancer with my husband. I have experience from the cancer hospitals. Breast cancer, for me, is addressed by 3 hospitals. A private physician made the recommendation to undergo testing. A public hospital diagnosed the case. Another public hospital is where I underwent surgery, and a third public hospital is where I received radiation therapy. I would like to say that I was lucky because we had very good waiting times at all stages of my treatment. And I can say that public hospital physicians are wronged by the organization of the hospitals, really. At first, I didn't know anything about the disease. I didn't know where to resort. So I searched online, trying to see what every hospital offers and how up-to-date their equipment was. Either we talk about private or public hospitals. I can tell you that I work in the public sector, and many other colleagues working in the public sector. I work in a laboratory. We trust the public sector. I don't know, is it because they are not getting paid enough? They have huge numbers of patients, something that offers experience to the physicians. There is some trust to the public system. And of course, the fact that you start a treatment for a disease that you don't know how long it will last, you don't know what the cost will be, and you don't know whether you will be able to afford it and whether you will be able to leave the private sector behind to resort to the public sector. Everything leads to the public hospital. So we need to reinforce and strengthen public hospitals. So during my search online, I tried to see what they were offering them. When a patient visits a hospital, should be given a brochure, a leaflet, something that would be enough for the patient to know what the hospital offers. All hospitals I have visited were able to provide a nutritionist, a psychologist, and in some hospitals, the nutritionist, the dietitian, would make visits in the wards in order to give instructions to the patients, something that is free of charge, but is extremely helpful to the patient. And let me say a few things about Alma Zois. They're doing a great job. They let you know that there are other patients who survived, so you feel better, you feel like they're very close to you. And the patient's experience is very important, and we know that patients should be involved in decision-making. And the same applies in the case of alternative treatments, things that I needed in the case of my husband, and they were also helpful. I underwent puncture because it was very, very useful for me. It was the only means of relief. Yoga, alternative therapies that can help patients. And this is something that can be done by the associations. Thank you so much. Congratulations again. Excellent. Thank you very much. What you said is exactly what we have been saying for the past 2 years. You said that my biopsy was taken and tested in this place, my surgery was performed in another place, and so on and so forth. This is not what an organized breast center is. We want to ensure, regardless of whether it is public or private, we want to ensure that we have breast centers. You will go there, you will do everything you need to do, and then the center, if they're not able to perform chemotherapy because they don't have the right machines, the right equipment, to refer you at the right time to the right hospital. It's not up to you to search where you will undergo surgery, where you will undergo chemo, where you will undergo radiation therapy. It is the state's obligation to provide you this information at the highest level possible, and this is something that can happen in both sectors, private and public. The breast center is the one-stop shop. You will go there and you will be directed and guided. Thank you so much. I think that we don't have any other questions. Thank you again. This has been a very interesting session. Let's hope that next year we will be able to share more regarding the development of this effort about breast centers establishment. Thank you very much.
Thank you.
Καλησπέρα σας.
Good afternoon. My name is Manolis Alloustros, Assistant Professor of Oncology at the Department of Medicine of the University of Thessaly, and I'd like to congratulate and thank the board for the invitation and the choice of this very interesting topic that has to do with high-risk women, high risk for breast cancer. Now, the agenda has been formulated, and it's quite interesting. We're going to classify them. We'll see how we can assess their risk of their disease and how we treat this information. Now, starting at, I can tell you that I have great expectations from this session because of the participation of Mr. Papaioannou, but not only him. I'm sure that all speakers are going to share with us their excellent experience, vast experience on this. Now, we'll start with those women who are on a high risk. Ms. Fostira, who is a geneticist with the Democritus Institute with a vast experience in his genetic analysis, is going to share with us her knowledge. Ms. Fostira, you have the floor.
Καλησπέρα και από μένα.
Good afternoon from me as well. I hope you can all hear me. Now, yeah. So within the next 15 minutes, I'll try very simple words to explain a few things about the way we classify high-risk women and in what way we can trace them through gene tests, genetic tests. Of course, breast cancer is an important global problem. A high number of women are diagnosed annually with breast cancer. 1 out of 8 women will have cancer. Breast cancer, that is. So we're going to talk about hereditary breast cancer. Although it is a general belief, I'll tell you that hereditary cancer is the minority. So only 10% of all women who are going to be diagnosed at some point in life will have some hereditary predisposition. I suppose most of you must have heard of BRC BRCA1, BRCA2 genes, and through technologies from sequencing and all the innovative applications we have in labs, we have been able to diagnose a series of other genes. Of course, we are talking always about the minority of genes as compared to BRCA1, BRCA2. Everything changed from what it seems ever since we had this famous woman, Angelina Jolie, who said, you know what, I've had an RR mastectomy and I'm thinking of having an ovariectomy because there's something with my DNA. But let me tell you that this whole story starts many years before that. Of course, the woman who started out this is not a Hollywood actress. This all starts with a mathematician, Mary Claire King, who had initially developed a mathematical model to see what happens with women who have a series of genes in an era where we weren't familiar with genetic predisposition. This is the woman in the picture you see. Even a decade before the discovery of BRCA1 and BRCA2, she had predicted that the lifelong risk added by these genes on the basis of her mathematical model. But let's see why because I know that this announcement by Angelina Jolie was a shock to the public opinion. It wasn't broadly known that women could have a risk-reducing mastectomy, and this was a shock to the world. Let me put this in the correct framework. This is the family tree of Angelina Jolie, whom we can see here in the family trees. Women are in squares, represented in squares. Men are represented in circles. Her mother suffered from ovarian cancer. She died at the age of 56. Her aunt had breast cancer, and her grandmother had also ovarian cancer and lost her life to it. So Angelina Jolie, despite the fact that she's really famous, she didn't have a random family. She had a family with a heavy family history. So the reason why she underwent a genes test and ended up making a decision to have risk-reducing mastectomy was this one. So why we would ideally want to be able to identify all women who present these changes in their DNA? Let me tell you that all people have BRCA1 and 2 genes in our DNA. The predisposing factor is the genetic mutation. That is the fact that the gene is spoiled somewhere in one of its letters, and this doesn't function quite well. This is predisposition for you. So first and foremost, we've said that we all run the risk of suffering from breast cancer at some point in life, whether we have a BRCA or not. But what changes with these type of women is the lifelong risk of cancer. So from 12%, this risk might reach even 70% in the lifetime of a woman. In parallel, there is an independent risk of her being diagnosed with ovarian cancer, not metastatic one, because this is something wrong. And we're talking about a second primary cancer. In the general population, the risk is 1% for ovarian cancer. For BRCA1 women, there is 44% risk. So as you can understand, we need to know which women have run this important risk of suffering from breast cancer and ovarian cancer. Now, can we practically say, as I speak, that all girls born will be examined for BRCA1, BRCA2? Yeah, okay, we can do that, but the issue is the cost, the high cost. Despite the fact that the cost has been reduced throughout the years, we don't have organized structures allowing us to do this, because we need to have specialized teams of people who will be able to manage these results for these people with these results, and we need to have readers of genetic data, as these are output from a computer, and being able to interpret them. So let's go to the start of things. Back in the early 90s, research and not diagnosis back then was done in families with many cases, 4, 5, or 6 cases of breast cancer within such families. So through these heavy history families, we were able to identify such genes. Moving on, we found the way to analyze them and diagnose them in labs. So as of 2000, 2005, slowly and gradually, we started providing services and running these tests diagnostically only in families with a severe family history. As of 2010, this has entered clinical practice using specific criteria to check women who meet these criteria for genetic testing, and within the next 5 or 10 years, all women, I think, in the general population at some point in their 30s or 25 years of age will be able to run such genetic tests, regardless of their family history. As I said, 90%, we're talking about 90 of sporadic cases. 10% account for the inherited. This can be traced in a smart way. We know women with hereditary cancers are usually diagnosed with breast cancer quite young, under the age of 45, usually. And I focus on usually, and the term usually, because there is no absolute figure in life, in medicine, in science. So we're based on figures. Obviously, there could be women with BRCA1 who will never manifest breast cancer, but usually such women are diagnosed early enough, and they have an important family history, either women with breast cancer or ovarian cancer or prostate cancer men. I will add to that something additional, the type of the mass, the histopathology, which shows us the type of cancer. This directs us as to whether a gene is hidden behind all this. So high-grade carcinomas usually are associated with genes rather than the in situ cancers or grade 1. There are several guidelines. I won't enter into details. Breast surgeons, oncologists, radiologists, geneticists are aware of that and are familiar with that. There are specific criteria, and if these are met, well, we can have a diagnosis. The tests that we run do not pertain only to BRCA1 and BRCA2, but we use the genes panel, which has to do with an array of genes. Could be 40, 20, or 100, depending on the laboratory. Now, why do we have to run a genetic testing? There are several axes to this part. Even if a woman has been diagnosed with breast cancer, it's important for us to know whether there is hereditary element in it, but initially for herself, because we need to know how we need to follow up this patient. If I have a mutated BRCA1 and have breast cancer, this doesn't stop there, because I have high risk of ovarian cancer or a second breast cancer. So I need to have this information either to follow up the patient or to opt for certain risk-reducing operations. Something that has been greatly developed in the past few months, and I hope that you'll hear about it, is the therapeutic approach. So how hereditary cancer women, even at an early stage, can have a maintenance treatment, getting a pill to reduce the risk of recurrences, relapses, or even new cancers. And something that we tend to forget is that we're talking about genetics, predisposition. We are talking about family-run elements. So when we identify a genetic change in a woman, this is useful for all her blood relatives, both women and men. So how can we follow this procedure? The first part has to do with the selection of patients on the basis of international criteria, family history, diagnosis, histopathology, etc. There is consultation before the screening. Patients need to know why we run this test. Well, of course, we need their written consent. There should be a family tree for 3 generations following interview and a collection of histology reports, both from this individual and relatives. The fact that there is no national registry renders difficult the part that has to do with the relatives. There's the analysis with the genes panel, then consultancy post-control, and then ideally, we would like to see for people with mutations to see their relatives as well. Now, the technologies that we currently use in labs in the past 5 to 6 years are quite advanced and allow us to be able to read many genes in many patients. And this has led to the reduction of cost. The cost is significant, but it's much lower, almost half of what it used to be 5 years ago. We're talking about a complicated and complex procedure, intercourse for another specialty, which has to do with bioinformatics. We're talking about IT experts, scientists, who are able to interpret these data output from the computer, and they can translate them into genetic data. Now, depending on the laboratory, one may even read 20, 30, 50, or 400 genes. These do not always pertain to breast cancer, but usually these panels are designed for the overall hereditary predisposition for cancer. And we're talking about different types of malignancies here. Now, how many are the breast cancer genes? As I said earlier, we're not only talking about BRCA1 and 2. There are two important studies. This is a graphic presentation of one of them. Oh, I have 2 minutes left. Oh, okay. So we've found that there are at least 12 genes associated with breast cancer predisposition. What I want you to know out of this complicated and intricate transparency is that all these mutations of such genes do not always lead to breast cancer. BRCA1, BRCA2 quite strong, but there are others, P10 or CHEK2, etc. They are important, but not equally as important. So it is important for us to understand not only whether there are hereditary factors, but to see whether these are important enough. We're talking about penetrability, rather, of genes. And I will conclude, and I hope I'll be on time, with two real case examples, real cases. So, a lady, 38 years old, she's followed up, etc. She's healthy, asymptomatic, etc. Her mother had been diagnosed with breast cancer at 40, and she has a stepsister of the mother who has been diagnosed with breast cancer at 55, at the age of 55. So she wanted to run the genes, sequencing the genes test. The question is, what do we want to ask and what can we answer? If we give her a gene sequencing, can we actually give her an answer as to whether there is a hereditary element? Probably not. We need to identify the most appropriate person, the one who has already been diagnosed with breast cancer. The mother of the child, and by examining her, we can help the entire family. If we act selfish and we only examine this lady, we only get information on herself and her children, not for her brothers and sisters, etc. I'll skip that. Because I want to touch upon two issues that are quite important. So, as I said earlier, in my view, an important part of the genes testing is the targeted testing of relatives. So, if we have identified a mutation, we can have the screening for pre-symptomatic individuals. Amongst first-degree relatives, the probability of having the same genetic mutation is 50%. So through our work and the cooperation with Alma Zois since 2010, we were able to check more than 600 women on hereditary factors for breast cancer, and through them we've been able to have targeted testing of 97 relatives thereof from 34 different families for a series of genes. These are clinically significant results, so you can understand how important it is to come from a family with severe history and know that you won't be the next to follow. So I would conclude with that. I want to get rid of the urban myths. These are things I keep on hearing, but they're false. Dads cannot transfer breast cancer genes. No, this is wrong. We get genes both from our dads and our mothers. The risk of men suffering from breast cancer due to the genes is much lower. So they have the genes, but these are not expressed. My cancer is hormone dependent, therefore it's not genetic, it's not based on genes. No, it has to do with the treatment. Hormone dependent is not something that has to do with our hormones, but rather the treatment. I'm 40, and my mother was 40 when she was diagnosed, so I expect that I'll have the condition at 40. You might have not inherited the gene. If I have the gene, I need to undergo mastectomy. It's an option. It is not a one-way street. Whether you're going to have a risk-reducing mastectomy is a discussion, as a debate you have to do with the experts and see whether this fits you personally. So that's all from me. Thank you very much.
Thank you very much, Ms. Fostira. In order to better manage our time, I will collect all your questions and then ask them at the end of all the presentations. And now, once we have grouped some women under the high-risk category, how we can better manage these high-risk women, Mr. Lanitis Sophocles is a specialized breast surgeon with long-standing experience. He's very well trained, so we're looking forward to listening to him. Mr. Lanitis, like we said, you're addressing the general public, so please keep it as simple as possible. I would like to thank you all. I would like to thank Alma Zois for this honorary invitation. It's with great pleasure and joy that I am participating in this hybrid event. I am sure that this will be highly successful, and let's hope that this will become an established event. Over the next 15 minutes, I will try to share the surgeon's perspective about high-risk women. So, over the past 50 years, we have seen huge progress in the methods for diagnosis and management of breast cancer. Now we can better understand the disease, and awareness has been raised significantly in terms of screening and prevention. We have grown better. We have become better oncologists, better surgeons, better physicians. And now some things such as prophylactic mastectomy have obtained the position they deserve. This means that prognosis is better for our patients, and we're now able to offer better quality of life. Understanding the disease has led to better understanding of the risk factors. And we have the risk factors that we can control and the ones that we cannot control. And of course, in the second category, we have gene mutations, family history, etc. So when a patient comes to us, a woman who is not a patient yet, our perspective should be the following. You need to assess the risk, and we need to classify those women as high, moderate, or low-risk people. We have various models, numerical, mathematical models that we can use in order to show us which is the risk for a woman to develop breast cancer. As you can see, we're now very good at predicting some factors. Once this first step has taken, we need to establish the monitoring plan. Will this plan be the same with the general population? Should we start earlier? Should we run different checks and tests instead of mammography, maybe an MRI mammography or anything else? That's an important decision. But for surgeons, the most important decision that cannot be made by a surgeon alone is the determination of the surgical maneuvers to reduce risk. You have seen the slide. You know what sporadic cancer means. It means cancer developed in patients with no family history. We have a 15 to 20% of patients who have family history, mean that they run twice or up to 4 times higher risk. And we also have the 5 to 10% people who have a hereditary form of cancer and who have mutations in those genes. I believe that you have seen that up to 50 years of age, patients with BRCA1 have up to 65% to develop cancer. At the same time, we're now better in finding more genes, and by identifying those genes, we know which are the ones that create high predisposition to develop breast cancer. So right now, we are able to identify high-risk women and to give them some numbers so that they can make their decision. The algorithm that we follow is this. First of all, we properly assess risk. We cannot have a woman with a small DCS saying, okay, you're running a huge risk of developing breast cancer. No, we need to be confident and absolutely certain of the numbers we present to her. Then we stratify these women, and then we try to see which are the genes that are involved. If there are genes involved, we need also to co-estimate other and co-consider other factors. For example, some biopsies that might have shown an atypical hyperplasias of the lobes, of the ducts, and we also need to correlate the history of those patients. Once we have done that, we will be able to assess, stratify our patients per risk, and of course determine the monitoring plan. This is very important because not all women want to undergo prophylactic mastectomy. Not all of them should undergo prophylactic mastectomy. For patients who fall under the high-risk category, yes, very high-risk category, yes, we need to propose something and share data. We know that the general framework that does normally have to do with this presentation alone, we need to modify the lifestyle. Of course, later we're going to listen to the prophylactic hormone therapy and my part. When are we going to propose a surgery and which are the surgeries that we can propose? Always in order to offer life expectancy of more than 10 years, because if this is not the case, then there's no point in doing that. What's the most well-known, the most famous risk-reducing mastectomy? It's prophylactic mastectomy. You have heard why is that, why it has become so famous, why it has been promoted so much. So we know that prophylactic mastectomy, and allow me to use this term, although it should be called risk-reducing mastectomy, reduces the risk for breast cancer more than 90%. But we still have 1 out of 300 women who will develop breast cancer in spite of having undergone the surgery, and they should know that. Does it improve survival? Well, we don't know. We don't have enough data. We only have data for BRCA1 and 2. We do know some things about those genes. Well, yes, we have improved. We as surgeons, we have started back in 1984 with radical mastectomy, modified radical mastectomy in 1948, thanks to radiation therapy. And this leads us to the 1970s with the contribution of medical oncologists, pathologists, who are now able to spare or preserve the breast. This led us to skin-sparing mastectomies, and then what we do in such cases is the skin-sparing mastectomy. Those types of mastectomy have limited sections, they're well designed, they preserve the majority of the skin, the entire mammary gland is removed so that we can be hormonally correct, and this also allows us to opt for the reconstruction at the same time. And this means that our patients can benefit from the maximum highly cosmetic and natural result. And now we are in the nipple-sparing subcutaneous mastectomy. As of 2000 and on, in the case of prophylactic mastectomy, we are now using this technique. What have we achieved? We have achieved improving ourselves in the reconstruction with autologous tissue transplant and, of course, the implants. Our techniques have changed, and they will change over the next 10 years. Right now, we're at a very good level, have very good implants, very good meshes, very good reconstruction techniques. So quality of life is something that we can offer. Now, which are the mastectomies that we are going to propose to a woman who would like to proceed with prophylactic mastectomy? We have already heard them. We have the skin-sparing mastectomy. That's a very safe, oncology sound surgery. Very few complications, a 10% skin necrosis possibility, but if we can consider that this can be treated as well, then that's minimum. We also have the nipple-sparing mastectomy. We cannot do that in all women. We have an additional risk for nipple ischemia. This does not mean that we will lose the nipple, but we have an ischemia. And in the case of women with ptotic breasts, we also have the skin-reducing mastectomy, where we offer plastic surgery at the same time. So you can see that we have a solution for every woman. Of course, there are complications. Of course, those complications increase. The more demanding the surgery, the more the complications. But now let's look into the indications. If you look into the guidelines, you can see that we have 3 main indications. The first is the genetic mutation, meaning that we have more than 20% risk of developing breast cancer. Maybe we might have LCIS plus strong family history and radiation therapy in age younger than 30 years of age, which increases the relevant risk. And I can assure you that we have patients come to us with a small DCIS, and just because the breast is dense, they have been proposed prophylactic mastectomy. Huge mistakes are committed. Consultation is required, and in order for those patients to make the best decision, we need to consult them and advise them appropriately. We also need to remember that we have two types of patients ahead of us. The first is the healthy patient, the patient with a healthy breast, and we are there to propose to them that they cut this healthy part off. And on the other hand, we also have former patients, patients who have undergone surgery, chemotherapy, radiation therapy, lumpectomy. They have gone through a lot, so they're more willing to take the prophylactic mastectomy compared to a healthy subject for whom cancer is something very distant. So it's very important to listen to the woman, understand everything we want to share. Now, let's move on to the benefit. Is there a benefit? Cochrane database analysis. They collect all the papers that are available and they're interpreted in a way that allows us to have concrete results. Now, when it comes to bilateral risk reducing mastectomy in a healthy woman, yes, it reduces the risk of breast cancer more than 90%. And of course, in the case of the very high-risk patients with those BRCA1 and 2 mutations, that's maybe the only option. But when we opt for the contralateral risk-reduced mastectomy, we saw that it reduces the risk, but we don't know whether it improves survival. So we don't know whether a woman that has one side affected, whether she should opt for surgery on the other side. But then we had another study saying that, yes, even in those cases with the contralateral risk-reducing mastectomy can lead to increased survival. So to make the long story short, all very high-risk women can benefit from a prophylactic mastectomy, both in terms of survival and breast cancer development. But we all need to remember that every surgery comes at a cost. We know that there are demanding procedures that need to be carried out by specialized surgeons. There are complications, inflammation, purulation, skin and nipple ischemia. Okay, this might be 5%, but for a woman who experiences the ischemia, this equals to 100%. Sometimes the trauma might reopen or we might lose the implant. Things might not be that well for a percentage of our patients. Even if everything goes well, they might experience an asymmetry because we cannot have an identical breast to the one that the woman already has. At some point, a capsule is created or indurations. All those things might be translated into psychological problems and might affect the quality of life. All those things need to be discussed and addressed prior to proceeding to surgery. And I would like to conclude with some images so that you can understand. I believe that now simple mastectomy should be off the table in all cases. I believe that right now we're in a position where we can offer better results. Skin-sparing mastectomy is a safe choice because it combines the oncology safety with a very good and aesthetically sound result with nipple reconstruction. When the patient wears her clothes, she can feel normal, she can live normal. Now, skin-reducing mastectomy in the case of patients with big or ptotic breasts, okay, in that case, nipple is at risk more, but we also have some choices. We keep improving over the past 4 or 5 years. We can do such surgeries, preserving and sparing the nipple. So we're doing better, and I believe that in the next 4 to 5 years we'll be able to offer nipple-sparing mastectomy to all patients, even if they have big or ptotic breasts. And now the flagship, nipple-sparing mastectomy, the subcutaneous mastectomy I mentioned before, the best possible results, the more natural results for the woman. Of course, it's addressed to small or medium-sized breasts, and we know that this is very important, very satisfactory for the patients. And now we have the two categories of patients. In the first case, we have a patient who had developed cancer. She opted for skin-sparing mastectomy. In the second case, we have a BRCA1 positive patient who opted for the nipple-sparing mastectomy. No matter what we choose, this patient underwent nipple-sparing mastectomy on the left breast and skin-sparing mastectomy on the right breast. And we know that more or less the result is very good. In conclusion, we need to properly assess the risk for every patient. The patient needs to know what the risk is. She needs to be informed about the available choices. Patients need to be fully informed about the risk and the benefit of prophylactic mastectomy. They need to know when and to what extent this will help. They need to know which are the possibilities to develop a diagnosis if they don't opt for that. And of course, patients need to make informed decisions, always knowing the possible outcome. I hope I didn't bore you. I hope you understood what I mentioned. If you didn't interrupt me, I guess I'm okay with my time. Thank you so much.
So thank you very much, Mr. Lanitis, for the pictures speaking for themselves. I only saw very good aesthetic results, but from experienced surgeons, we only have to wait for good aesthetic results. Now we will go on with Mrs. Nikolaidi, who is an oncologist. She's going to give us not a different perspective, but rather she's going to add to the options and choices we have for the management of such high-risk patients. Madam, you have the floor. The speaker is muted. Now, good afternoon. Thank you all for the opportunity to participate even through the internet. Now, my talk will be in continuation of the two previous presentations and has to do with the management of high-risk patients and the perspective of the oncologist. I would like to apologize because some transparencies might seem quite difficult, but I'll try to simplify things. As you can understand, oncologists are going to see a patient following a diagnosis of an early breast cancer. And oncologists need to plan to see whether this is a high-risk patient. So it is important for us to take down, although in general many elements have already been mentioned, we need to take down what are the characteristics of high-risk woman. It has to do with tumor staging, having to do with the size. The second one has to do with the invasion of the lymph nodes of the axilla. Third fact has to do whether we are going to manage to eradicate fully the cancer cells before chemotherapy. There are certain scores that are defined by the clinical stage, the pathology stage, the expression of estrogen receptors, and the differentiation of the specific tumor. And finally, there are some molecular tests with genetic signatures for each tumor, which are often used to check whether there is a risk of relapse and to what extent the addition of hormonal dependent treatment, whether chemotherapy would be required to reduce the risk of relapse. We have found elements and evidence that shows that all this affects the course and the outcome for a patient and the risk of recurrence. That is, we know that the presence of positive nodes in the ipsilateral axilla is an element that can affect the relapse-free period, and we know that when we achieve a complete pathology response will lead to better outcomes as against having a residual disease, and the lower the scores, the better these women will do with the treatment. Now, only 2 words regarding genetic signature. You might have heard about oncotype and mammaprint, etc. This is the molecular analysis of an early cancer with positive hormonal receptors and HER2 negative, and this helps us identify whether this woman will benefit from the addition of chemotherapy, or she has a high score for a relapse only with the prophylactic chemotherapy. Now, this brings us to what has already been presented by other speakers in breast cancer. Aside from the fact that we have to deal with all these elements, if we are to characterize if they are in high risk of recurrence or relapse, etc., we need also to bear in mind whether there is an additional increased risk due to from hereditary reasons. So this has to do with BRCA1, BRCA2 genes mainly, and has already been mentioned by Ms. Fostira. We shouldn't have in mind that only the specific subtypes of early breast cancer should be checked for the presence of mutations in these genes, because the triple negative breast cancer is usually more associated with this hereditary burden, but also HER2 negative cancer has also significant percentages, and to a lesser degree we can find them in all the other subtypes. Now, when women come to see us with an early breast cancer, and we need to think whether we are going to proceed to a genes testing for the specific genes, aside from a very good history we need to have to see whether relatives suffer from respective neoplasias, etc. We need to know the age of diagnosis, since BRCA mutations of women are usually younger, the tumor grade, which is low, and we need to say that such women have a higher probability of demonstrating metastases or a second breast cancer. We also need to tell women that the presence of a mutation in BRCA genes does not necessarily mean that they have an extra burden vis-a-vis their survival during their treatment period. Studies have not reached a definite conclusion yet, and we cannot support such a claim. Now, and this brings me to the optimistic messages for such women, because as you can understand, every woman with an early breast cancer with a BRCA1, BRCA2 mutation will have all the treatment she should have on the basis of her staging. That could be adjuvant therapy, chemotherapy, or radiation therapy. But for those women who have already been characterized as high risk and in which we have found BRCA mutations, we have the option to administer other therapeutic options. PARP inhibitors form a classification of drugs that have been made known in ovarian cancer, particularly in women with mutations of BRCA1, BRCA2. They have also been studied in metastatic breast cancer for those women who have this mutation of BRCA1, BRCA2. And we have seen with olaparib and talazoparib that there is a benefit as compared to the typical chemotherapy in such women regarding their relapse-free survival. And we had olaparib as an adjuvant therapy, as a maintenance therapy after the typical therapies in early breast cancer in high-risk women with BRCA mutations. This specific category of drugs is based on the fact that PARP protein is the one that corrects the lesions and damages in the cancer cell. But when we inhibit this, and since patients with BRCA mutations have a destroyed pathway of repair, then the cell is led to apoptosis. Now, I will be presenting the data of this study regarding olaparib, which on March 11 has been approved by the American FDA as a drug, as an adjuvant therapy for BRCA mutations patients with high risk. The patients included in the study were initially those with these mutations, patients with stage 2 or 3, HER2 negative patients, but they were either hormone negative, hormone positive, or they had already taken the typical therapy. They had completed local treatment and had 6 cycles or more of neoadjuvant or adjuvant chemotherapy containing anthracyclines and or taxanes. And now these patients have been divided and separated into classes of high risk. And for those who had received neoadjuvant group, those who were considered high risk were those with a triple negative breast cancer whose stage was T2, but had also lymph nodes positive, or they had HR positive and more than 3 lymph nodes. For those with adjuvant group women, the women would be included if they had not shown a complete response, or they would have a partial expression of the receptors with scores above 3. Such women were randomized to olaparib 300 milligrams twice a day against placebo. So this was a maintenance treatment for a year. Such women, as you can see, in their majority, by 70%, had the BRCA1 mutations, and at a percentage of 28 had mutations of BRCA2. 2/3 of them were premenopausal, and they were mainly triple negative breast cancer patients, since 82% had triple negative cancer, but there was also another 18% of women who which was HER positive. The grade 2A and 2B, and of course there was also 3A, as we mentioned at the beginning. What has been proven following this treatment? There was a reduction of the risk of an invasive relapse by 42% for those patients who were on olaparib for a year in a follow-up for 3 years. Is there a benefit for all patients? Yes, indeed. This benefit might range. For instance, if women as chemotherapy had platinum, they benefited more, but the benefits pertain to all patients, be them on adjuvant or neoadjuvant treatment, whether they had been exposed to platinum or not, whether they were triple negative, but even into hormone positive. Now, in the 2 years or 3 years of follow-up, 87.5% of patients were free of relapse. And moreover, what was shown yesterday by the ESMO plenary was that when we have reached a follow-up of 4 years, the addition of this specific treatment gave a benefit to the overall survival, because 70% of women were still, 90%, excuse me, were still alive. So this goes to show how significant this preparation is for these specific patients. And since quality of life always plays an important part, we need to say that the use and maintenance of treatment with olaparib was well tolerated. A percentage of around 10% discontinued treatment due to adverse events, but in general, the percentage of adverse events was not such that would prohibit the continuation of the treatment. There were not serious adverse events, for instance, pulmonitis or new primary tumors or neoplastic syndromes or acute myelogenous leukemia. Rates were much, much better than in the placebo group. Here you can see some of the adverse events that have to do with the GI tract, fatigue, headaches, etc. But the only adverse event which is important is anemia, and it was found only in 5% of patients. Since there are data from the quality of life of patients when they are on olaparib for 1 year, at least in 2 years' time, it seems that the quality of life, having taken olaparib following adjuvant or neoadjuvant treatment, had not been affected negatively. So concluding, I'd like to say that this trial, the Olympia trial, was the first to report that for such patients that are characterized as high risk, there is now there is an extra thing to do after the standard treatment. There is yet another targeted therapy that can be used as a maintenance treatment that can increase their overall survival. Maybe the number of such women is not that high, but this doesn't necessarily mean anything. It is important for us to know that by adding a targeted drug for a year, we reduce the relapse risk by 42%, and 90% of patients are alive at 4 years' time, and with a quality of life that does not deteriorate for such patients. Many such patients, if they are hormone positive, who are on hormonal treatment as well, which adds to the toxicity profile. So if there is a take-home message out of all this presentation by an oncologist, we need to see that the control of patients with early breast cancer regarding these gene mutations, at least in the genes we now know that can be treated in a targeted way, BRCA1, BRCA2, should take place at the beginning, and that we should avoid not providing women with such possibilities. Thank you.
Thank you very much, Ms. Nicolaidi. After the last presentation, we will get back to you so that you can share a few more things regarding the role of MRI, mammography as a preventive test, as well as the prophylactic tamoxifen regime. But let's move on to the last presentation delivered by Professor Papaioannou. He wears many hats. I will just mention his title as President of the Negotiation Committee of AOP. And I know that he's with us today to share something very positive and good. Thank you so much for your kind words. Thank you for this invitation. Congratulations for this event. I believe that my role is not very pleasant, because we have to address a controversial issue, which is, of course, the reimbursement. I don't think I'm the most competent person to talk about the needs. We have listened to all the clinical data, so I don't want to repeat myself. But since we talk about money, since we talk about reimbursement, let's look at the big picture and the environment in which we are called upon to operate. You know that already, that cancer ranks second as a cause of death all around the world. You do realize how big that is, you do realize how important that is, but when it comes to the technological developments in genomic medicine, you can see that the number of genetic testing products that now are available on market increases exponentially. You can see that today we have 75,000 genetic testing products available on the market. Now, when it comes to biomarkers, in particular, that we use in cancer in the United States from 2015 and with an estimate up to 2024, you can see the increase in the health expenditure. The speaker has a problem with the pointer. You can see that we talk about billions of dollars and how this market increases over time. You can see that the biggest part of the market in terms of diagnostics as well as the drug discovery. You can see how much money has been spent on that. Now, when it comes to total expenditure on healthcare in Greece, you can see that, I'm afraid, is dropping. And it is in this sad context that we're called upon to reimburse the new available treatments. And on the other hand, we have the out-of-pocket spending that keeps increasing in Greece. Of course, this is not at all pleasant, because that's not the best possible scenario in order for you to discuss or negotiate the reimbursement of those things. The environment is rather hostile. Now, when it comes to the National Organization for the Provision of Healthcare Services, AOP, you can see that we have a specific procedure on the basis of which new technologies are being assessed in detail, and we're running processes in order for them to be reimbursed. You can see this unpleasant and extremely provocative role that the negotiation committee has undertaken. That's what we try to do. We try to negotiate the prices of medical devices or in vitro diagnostics, etc. So this is a committee that bears the burden of negotiating everything apart from drugs. You do realize that this is a huge field. It shouldn't be a committee, it should be an organization. And those working in this committee are not getting paid. Those are the ordinary members and the substitutes who are called upon to meet the needs of all those sectors that are being reimbursed by OP apart from the drugs in terms of laboratories, private clinics, etc. So the process for reimbursement starts with a slide that normally should precede this one. KESI, meaning the Central Council of Health, assesses biomarkers, their clinical utility, as you know, and of course it also opts to the cost determination. And then a ministerial decision is issued in order to determine who are the patient and at which price will receive a reimbursement for their tests. And then the insurance bodies are being informed about our decision. However, in order to create the contract, so with the laboratories, we need to start with a negotiation, not only in order to reduce this price, which is very high, but also to set some rules and conditions as to how this test will be reimbursed. So, AOP's administration assigns every year this committee with a task to negotiate all those things in order to include new technologies in its services. In our case, we have such a committee that exists for many years now, but the new committee was established late 2020, and in December they started convening. They set 4 subcommittees in order to allocate the various topics: clinical topics, diagnostics, medical device and equipment, and other services. And in early 2021, they announced following a prioritization of the issues upon which the negotiations would begin. Here you can see the allocation. We have 5-member committees working in order to meet the needs. Well, until today, 12 negotiations have been carried out. Most of them have to do with cancer in general. The diagnostic radioactive substance F-18 has been completed with success. In terms of breast cancer, we heard before that now we have contracts with some providers in order to have those panel testing reimbursed. The major success here is that we managed to reduce the co-payment rates for patients, meaning that now this burden has been alleviated for patients. We have set specific rules so that more testing could be carried out with more details. Right now, and on my next slide, I'm going to give you more information. We're now discussing the negotiation, conventionally speaking, the genetic test for BRCA1, BRCA2. You do realize how important that is. We have also negotiated issues for diabetes mellitus, Mediterranean anemia, thalassemia, mental diseases, chronic diseases, transplantation, in order to check the histocompatibility antigens, people with disabilities, about supported living structures, and daily hospitalization units, daily care. Those things have been completed, and recently, two days ago, we also completed with negotiations about diabetes mellitus type 1 systems. Now, I would also like to say that money is not the only thing we're focusing on. You do realize how important it is for all patients to have those financial resources being considered and carefully allocated. You do realize what's the social, financial, and psychological impact of our decisions. Our organization has benefited by more than €5 million thanks to this contract, and of course our organization has been spending €4 million per year in order for some tests to be a limited number of tests to be reimbursed. Now, when it comes to BRCA1 and 2, that's a major point of concern. This negotiation started back in April. It's almost a year now that's been going on. Okay, you might think that that's a very long time period. You don't know what's the problem. Is it a matter of workload? How is it possible to be in negotiation for more than a year, for almost a year, without having reached a conclusion? We have already met with medical societies, patient associations. We have collected all the necessary scientific data. Something that is extremely challenging for organization is to set the reimbursement model. And right now, we are trying to do something unique in Greece, something that has not happened before. If it is completed, this might be a highly pioneering approach, European first. And it takes us a lot because it will also lay the foundations for the upcoming negotiations. It will bring forward other things that have to do with how we can better manage requirements in such a framework. And we know that this will pave the way to other things as well. This is the reason why this has taken us so long, but I believe that we're nearing completion. Things change. In medieval times and before that, biomarkers were, for example, the color of the urine. We had uroscopy as a test, and the sensors and all the various instruments used to measure that was the tongue, because back then they would taste urine to see the acidity and the other parameters. And this has been the first method to diagnose diabetes. Since then, things have evolved, have developed. Technology is moving far beyond us. So we're trying to meet the basic needs. And once those main basic needs are being brought forward, they need to be reimbursed. And if you look into the first slides I showed you, you can see the big picture, like I mentioned before. I believe that in combination, in collaboration with medical societies and patient associations, and of course, if there is political will, because some things call for political interventions, especially when we talk about financing, I believe that we're taking some slow but steady steps. Thank you very much. Thank you very much. We were hoping that we would have listened something more promising, but anyway, you showed us that we're on the right track and hopefully will offer us what we need. Something better, something more concrete, actually. We were looking forward to listen to something more specific. The comments from the audience are off the microphone. Well, I hope that we will get there, right? Well, you know, since this negotiation process has started and we have reached this point, I know that this will be completed, and let's hope that we won't need 2 years to complete that. Let's hope that by the end of the year we will have reached a conclusion. I cannot share more details. I cannot divulge that because I'm not at liberty of doing that. But personally, I'm satisfied because I think that we're laying the foundation for the years to come, for the upcoming negotiations. And sometimes preparation lasts longer especially when you try to innovate in order to open doors. This delay is not that we're trying to hide the problem, to put it away. The comments of the microphone. I didn't have the time schedule. I don't know if you saw that. And the Mama Print negotiation lasted for 3 months. And we worked on that in June, July, and August, and this is where we ended it. We know that it is a difficult task. I didn't mean that you should feel bad because they didn't go on holiday or on summer vacation. But anyway, I just wanted to say that we're doing everything we can at the level of the committee. Of course, there are other topics that had been waiting longer for the negotiations to finish. I'm sure that we have more questions to ask, I know. It's a very difficult position I find myself in. Actually, not the hardest, but anyway, it's difficult. Okay, but I believe that your mandate is very important. Now, I would like to give the floor to our commentators. I would like to ask you for your comments. Please be very, very brief in order to have some time for discussion and questions. Mr. Antonopoulos, you have the floor first. Mr. Antonopoulos is the director at the Oncology Hematology Department of AstraZeneca, a company that is of special interest thanks to their product for hereditary cancer. AstraZeneca is a company that has supported genetic testing a lot in our country for almost a decade now. It's been almost 10 years now that through HESMO, the Hellenic Society of Medical Oncology, AstraZeneca has been covering this cost for ovarian cancer genetic testing. And this has been a major contribution to our work. Thank you.
Thank you very much, Mr. Salustros. I'd like to thank you for this honorary invitation to be amongst you today. We take down the same path, as I've said many times, and an important element in this development is the cooperation of all bodies and agencies. So this is what we achieve today around this round table. Now, what I'd like to point out is that starting from the first presentation by Ms. Fostira and reaching the last difficult or awkward presentation vis-à-vis the biomarkers reimbursement, there is one thing in common throughout this course, from prevention to treatment and in extension to access to innovative drugs. What do we have in common is a biomarker. The biomarker, anyway, constitutes an indispensable part in precision medicine. Therefore, it's important for us to solve all issues pertaining to the biomarkers. And definitely, well, usually I'm an optimistic person. Listening to the last presentation and knowing the background of some things, indeed, I think it's high time we solved this with the biomarkers. Now, I'd like to share with you pretty quickly in a minute a discussion I held yesterday with my niece who goes in the second grade of high school, junior high, and she likes me explaining to her the topics of conference, etc. So I was trying to explain to her the biomarkers, and I taught her a few things. She is a Formula One fan. She's against the stereotypes. And as soon as we completed our discussion, she turned to me and asked me, "That is, Uncle, this part with the biomarkers is as if you give me a Ferrari as a present without giving me the key to enter it." So this is how it works for drugs. We have innovation in drugs. The Greek state has helped us have access. You mentioned it yesterday, Mr. Salustros, in the Economists Conference. But we need to go back to see how we can have access to innovation, and this has to do with biomarkers. You know it too. We've talked a lot with Mr. Kikilias, etc. The part of the cost is important, but it is rather small as compared to the budgets for breast cancer and ovarian cancer innovation. And since, as you saw, Ms. Nicolaidi showed data and evidence and said that the specific therapeutic choice gives us the opportunity to have a better life expectancy. I'll change this and I'll tell you that the biomarker is the one that provides access to the appropriate treatment that will lead to these improved survival. So it is important for us to set up the regulatory framework, the reimbursement framework, in order for innovation and access to drugs go hand in hand with access to biomarkers. Thank you. Thank you, Mr. Adonopoulos. Correctly put. The truth is that the Greek state, as we said yesterday, even in its dire moments, was really close to the oncology patients. For instance, this drug that you heard about, Ms. Nicolaidi, has been only approved by the American FDA on this Friday, but there were many cases where we would suggest, or rather we would give a positive opinion for our patients to receive this drug before its approval. Now, Ms. Battistatou has joined us. She is a professor of medicine at the University of Vienna. Yes, well, thank you very much for the invitation. It's an honor and a pleasure for me to be with you. I hope that you can hear me. So I watched carefully and cautiously. It's an excellent event, and indeed I'd like to congratulate you, and I wish many happy returns. Now, in conclusion and in summary, if there is a take-home message, I'd say that every time we give a diagnosis of breast cancer to women, she starts wondering whether she has inherited it from her sister, from her aunt, or from her grandmother who suffered from breast cancer, because we know that 1 out of 8 women will eventually have breast cancer. So in our broader milieu, there's bound to be a woman with breast cancer, and I was happy to hear that things have been cleared. The breast cancer is a multivariant multifactorial disease. There are many factors involved. We're talking about environmental factors, the living, the lifestyle, hormones, and genetic factors. Only 10% of cancers are those who are purely genetic. This is important, and we also heard that even if we have this predisposition of developing breast cancer, we heard how we can protect ourselves either with medicines or operations, etc. I cannot but emphasize what the previous speakers said. As a pathologist myself, I consider this a big disadvantage in our own healthcare services provision. In our hospitals, etc. The reliable biomarkers control is the one that will allow us to opt for the best treatment and optimum response. So, is it possible to approve the use of a drug without approving of the reimbursement for the biomarkers? Even if we have approved of the medicine, not all patients have equal access to it because they cannot afford the biomarkers test. And as you heard, the cost of such a test is only a small part as compared to the cost of the respective medicine. So we think that we should have both at the same time. Approve of the drug, but also approve of this reimbursement for the biomarker testing. I'm glad to be here, and I'm glad to see that this has been a very constructive discussion. I'm sure that Mr. Papaioannou is listening to us attentively. Thank you, Ms. Batistatou. Would you like to move to the panel now? Ms. Chrysanthou Piterou, the Vice Chairperson of the Board of Alma Zois, is going to give us her own comments. We'd like to thank her for the hospitality and the initiative to organize such an important event today and tomorrow. So, good afternoon from me as well. I'd like to warmly thank our excellent speakers who have shared with us in an analytical way the definitions of high-risk women and the management from the part of the surgeon or the oncologist. As we heard, medical operations and acts have been inundated by the biomarkers that help us identify high-risk women, but they can also define the course of prevention of such women. If they have the disease, this will be diagnosed at a very early stage. Now, belonging to this specific group of patients, indeed, I feel proud of this progress that we have seen in the past few years, and I strongly believe in its contribution to reduce mortality rates. However, I'd like to share with you one of my concerns as to what the best management of high-risk women is, from the identification, diagnosis to the decision-making procedure. Now, Alma Zois has concluded with some basic positions on that, which I'd like to support on the basis of my own personal experience. In 2001, when my own adventure started with breast cancer, I knew that I would belong to a high-risk group. I had my grandmother and my mother who had fallen ill, BRCA1, BRCA2, had not yet entered clinical practice. However, I had started follow-up and gynecologist, and I had some occasional mammograms without following a coordinated and continuous follow-up. The presence of quite an extensive cancer astonished me, and I thought that I was doing something wrong. So the best thing and the first thing to do is to have effective measures to identify high-risk young women who might not be aware of their status. What is important is to have campaigns to raise awareness and to provide information to all these women everywhere these women are, they can be found: schools, universities, employment, etc. Then it is important for women who are aware that they are members of this team. They need to have access to continuous clinical studies with imaging tests starting 10 years earlier than the first cancer seen in the family, and depending on the type of the genetic mutation, aiming at timely diagnosis and treatment of an early cancer. Of course, the requirement is to have access to certified labs for biomarkers, for the tracing of genetic mutations, and to have all these tests reimbursed by the state. We all heard that these are expensive tests, and despite the fact that reimbursements for BRCA1 to have been established, so far they are not implemented, and we are still claiming for the reimbursement of these two genes while we are at the phase of a genes panel. I go back to my own case, the mastectomy and lymph dissection have helped me remove cancer. I had an immediate plastic surgery. This helped me accept my image. Then I had chemo and radiation therapy. I was lucky to have a very good relationship of trust and cooperation with a team of doctors who took care of me and who helped me deal with the side effects. But then there were other difficulties. I underwent the genetic testing together with my mother. We were found BRCA1 positive positive, and this to me meant that I was at high risk of developing a new cancer on the other breast, as was the case with my mother, but as well as ovarian cancer. And while at the end of my treatment I was trying to recuperate, I was before invisible enemies again. I had to choose between frequent controls in order to diagnose a potential new cancer at an early stage and a risk-reducing mastectomy and the ovariectomy. There were many dilemmas. Experts would speak with percentages and probabilities. However, the final decision was up to me. The fear and insecurity of guessing to go through the same thing, and the fact that I had already had my children led me to opt for risk-reducing operations. Alma Zois played a very important part where mental health experts indeed supported me to manage the control of the genetic testing and make my decisions. And yet another level of big difficulty in managing the whole situation was and still is the communication of the results of the tests with my children and their utilization to the benefit of my children's lives. So we can all understand how important it is for a woman to have access to these facilities and consultancy services. Women need great support if they are to weigh the benefits, the pros and cons for each decision in order to make sure that the quality of life is taken into consideration and the personal preferences of this specific patients at this stage in life. Another non-negligible matter which concerned us, and I think is a concern for all women in such a situation, was the fact that as a family we had to handle a huge financial burden, because back then there was no reimbursement, neither by the private nor by the public sector, vis-à-vis diagnostics tests and optional operations, as is the case so far. Although it's already been 20 years, everything had to be justified under the background of a false diagnosis of an extreme condition, and this is still the case today. And it doesn't do justice to the health system. The reimbursement rates in case of risk-reducing mastectomies for patients who have already been diagnosed with cancer and have mutations is really important, and we need to have the reimbursement for plastic reconstruction surgery, aiming at the mental rehabilitation as well. Let us not forget that women have to deal with all these difficulties and might not potentially be led to the best result because of the financial burden. So, in summary, it is really important for us to collaborate, we, patients' associations and scientific community, in order to properly direct women, high-risk women, to the proper services of the healthcare system so that they can get responsible care. This can be done only by specialized breast centers with multidisciplinary teams, experts, including clinical geneticists and mental health consultants. The reimbursement rules and regulations need to be fully aligned with modern and documented research data and the recent guidelines for clinical practice with a balanced cost-benefit approach. It is only in that way where we can reach better prognosis, reduction of the cost of treatment, and reduction of the mortality rates, which is what we're all after. Thank you.
Ευχαριστούμε πάρα πολύ. Κυρία Μίτση, κάναμε πολλή προσπάθεια να τηρήσουμε το χρόνο, οπότε τα 15 λεπτά.
Miss Mitzi, thank you so much. We have struggled to keep our time, so we will blame you for this 15-minute delay. So now let's try to answer the questions that I guess you might have, and we'll allow for some time at the end in order to return to the high risk that is not always related to the genetic background, etc., because we're not only talking about BRCA1 and 2 positive women who run high risk of developing cancer. So, any questions? The question is off the microphone for the time being. Well, I would like to ask you the following. A woman might come to me saying that she has a family history of cancer. Where should I refer her? What's the medical specialty I should refer her? Either say that I should refer her to the breast surgeon, others to oncologists, other to gynecologists. What can we do? I'm not talking about already diagnosed women. I'm talking about healthy women who want to know if they're high risk or not. Who's the physician I should refer her to? Secondly, allow us to especially thank Mr. Papaioannou, because I do realize that he's in a precarious position here. It's very difficult to make a point in terms of reimbursement and the delays and things that go on and on forever. Thank you so much for being bold enough to come here today. It has been a pleasure because I listened. Let's hope that we won't reach the end of 2022, but at least BRCA1 and BRCA2 will be approved as soon as possible. And I'm very glad to hear that this delays because you are trying to create an algorithm that will be used later. I'm very glad to hear that you're paving the way for other biomarkers to receive approval more quickly without having to go to need 3 or 4 years for an approval of already legally established biomarkers. I'm glad to hear that there is this new perspective. Now, when it comes to what Ms. Piterou said, I need you to understand that reimbursement of preventive surgeries is very important. Women have to undergo them, need to do them, because they're facing a survival risk. This applies to both healthy and already diagnosed women, and I would like you to keep that in mind. Thank you. Thank you, Ms. Michalopoulou. Now, when it comes to your first question, I would like to link this session to the previous session and say that the way in which those women are managed and addressed should be included in high-risk centers, breast centers. And if it is one time difficult to organize ourselves and create breast centers here in Greece, it is even more difficult to do that in other cases, because you do realize that we need to follow a multidisciplinary approach that is more complicated. AOP, sooner or later, I hope, will do what we're wishing, what we're asking for, and let's hope that this will happen soon enough. But then we also need to organize the structures. We need to improve our education and training. We need to ensure that genetic testing is being carried out properly and adequately, because let us not fool ourselves. Okay, we have a biomarker linked to the medicine, but high-risk women management is very complicated. And it starts before the diagnosis and it escalates to reach treatment. So you do realize that it takes collective effort in order for us to be confident and say that this woman with a family history should be referred there or there in order for her to undergo this testing and then be able to opt for another approach. Because a positive test gives us a direction. A negative test does not mean that this is the risk that exists for the general population. Are there any other questions? Okay, you have 2 Facebook questions. Okay, the first question goes to Ms. Fostira. A lady asks, when a daughter is not tested positive for these genes, if there is a mental law, does her daughter's offsprings will have these genes? Okay, let me say that sometimes we have heard that there are genes skipping generations. Why is this happening? Because some genes are expressed differently depending on the gender. I gave you an example of a breast cancer gene that goes through the paternal lineage. There is the father, they carry on this gene mutation, he won't develop any cancer, but he passes it on. The second thing I want you to remember is the one I mentioned before. When you have a BRCA1 genetic mutation, the possibility of suffering from breast cancer is 70%. It's not 100%. So practically it means that those women live among us. They have BRCA1 or 2 positive testing. They don't know it and they might never develop breast cancer. What we know from mental law is that genes pass on from generation to generation. So if today I'm tested and I don't have a BRCA102 mutation, and then I father children, then I cannot pass the BRCA102 of my mother. My mother might have a BRCA102. I'm not the biological mother of the child because I have given birth to children with donor eggs. Then you do realize that this is irrelevant. And we also have cases of mutations that occur at the time of birth. But the mental law is clear. If I don't have an altered and mutated gene, this cannot pass on to my offsprings. I think now it's clear. The next question goes to Ms. Nikolaidi. Are you still with us? One lady asks, so do you think that LABA is what you should propose in the case of HER2 negative HR positive cancer? Well, okay, that's a very interesting question. I cannot answer that regarding the olaparib because we didn't have HER2 positive patients in our study. So we don't have the data. I was asked the same question by a young patient with positive BRCA2 and HER2 positive. Actually, I tried to make a review of the literature, and actually there are no data right now that can document the administration of olaparib, either as an adjuvant or in metastatic setting for patients who have HER2 positive status and BRCA2 mutation. So I'm afraid I wouldn't recommend that, considering the existing evidence. However, if you allow me, I do realize what Mrs. Salustra said. In my presentation, I focused on high-risk women who have a genetic mutation because I thought that this was the main topic that you would like me to address. So whenever you want, Manolis, we can broaden this topic because I do realize that you would like to have this information as well. Okay, so a question to Ms. Nikolaidis and Mr. Lanitis. So you have in your practice a 50-year-old lady, that's an example. This lady has a mother who developed breast cancer in her 60s. She has increased BMI, she's a smoker, she does not exercise regularly. You run a mammography, the breasts are extremely dense. Okay, she has gone through the genetic testing without being tested positive in any mutation. How would you assess the risk for that woman? And which are the other factors that determine not the highest, but the high risk for developing breast cancer? Because you do realize that we talk about too many women among the general population. Ms. Nikolaidi, then I think that this will give you the pass in order to explain how we can better manage this increased risk. Okay, sure. You would like me to answer, or Mr. Lanitis? So, well, please, you can answer first, and then Mr. Lanitis. So, yes, it's true that Apart from the genetic burden, we also need to consider the family history. And there are other factors, such as the one you mentioned before. Obesity needs to be included. Alcohol consumption. Other things that have to do with reproduction, whether woman has had children or not, what was the when the menstruation began, whether the menopause has delayed. We also need to see the precarcinomatous things status, for example, the atypical lobular hyperplasia or the DCIS, the atypical ductal hyperplasia. So you do realize, as a consequence, we also need to consider the lifestyle as playing a decisive role, and they are additional factors that might lead to the development of malignancy or breast cancer. Of course, not to the extent that this would apply if there was also the genetic mutation in the background. So, the question is, in the 50-year-old woman with a family history with a mother who developed breast cancer in her 60s, how are we going to approach it diagnostically, right? No, I'm talking about your preventive approach. How are you going to manage her risk status? She has an increased risk status, right? Well, yes, okay, first of all, she needs to start by following the annual imaging testing regarding her breasts. In that case, I would like her to go through a breast surgeon consultation. She should undergo yearly tests with breast imaging. She has dense breasts, so I understand that mammography maybe in such high-risk patient might not be enough because it cannot give us a comprehensive overview. So maybe we could say that the annual testing combined with an MRI mammography could be more supportive in order to have a better clinical overview, a better image of her breasts. Okay, so Mr. Lanitis, I guess you won't propose an RR mastectomy. Well, actually, that's a very tricky question, because she does not meet any of the criteria that we would like her to meet in order to include her in a more systematic control. MRI mammography, well, as per the guidelines, is not right for her because we propose that in premenopausal women bearing the BRCA1 and 2 mutation. This does not mean that we can place this woman under specific guidelines. We need to approach this woman on a personalized basis. But even if you have a dense breast, we might be able to early detect a cancer there. Our advice would be for her to lose weight. I had also included a slide with the factors that we can control, and of course weight control is one of those factors. And of course she should go through regular testing. MRI mammography, yes, why not? I would include that. Every 2 or 3 years she would undergo an MRI mammography. And you do realize that when you have a high BMI woman, it's not very frequent for those women to have dense breasts. So that's why I said it's a tricky question. So we need to become more familiar with that woman, and I would follow up, I would monitor her more closely. Okay, thank you very much. Other questions? Other comments? Okay, I think that's all. Okay, we have... Allow me now to take advantage of my position. And I saw, Mr. Papaiwan, on your list with the topics under negotiation that you have also included chronic diseases. I see that you have also included other conditions. I would kindly ask you to include the patients who are nearing the end of their lives, or the patients at the end stage, the patients who receive palliative care. And I believe that if you take this initiative, AOP will make a substantial contribution to oncology patients, because that's one of the biggest needs in order to improve oncology care in our country. Thank you so much for your presence. Thank you for your contribution. I would like to thank all the speakers, the commentators, all the members of the audience. And I believe that now we can move on to the next session. Thank you so much.
Μ' ακούτε τώρα, μ' ακούτε. Πολύ ωραία. Καλησπέρα λοιπόν.
Good afternoon once again, dear ladies, dear gentlemen. I don't think it's working. Well, yeah, it is working. Okay. So I'd like to welcome you to this first Breast Cancer Patients Conference. It's an honor and a pleasure to be a moderator this significant roundtable on return to work. And almost 2 years after of a pandemic crisis, in this hybrid organization of an event, we get the opportunity to meet each other, something that we had missed. Now, until 2040, the estimated number of breast cancer patients around the world to working age is approximately 75 million. So you can understand that the return to work is really important. It's a high stake. What is important is that return to work enhances quality of life, financial independence, reduces social cost and social burden of cancer. But as you might suspect and as you might know, this return to work is not without obstacles. There are hindrances, obstacles, difficulties. Studies show that the unemployment risk after a woman diagnosed with breast cancer is getting unemployed is 1.4 times higher, and even more so in cases where we have freelancers or women working in small businesses. And it's always nice to think about discriminations due to gender. That are there anyway. So on this occasion, we'll try to think about such issues, and we'll have with us distinguished speakers whom we'd really like to thank for having accepted our invitation. Don't want to tire you any longer. We'll move on directly to Ms. Agela Milona, who is an economist with a Master of Science in Business Administration and Human Resources Administration. She has been working in Human Resources Department in the NGO Theotokos, and we are ready to listen to what you have to tell us on the return to work and cancer, breast cancer. Dear friends, good afternoon. Indeed, I'm really touched to be amongst you because for the first time we touched upon the issue of return to work or for those women who have had breast cancer. I'm amongst you. I feel close to you because we have had similar experiences. I too had manifested breast cancer 5 years ago. And back then, when I was diagnosed, I also had my mother with breast cancer at the end of chemotherapy. So far, I had the experience of taking care of a cancer patient in the family. And pretty soon, almost in parallel with her, I came into that same position. Aside from the huge issues that arise, which we all know, an important issue is employment. Now, work. I don't think that the specific weight is really followed. we need to make many decisions at all levels in our life, and having this emotional burden, being emotionally charged as to the way we will handle our treatment, how we will be responding to our relations in the family. We have to see how we will be handling the issue of work, how we are to tell our superiors, how we are going to manage time, whether we can have sick leaves, for how long, how will we communicate with our colleagues, will there be an impact on our professional career? Is there any possibility we lose our job? Is there any possibility to be discriminated against? So all these concerns and issues become real. This is the new reality of our life we need to manage most of the times, because in our professional arena we avoid to speak openly about it. We have before us superiors and colleagues who might feel awkward. They don't know how to stand next to us, and the truth is that many a times this further increases our stress and our insecurity. From the part of the employers, there could be behaviors such as cold attitudes, where our superiors might involuntarily be cold in their communication with us, or might question the timely planning, etc. The same as with colleagues, because they don't have the appropriate training to handle all issues that might arise from such a condition to a colleague. Well, this is awkward. This is only part of the issues that arise. Of course, we understand that the role of the employer is important. If employers are able to understand our needs, if they are able to understand that we might feel tired, we might have fatigue following our treatments, we might need to visit our doctors frequently, they need to be flexible about it, but it all needs to be seen systematically. Something which is not the case, and because right there and then we are on our own and we need to put an order in all labor issues. There is no clear guidance by the employer, by human resources directors, etc., as to how we can return back to work. This starts right from scratch, from the first moment, as soon as we are diagnosed. Employers need to have a very discreet meeting with us to get information as to how the steps of treatment will be, what is to follow, and gradually we need to start considering how we're going to deal with this disruption in our life. Correct communication and understanding exhibited by our employers and by our colleagues is crucial. This will allow us to find the strength and calm to respond to the requirements of our treatment. On the other hand, we don't want to become isolated. I don't think that there's any woman wishing to be isolated from her working environment. It is really useful to feel that she has still a working life. It is important to know that he will be returning to work at some point. By experience, I think that many of us have felt great stress as to the way we will handle this in our lives. The truth is that we are concerned. We might hold such discussions informally, but what's missing from the working environment is actually to have this cooperation and those steps that will create a normal transition to the return to work, both for financial reasons as well as for all those reasons for which return to work is important to us all. Because cut away from work, this would mean devastating effects. So unfortunately, we are cut away since we have to leave on a sick leave, etc. Rarely do we see cases where there are channels of communication that are still left open. All this has to be done in a way that is well balanced. Whatever we apply needs to take into consideration the needs of the patient, the general environment. The success of such a program depends on many factors. Each woman sees her work in a different way. And there are differences in educational levels and needs, etc. The broader environment, the financial environment or the family environment play all an important part. All these affect our own mood and behavior and stance vis-à-vis our return to work. What plays an important part is the working environment, be it a small business or a larger business. How much flexibility is available? Can they offer programs for a gradual return to work with a working hours schedule which is quite flexible, allowing for quick breaks or adjusting the working space, or where you can have an extra sick leave other than the one provided by the law, or at least have a framework that will facilitate you without cutting you off, but at the same time allowing you to participate in your work life. This is what we're all after. We want every woman to return to work, start over. This is going to be new normalcy. Through this experience we change, but we bring new things into our work environment. With the appropriate programs and with the support of employers and colleagues, having received training and education on similar cases, people who have opted for a different way of work, or who have a psychological impact, whose disease had a psychological impact on them. So this can all be trained. I mean, there can be trainings for employers, colleagues, etc. And this would mean that all these relations are improved. We have higher rates of empathy, higher rates of willingness to cooperate. This renders our working environment much more humane. This is not the ultimate objective, of course, but this is something that actually promotes business culture, and in general it promotes social ties. We open up, we show interest, we learn what this disease is all about, not in order for us to fear it, but in order for us to stand by next to these people. We get to know their needs, we get to know how we can help them and have this normal and sound transition. So through this, I think there is a benefit and an added value both to businesses as well as to patients. So there is a humanization, if I may use this term, of the working space. I think that's important. I don't know if you have experienced a similar thing. I don't want to mention too many studies and services, etc., because the issue of return to work is huge. There are many factors that are in the play. But well, our aim for today was to start speaking about, so to start considering how important it is for women who have been diagnosed with breast cancer to maintain their job and go back, return to work without any fear, without any stress, without being scared that they are going to be fired, that they won't be marginalized because of that, etc. And unfortunately, because our vulnerable fellow human beings are easy to fall into the margins, we need to learn how to embrace vulnerable people at the time of their need, thus empowering them and including them in the broader society. We coexist, we live all together, and there's room for everyone to develop such policies. In large businesses, I believe that it's relatively easy to have this because there are already organized human resources departments, and they have highly specialized personnel. In smaller businesses, associations such as ours, such as Alma Zois, could offer significant help, providing providing advice to employers in small businesses, providing advice to employers and employees as to the steps of the return to work process. There needs to be coordination and cooperation between many different parties. We have the work physician. We can create return to work groups, specialized ones, occupational psychologists. This would have an impact on all aspects of our lives, but I believe that with coordination, good spirit of cooperation, all these things can be solved in the best possible way, avoiding conflicts, avoiding stress, avoiding uncertainty. We need to create those conditions that will empower people, because the aim is for women to return to work, not only because this makes a difference in the life of such women patients. They have one less thing to worry about. this allows us to be calm and move on to dealing with the other significant issues we need to tackle. But I do strongly believe that maybe through this test, we might become better people. We might be able to stand next to each other. We might be able to learn. We need to help employers, colleagues, those who compose our working environment need to understand, they need to see, they need to receive training. Maybe they need to acquire extra professional skills. We need to do what we can do. There are tools, there are surveys, there are studies that are being conducted, and we can offer appropriate professional help for the return of women to work. And another thing, thank God we have the law protecting women in extreme cases of discrimination. This is the law on disability and people with disabilities. This is really important because there is no clear distinction or clear definition that pertains to cancer patients, women cancer patients, but there is this law on discriminations, etc. There is a huge amount of stress involved here. We need to be really cautious. We can't have a woman who suffers from cancer have to manage this stress as well, because so far every patient is on her own. The rehabilitation program, the return to work program, they are not in a position to make the best of judgment. And when there is cutting off of the communication channel, it is quite confusing for them. They might opt for wrong decisions because of such a inefficient planning of the return to work. It would be a great facilitation. This I said off the cuff. I didn't want to speak about surveys, studies, and hard data. Yes, well, Ms. Milona, we'll have the opportunity later on, if you have concluded, to discuss about all this. What I wish for is pretty soon for the next generation of women to have to deal with a different reality under better conditions at all levels, even at the level of the working environment. We need to have the steps necessary in order for women to be supported. We owe this to them. We need to help them providing support. Thank you.
Thank you very much. I would like to thank you for this highly comprehensive presentation. I would like to repeat a few words, and I hope that we have the opportunity to discuss these things: communication, understanding from the employer, from the colleagues, loneliness of a woman who is called upon to make decisions about things that she doesn't know about, synergies, and integration. And we know that this is beneficial not only for the woman who returns to work after diagnosis, but also for the society, companies. So I would like to give the floor to Ms. Eleftheria Koureda. She's a trained volunteer of our associations. She is supporting the cause of the association for many years now. She has also served in the board from 2008 until 2021. She's Labour Inspector at the Labour Inspectorate of Greece, and we're looking forward to listening to your presentation about the needs and obstacles of working patients. I would like to thank you for this invitation. It is with great pleasure that I find myself with you today. I would like to thank you for offering me the opportunity to start this discussion and discuss the return to work for breast cancer patients. I happen to be an expert on this topic. I'm a special labor inspector. I have worked for many, many years on return to work, both in theory and in the field, in terms of audits that have to do with working women and employees in general. And I'm also a breast cancer patient. I have an 18-year-old experience with breast cancer, and I have gone through these phases myself. So, and let me now move my presentation forward. So, survival of breast cancer patients is a different experience for every woman. Everyone experiences this disease in a different way, and it is an ongoing experience. It's not a one-off thing. It's not something that ends at a specific time. A very important aspect of a patient's survival is to regain as many as possible of our pre-cancer related life aspects. And at the same time, we want to ensure that patients find new ways to successfully continue their life. It is in this framework that the return to work and reintegration to society is very important. For many women, this is a priority. The speaker still struggles with the pointer. Now, first of all, an important thing is the living. We need to make a living, because we know that everyone works in order to meet the family's needs. And working is very important because it can offer an opportunity to women to reconnect to her social relations with friends and colleagues. It is a very important source of self-confidence and self-improvement. And in the case of some women, it helps them to focus on something else other than the disease. And as a result, this is reassuring, and this also makes them more willing to live and experience this return to work. Well, some key observations, all on the basis of published research and papers that have been published in Europe and elsewhere. Approximately 1 out of 4 cancer patients state that they have lost income from their work as a result of the cancer diagnosis. It is true that freelancers, when diagnosed with cancer, are especially vulnerable, especially if the social insurance system does not compensate a part of income loss, because we know that freelancers and self-employed people have to discontinue their work, and this is an actual reality. Cancer treatment in some cases might lead either to work loss or change. In Greece, there are differences and inequalities in terms of the rights that cancer patients have. And I'm talking about people who work in the public and the private sector. A working patient or a breast cancer survivor can experience many different things in terms of their workplace. For example, they might continue working throughout their treatment. I was one of those cases. I continued working. I'm one of those cases. They might change the type of work or the working hours. For example, they might switch from full-time to part-time or vice versa, or they might start working more from home. They might also experience loss of work during treatment. They might try and find a new job that is either a matter of choice or necessity, because many women decide to change their work or the job because they prefer to switch to something they had never tried up to that moment and they wanted to do that now. They might have also developed comorbidities as a result of the treatment, something that requires from them to change their work or position. Some women might feel unwell when returning to work because they are afraid that they might not be able to cope with stress and the intensity of work, and many women with breast cancer working in manual jobs might be faced with substantial loss of their performance. For example, hairdressers who need to use all this equipment, they might have undergone mastectomy, so this means that it is difficult for them to make those movements, because you do realize that there's a certain intensity of women that iron things, waiters that have to carry heavy trays. All those women might not be able to return to their existing workplace, and of course they cannot perform equally as they did before. Now, on this slide I have included the situation as it should be. Working breast cancer patients or survivors, either they have completed their therapy or they return after the treatment, should enjoy equal rights with anyone else in the workplace. They need to be given equal opportunities, regardless of whether she has announced or not, or whether she has shared or not the fact that she has suffered from cancer. When it comes to aspects such as hiring, promotion and workplace behavior, it should rely exclusively on her capacity and skills, without having the cancer or the diagnosis being involved in that. In Greece, we do have the legal framework regarding the equal treatment in the workplace, because it addresses the needs of patients and breast cancer women. I believe that this is quite modernized, but in practice, because okay, we might have the theory, but in practice we see that there are some gaps in terms of its implementation. On this slide, you can see some of the needs that breast cancer patients have in terms of their return to work, as they were recorded during a workshop that was organized upon an initiative of Alma Zois last year. This workshop discussed the needs of working cancer patients and the obstacles they're faced with when they want to return to work. And those needs were recorded by numerous women spanning across various industries and sectors. One of the main needs is the need for comprehensive and timely update as of the moment of their diagnosis regarding their labor rights. Because when you know what you have to address, what you should do in order to address it, then it's better for you to organize it. If you know which are your rights, then you can schedule accordingly so that you can then return to work more easily. Women expressed the need for having flexible working hours, meaning whether modifications could be made depending on what every woman has to address and what her needs are in order for her to return to her work, so that women can work for as long as they want. They also shared the need for having longer recovery time before returning to their workplace, and of course the maintenance of a disability rate in women with metastatic breast cancer. Now, when it comes to obstacles, there are obstacles that have to do with lack of information about the patient's rights, lack of an institutionalized and established framework that can meet their needs, complexity of the processes that are required in relation to insurance bodies and disability certification centers, and of course another important obstacle is stigma, disease-related stigma, and I'm going to elaborate on that later. Well, when it comes to return to work, we know that there are some reasonable adjustments that need to be made for women with breast cancer. And I'm talking about women who return to work after a breast cancer experience. Which are those reasonable adjustments? Those things include actions that can be undertaken on behalf of the company, of the business, in order to facilitate the return to work of those women, with a view to enabling those women to readapt to their workplace and become productive again. Those things indicatively include the amendment of equipment or devices that she uses. These might also have to do with adjustments or modifications in a working position, meaning part-time, modified or flexible working hours. Maybe she can also work from home to some extent. In general, those modifications can better facilitate women and help them perform as they did before cancer. This might also include the business offering a new working position with different duties and mandates. However, they should be equal in terms of payroll to the previous position. Let me now get back to this thing. Those are the modifications that the business can make. And it is very important for businesses and HR departments to bother considering those modifications, because those things are to the benefit of the business, because a returning employee that returns and tries to reintegrate after this experience, and even in the case of people who continue to work throughout treatments, or in case of women who are faced with metastatic breast cancer, and yet they continue to work. Once those modifications are implemented, then we have the occupational peace in the workplace, and this employee remains productive, keeps performing. And this is to the benefit of the patient and the workplace, because you do realize that in organized workplaces, we have workplaces where lots of factors need to be considered. So they work as a team. People who return properly to this environment is beneficial for the entire team. Now, going against discrimination, that's very important. This is linked to the disease-related stigma. It is very important for people who have cancer experience, and in that case we talk about breast cancer survivors. They shouldn't face discrimination. Actually, discrimination should be off question for everyone, but anyway. When we talk about female patients who continue to work or return to their work, shouldn't be faced with discrimination. However, it is likely for women to be faced with behaviors as the ones displayed on the screen. They might be isolated. They might be faced with others underestimating or undermining their capacity and effectiveness to work. They might see their promotion request being rejected without an explanation or justification. This might be due to their disease, lack of understanding and or flexibility with regards to their request to take a day off due to medical appointments. This might happen because, one might say that, the woman might ask for a day off or to go for a medical test, and then this might be frowned upon. Statements on behalf of the administration, the colleagues, that the productivity is not the same as it was, you're not like what you used to be, etc. And all those things mean that this woman is facing discrimination. Every effort needs to be undertaken, especially from the part of the employer, so that those things are not encouraged. And at this point, you have 2 more minutes to conclude. I have 2 more minutes? Okay. I think that we will have some time to discuss those things later. I believe that I have brought forward a majority of the issues I wanted to talk about, and I'd like to conclude with this slide. This is very important because it is a positive step. It's what we call post-traumatic growth. Those are the positive changes that happen in life after an anxious and stressful situation. Breast cancer falls specifically under this category in description. Women who have experienced breast cancer, not all of them, but most of them, describe a positive personal change. This positive change can happen in the workplace as well. And this might also happen because breast cancer women returning to work or continuing to work during their treatment have many things to offer. They have many things to add and contribute to their workplace because she has new life experiences. She's stronger. She has grown personally and mentally. She has obtained a different wisdom, and those things are valuable assets for every business. So I truly believe that we are precious for the businesses we work in. We offer a lot to the workplace. That's all I had to say. Well, I'm sorry I mentioned so many things in so little time. I wanted to bring all these things forward. Thank you so much. Everything is very interesting, very useful, but we will move forward very quickly because we don't have time. And I would like now to give the floor to Ms. Evgenia Fotopoulou. She's an attorney at law. She's a legal advisor at the Hellenic Association of Breast Cancer Women, Alma Zois, and she's going to talk about the right to be forgotten. Ms. Fotopoulou, please, up to 15 minutes tops, otherwise I will have to interrupt you because we want also to give the floor to our commentators.
First of all, the right to be forgotten is my topic, Before we started speaking about cancer, let me tell you what the right to be forgotten is all about. Very specifically, it is defined under the General Population of Personal Data Protection. This is the right of everyone, and not only patients, to have their personal data deleted, and since they are not necessary anymore, and since they do not give their consent. When health issues are involved, you can understand how important the right to be forgotten is. When we want to delete a past that should no longer affect us in our lives, cause problems, as previous speakers have mentioned, because the problems arising are huge when we try to return to work, for instance. Unfortunately, I'll speak about the legislation abroad, because still in Greece we haven't incorporated any law or any decree pertaining to the right of cancer patients to be forgotten vis-à-vis insurance companies, banking institutions. We all know, directly or indirectly, that these institutions ask for a history in order to provide insurance or to grant a loan, whether they're going to do so in the same terms as for other people who haven't fallen ill. So since all this is still not incorporated into the Greek legislation, I will refer to foreign legislations. I'll skip some transparencies. You were right, Ms. Kourin, the button? Yeah, okay. I've prepared several transparencies, but I won't show you all of them. If you want, I can send them, I can email them to you. There are some of them that are quite significant. I'll start with Portugal, with a very analytical legal framework, which of course is quite recent. For Portugal, this stems from 2021. You see that it is a repeated motif, a repeated pattern. We have several categories. So, on October 22nd, 2021, the Portuguese government approved of a law regarding the right to be forgotten for people who have overcome significant problems of health and disabilities. This law aims at improving their access to mortgages, consumer loans, insurance policies, etc. So, according to this law,
συμβάσεις σε οποιονδήποτε έχει υποφέρει από ασθένειες που μπορεί να οδηγήσουν σε μειωμένο προσδόκιμο ζωής, όπως ο καρκίνος και κάποιες άλλες ασθένειες. Οι χώρες που στη συνέχεια θα αναλύσουμε είναι η Γαλλία, είναι οι κάτω χώρες, η Ολλανδία, το Λουξεμβούργο, το Βέλγιο. Ειδικά η Γαλλία υπήρξε πρωτοπόρος, ήταν ήδη και πριν την ψήφιση του GDPR, αλλά μετά το έχει ενσωματώσει και πιο συγκεκριμένα. Αυτή είναι πολύ σημαντική διαφάνεια. Είναι ίσως η σημαντικότερη, δεδομένου ότι υπάρχει αυτά ακριβώς τα σημεία, τα τρία, είναι σε όλες τις νομοθεσίες και των υπόλοιπων χωρών, που στη συνέχεια θα δούμε πολύ ακροθυγώς. Την Πορτογαλία θα δούμε αναλυτικά ως πρότυπο. Υπάρχει λοιπόν το δικαίωμα στη λύθη, που ο Πορτογαλικός νόμος 75 του 21 θεσπίζει, οι θυγόμενοι δεν πρέπει να υπόκεινται σε αύξηση των ασφαλίστων, ούτε να αποκλείονται από οποιαδήποτε ασφαλιστική κάλυψη. Καμία πληροφορία για την υγεία σχετικά με ιατρική κατάσταση που προήλθε ή επιδεινώθηκε από ένα κίνδυνο για την υγεία ή κάποια αναπηρία δεν μπορεί να συλλεχθεί ή να υποβληθεί σε επεξεργασία από πιστωτικά ιδρύματα ασφαλιστές σε προσυμβατικό πλαίσιο, όχι όμως ανεφόρον. Ίσως πριν αυτό το οποίο υπενήχθηκαν έδωσε μια λάθος εντύπωση ότι δεν θα πρέπει να λαμβάνεται κανένα ιστορικό από τη στιγμή που κάποιος έχει νοσήσει. Όχι, αυτό το οποίο έχουν ενσωματώσει ξένες νομοθεσίες και ευελπιστούμε να γίνει και από τη δική μας, είναι με τους εξής όρους. Εάν έχουν περάσει 10 έτη από την θεραπεία, από όταν έχει τελειώσει το θεραπευτικό πρωτόκολλο σε περίπτωση σοβαρού κινδύνου υγείας, ή 5 έτη από το τέλος του θεραπευτικού πρωτοκόλλου σε περίπτωση ανάρρωσης από την πάθηση, αν η πάθηση έχει λάβει χώρα πριν τα 21 έτη. Αυτή είναι η δύο όροι, πολύ σημαντική. Δηλαδή, θα πρέπει να έχει περάσει ένα σεβαστό χρονικό διάστημα 10ετίας ή 5ετίας στην περίπτωση που κάποιος νόσησε πριν τα 21 έτη, για να μπορέσει να γίνει δεκτή να είναι υποχρεωμένος ο ασφαλιστής ή οι τράπεζες να συνάψουν τις συμβάσεις και να μην τις αρνηθούν για το λόγο της νόσου. Υπάρχει και το τρίτο σημείο αυτό των 2 ετών, αλλά δεν αφορά την νόσο του καρκίνου. Είναι για τις ασθένειες όπως, ας πούμε, το AIDS, που είναι μια διαρκής ασθένεια που κάποιος δεν είναι ζήτημα το αν ανάρρωσε, είναι 2 έτη συνεχούς και αποτελεσματικής θεραπευτικής αγωγής, ακόμα και αν κάποιος δεν έχει αναρρώσει. Σε περίπτωση αυξημένου κινδύνου, αυτό ουσιαστικά είναι ένα χαρακτηριστικό παράδειγμα, είναι το AIDS. Οπότε αυτό τη 10ετία και την 5ετία θα τη δείτε να επαναλαμβάνεται σε όλες τις χώρες. Παρόλο που στο GDPR δεν αναφέρεται κάτι τέτοιο, ωστόσο τα κράτη έχουν υιοθετήσει αυτή την πρακτική. Ο νόμος λοιπόν αυτός θα εφαρμόζεται, και εδώ είναι αυτό που σας είπα πριν ότι θα το εξηγήσουμε στη συνέχεια, τι είναι ο μετριασμός της αναπηρίας. Εφαρμόζεται όχι μόνο στα άτομα τα οποία έχουν αναρρώσει τελείως, αλλά και σε αυτά τα οποία έχουν μετριάσει την αναπηρία. Ίσως η φράση να μην είναι απολύτως εύστοχη, έχουμε κάνει πιστή μετάφραση, εννοούμε το εξής, ότι εφαρμόζεται και σε άτομα που έχουν ξεπεράσει μια κατάσταση αναπηρίας, ορίζοντάς τα ως εκείνα που, ανοίγουμε εισαγωγικά γιατί είναι ακριβώς η ορολογία, έχουν αποδειχθεί ότι βρίσκονται σε κατάσταση αναπηρίας ίση ή μεγαλύτερη του 60% και έχουν ανακτήσει τις ψυχολογικές, διανοητικές, φυσιολογικές, ανατομικές δομές ή λειτουργίες τους, μειώνοντας την ανικανότητά τους κάτω από αυτό το όριο. Δεν απαιτείται δηλαδή να υπάρχει πλήρης ανάρρωση, αλλά αρκεί να έχεις κατεβάσει κάτω από αυτό το ποσοστό αναπηρίας. Τρέχω τα σημαντικά γιατί...
Έχουμε 2 λεπτά περίπου.
Έχουμε περίπου 2 λεπτά. Ωραία. Τότε, περνώντας την Πορτογαλία, επαναλαμβάνονται, είναι στη διάθεσή σας, είπαμε, δεν θέλω κλείνοντας, να μείνω στη Γαλλία, η οποία ήταν πρωτοπόρος, υπήρχε η Συμφωνία Αέρας, η οποία ήταν ένα εθνικό πρωτόκολλο ήδη από το 2016, πριν το GDPR, πριν αρχίσουν όλα αυτά με τα προσωπικά δεδομένα να είναι πιο πολύ στο προσκήνιο. Είναι ένα εθνικό πρωτόκολλο μεταξύ του κράτους και επαγγελματικών οργανώσεων που εκπροσωπούν τα πιστωτικά ιδρύματα, τις εταιρείες χρηματοδότησης, ασφαλιστικές εταιρείες κτλ. Που σκοπός της σύμβασης αυτής είναι να διευκολύνει την πρόσβαση στην ασφάλιση και το δανεισμό για άτομα που παρουσιάζουν επιβαρυντικό κίνδυνο λόγω της κατάστασης της υγείας τους ή με αναπηρία. Μετά το GDPR βελτιώθηκε η Σύμβαση Αέρας, αυτό έτσι είναι τα αρχικά, και πλέον έχει και η Γαλλία κάνει αυτή τη διαβάθμιση με τη 10ετία και την 5ετία που αναφέραμε. Νομίζω δεν μπορώ να πω κάτι άλλο, οπότε σταματώ εδώ. Τα σημαντικά υπόθηκαν ωστόσο και ελπίζουμε και ευχόμαστε και με τη συνδρομή, δεν ξέρω εδώ, του Συλλόγου, ο οποίος μάχεται πολύ, αυτή είναι η δική μου εμπειρία, να μπορέσουμε να κάνουμε κάποια πρόταση στη διάθεσή σας, αν θέλετε κάτι να φτιάξω σαν κείμενο.
Κυρία Φωτοπούλου, ευχαριστούμε πάρα πολύ που συμπυκνώσατε και όλα αυτά που θέλατε να πείτε σε αυτόν τον χρόνο. Είναι πραγματικά πολύ σημαντικά. Η επιβίωση από καρκίνο του μαστού δεν μπορεί να αποτελεί αιτία διάκρισης για την υπόλοιπη ζωή. Να καλέσω αμέσως, για να προλάβουμε ίσως και λίγο χρόνο για συζήτηση, τις εκλεκτές μας σχολιάστριες, την κυρία Βαρχαλαμά, εκπρόσωπο από τη ΓΕΣΕ, και την κυρία Κατερίνα Δασκαλάκη, εκπρόσωπο από το ΣΕΦ. Θα τις δούμε διαδικτυακά. Η κυρία Βαρχαλαμά είναι δικηγόρος, πτυχιούχος της Νομικής Σχολής του Πανεπιστημίου Αθηνών, με μεταπτυχιακό τίτλο σπουδών στο Εργατικό Δίκαιο και είναι νομική σύμβουλος της ΓΕΣΕ. Και η κυρία Κατερίνα Δασκαλάκη είναι senior advisor σε εργασιακές σχέσεις στον ΣΕΦ. Να τις ευχαριστήσουμε πάρα πολύ για την αποδοχή της πρόσκλησης. Να πω σε αυτό το σημείο ότι δυστυχώς δεν έχουμε κάποιον εκπρόσωπο από το Υπουργείο Εργασίας, παρόλο που υπήρξε πρόταση, θα τους θέλαμε να είναι σήμερα εδώ. Παρόλα αυτά, θα συνεχίσουμε με τις εκλεκτές μας ομιλήτριες. Κυρία Βαρχαλαμά, μας έχετε ακούσει, θεωρώ. Έχουμε πει πολλά. Αν θέλετε να μας κάνετε το σχόλιο σας.
Καλησπέρα. Ευχαριστώ πάρα πολύ για την πρόσκληση. Είναι ιδιαίτερη τιμή και χαρά. Μεταφέρω και εκ μέρους του Πρόεδρου της ΓΕΣΕ την ιδιαίτερη τιμή και χαρά της πρόσκλησης της ΓΕΣΕ στη διαδικασία αυτή. Επιτρέψτε μου μόνο ένα προσωπικό σχόλιο πριν ξεκινήσω. Είναι ιδιαίτερη χαρά μου που βλέπω και εδώ την κυρία Κούρεντα, η οποία έχει υπάρξει, έχουμε δουλέψει μαζί σε κάποιες περιπτώσεις και στο εξωτερικό, και καταλαβαίνω ότι τις στιγμές που την είδα έτσι ισχυρή και δυνατή και να εκπροσωπεί ένα δύσκολο κράτος και με δύσκολες καταγγελίες στη Διεθνή Οργάνωση Εργασίας τότε είχαμε, ήταν αξιοπρεπέστατη, πολύ δυνατή, πολύ δυναμική, και χαίρομαι πάρα πολύ που την ξαναβλέπω και από εδώ. Κλείνω. Ένα προσωπικό σχόλιο αυτό. Και στο πρόσωπό της, να το πω ακριβώς, νομίζω ότι τιμούμε την προσπάθεια όλων των γυναικών που διέρχονται μέσα από αυτό το στάδιο, και εύχομαι επιτυχώς. Κοιτάξτε, για να είμαι πολύ σύντομη, το πλαίσιο το θεσμικό για την απασχόληση, την εργασία εγώ θα πω για την εργασία, όχι για τις αυτοαπασχολούμενες, έτσι, για τις εργαζόμενες, είναι ιδιαίτερα δυσχερές. Υπάρχουν κάποιες ενδείξεις φωτός, ελπίδας, προστασίας, σε βάση περιπτώσει, θα σας τα πω πάρα πολύ περιληπτικά κι εγώ. Ωστόσο, συνήθως κατά το στάδιο της εργασίας, όταν υπάρχει νόση και πρέπει να γίνουν οι εξετάσεις, οι θεραπείες κτλ., συνήθως οι γυναίκες αξιοποιούν δικαιώματα τα οποία δεν είναι για αυτό το σκοπό. Λίγο τραβάνε από τις αναρωτικές, λίγο τραβάνε από την ετήσια άδεια, λίγο μπορεί να κρυφτούν πίσω από κάποια άλλη άδεια. Δυστυχώς το πλαίσιο δεν είναι προσαρμοσμένο ώστε να διευκολύνει τους εργαζόμενους και τις εργαζόμενες που νοσούν από καρκίνο, εν προκειμένου τώρα μιλάμε για τον καρκίνο του μαστού, και δεν είναι και ιδιαίτερα διευκολυντικό. Αντίθετα, κάποια βήματα έχουν γίνει τώρα για τους φροντιστές. Οι φροντιστές φαίνεται να διευκολύνονται ως προς την υποστήριξή τους προς τα μέλη της οικογένειάς τους, τις γυναίκες, μητέρες, συζύγους, κόρες σε πολλές περιπτώσεις αμυλικότητας που εμφανίζουν καρκίνο του μαστού. Υπάρχει με άδειες για αυτό το σκοπό, και υπάρχει και η δυνατότητα εδώ ρητής ρύθμισης για την ευελιξία για ευέλικτες ρυθμίσεις στους όρους εργασίας τους. Προφανώς πρέπει να γίνει, να το υποδεχτούμε αυτό ως θετικό μέτρο. Βέβαια δεν είναι θέμα της ελληνικής πολιτείας, είναι συμμόρφωση με ευρωπαϊκή οδηγία, οπότε σε αυτό ήμασταν υποχρεωμένοι να το κάνουμε, και η προσωπική μου άποψη είναι ότι αν δεν υπήρχε οδηγία θα είχαμε αργήσει πάρα πολύ να το κάνουμε έστω και αυτό. Γενικότερα, και πολύ σημαντικό είναι ότι οι φροντιστές έχουν την προστασία που έχουν για την απόλυση, δηλαδή την προστασία από την άνηση μεταχείριση, και αν τυχόν προκύψει κάτι τέτοιο, ζητήματα πρόσβασης στις διαδικασίες, όπως την αντιστροφή του βάρους απόδειξης, δηλαδή ότι ο εργοδότης πρέπει να αποδείξει ότι ο λόγος απόλυσης ή βλαπτικής μεταβολής δεν οφείλεται σε αυτό που ισχυρίζεται ο εργαζόμενος και τους λόγους που χρησιμοποίησε τις άδειες αυτές. Αντίστοιχα, όπως είπε και η κυρία Κούρεντα, έχουμε το πλαίσιο τώρα που προκύπτει πάλι από νοσιακό κανονιστικό πλαίσιο, που είναι για την άνηση μεταχείριση λόγω αναπηρίας ή χρόνιας πάθησης. Εκεί πρακτικά τι έχουμε να πάρουμε από αυτό το πλαίσιο? Έχουμε να πάρουμε τις εύλογες προσαρμογές. Οι εύλογες προσαρμογές είναι αυτές που περιέγραψε πολύ καλά το πλαίσιό τους η κυρία Κούρεντα. Είναι αυτές και δεν είναι μόνο αυτές. Πιο κοντά στον προσδιορισμό των εύλογων προσαρμογών έχει έρθει η ΕΣΑΜΕΑ, η Εθνική Συνομοσπονδία Ατόμων με Αναπηρία, εξειδικεύοντας το πλαίσιο που υπάρχει για τα άτομα με αναπηρία. Οφείλω να πω, αν και δεν θέλω να είμαι σκληρή, ότι ακόμα και η διαδικασία της πιστοποίησης αναπηρίας είναι μια πάρα πολύ δύσκολη διαδικασία. Έχω και εγώ προσωπική εμπειρία. Και μόνη της αυτή μπορεί να επιβαρύνει την κατάσταση του ατόμου. Η αναμονή, ο χρόνος, οι καθυστερήσεις, οι ματαιώσεις, οι αναβολές. Σε κάθε περίπτωση, εφόσον πιστοποιηθεί τουλάχιστον το 50% της αναπηρίας, έχουμε τη δυνατότητα να πέσουμε μέσα στο θεσμικό πλαίσιο ή να πιστοποιηθεί η χρόνια πάθηση. Πάλι με ιατρικές βεβαιώσεις, έχουμε τη δυνατότητα οι εργαζόμενοι να αξιοποιήσει το πλαίσιο με τις εύλογες προσαρμογές. Εκεί ελπίζουμε όλοι στο να ανοιχτεί και να ζητήσει γρήγορα βοήθεια από οργανώσεις όπως το Alma Zois, τα οποία είναι αναγνωρισμένες για τη δουλειά τους, είτε από τα συνδικάτα. Από συνδικαλιστικές οργανώσεις που μπορούν να είναι δίπλα τους, ακόμα και στη διαδικασία πρόσβασης στην επιθεώρηση εργασίας, αν προκύψει κάποιο ζήτημα παραβίασης των όρων εργασίας τους, και μάλιστα να ασκήσουν και στο όνομα της εργαζόμενης τις προσφυγές, ώστε κάπως να βοηθηθεί ή να ενθαρρυνθεί. Αυτό που θα ήθελα να πω είναι, και για μένα ήταν πολύ συγκινητικό, είμαι περίπου 21 χρόνια μες στη ΓΕΣΕ, είναι το πώς προέκυψαν τα αιτήματα τα οποία τέθηκαν στις διαπραγματεύσεις για την Εθνική Γενική Συλλογική Σύμβαση και τα οποία έχουν επαναληφθεί σε 3-4 κύκλους διαπραγματεύσεων, δεν οδήγησαν σε ρύθμιση, αλλά για μένα το συγκινητικό είναι πώς προέκυψαν. Ένα από αυτά είναι το αίτημα για άδεια προσυμπληρωματικού ελέγχου. 2 μέρες άδεια, ειδικά για περιπτώσεις καρκίνου του οποίου η έκβαση σχετίζεται με την πρώιμη διάγνωση. Ένας από αυτούς είναι ο καρκίνος του μαστού και της τραχύλου για τις γυναίκες. Το αίτημα αυτό προέκυψε από γυναίκες εργαζόμενες μέλη σωματείων. Είναι συγκινητικό το πώς προέκυψε, πώς αναδείχθηκε από εργατικά κέντρα, από ομοσπονδίες. Υπήρχε ένας συντονισμός. Θεωρώ ότι και το Alma Zois έχει μεγάλο χώρο και δυνατότητα να φωτίσει και να οδηγήσει αιτήματα προς ρύθμιση είτε προς την πλευρά των λεγόμενων κοινωνικών εταίρων είτε και προς το κράτος. Οφείλω να πω ότι το κράτος μπορεί να συγκινείται, να συμμετέχει σε εκδηλώσεις, σε επίπεδο πρωτοβουλειών στοχευμένων ρυθμίσεων, μάλλον τα πράγματα δεν είναι πολύ καλά. Σε επίπεδο συντονισμένου θεσμικού διαλόγου με συμμετοχικές διαδικασίες, μάλλον τα πράγματα δεν είναι καλά. Στο Υπουργείο Εργασίας δεν λειτουργεί κάποια δομή διαλόγου, τόσο ώστε να φωνάξουμε, να πούμε τα θέματα που υπάρχουν για να παρακολουθούμε, να κάνουμε κοινωνικό έλεγχο στο κράτος για το πώς συμμορφώνται σε κάποια πράγματα. Ίσως στο τμήμα που είναι για την υγεία και την ασφάλεια των όρων εργασίας, εκεί θα μπορούσαν να τεθούν κάποια πράγματα, αλλά ισότητα, άνηση μεταχείριση κτλ. Δεν νομίζω ότι δεν λειτουργούν τα όργανα. Μία άτυπη επιτροπή για την άνηση μεταχείριση αυτή τη στιγμή έχει συσταθεί με πρωτοβουλία, ομολογώ, των ίδιων των υπηρεσιακών σπουδαίων ανθρώπων μέσα στο Υπουργείο. Ελπίζω από εκεί να μπορέσουμε να προωθήσουμε κάποια θέματα και αιτήματα συγκεκριμένων ρυθμίσεων. Και τώρα στο πρακτικό κομμάτι, η παράκληση θερμή να διαδοθεί και μέσω του Alma Zois. Εμείς έχουμε τις δωρεάν γραμμές πληροφόρησης στο Κέντρο Πληροφόρησης Εργαζομένων και Ανέργων και το δίκτυο συμβουλευτικής του ΙΝΕΓΕΣΕ. Και επίσης και η ΕΣΑΜΕΑ, αν δεν κάνω λάθος, έχει τις γραμμές για το διεκδικούμε μαζί, όπου και εκεί παρέχεται πληροφορία και στοχευμένη για τα ζητήματα των εύλογων προσαρμογών στη διάσταση πια της αναπηρίας. Τώρα στο ένα κομμάτι που υπήρχε παλιά για τις υποχρεωτικές προσλήψεις ατόμων με αναπηρία, με πιστοποιημένη αναπηρία, νομίζω ότι δεν λειτουργούσε μέχρι και πρόσφατα στο ΝΟΑΕΔ για τις επιχειρήσεις. Σε κάθε περίπτωση είμαστε στη διάθεση, ακούμε, νομίζω υπάρχει ανάγκη να γίνουν γνωστά περισσότερο τα αιτήματα αυτά και είμαι στη διάθεσή σας και εγώ για οτιδήποτε χρειαστεί, ερωτήσεις και πάλι ευχαριστώ πάρα πολύ.
Και εμείς ευχαριστούμε πάρα πολύ, κυρία Βαρχαλαμά. Να περάσουμε αμέσως στην κυρία Δασκαλάκη και σε ό,τι χρόνο μας μείνει μετά, να πούμε έτσι 2 ακόμα πληροφορίες που θα ήθελα και εγώ να πω. 2 ερωτήσεις από το κοινό έχουν ήδη απαντηθεί για τους φροντιστές και μία ακόμη Αλλά ας μην καθυστερούμε. Κυρία Δασκαλάκη, έχετε το λόγο.
Καλησπέρα και από μένα. Σας ευχαριστώ θερμά εκ μέρους του ΣΕΒ για την τιμητική πρόσκληση να συμμετάσχουμε στο σημερινό πρώτο συνέδριό σας, με αντικείμενο ένα τόσο σημαντικό και ευαίσθητο για τις σύγχρονες γυναίκες θέμα. Ακούγοντας με προσοχή τις προηγούμενες εισηγήσεις, είναι αναμφισβήτητο ότι είναι απαραίτητη μια ολοκληρωμένη και ενιαία προσέγγιση για την ομαλή ένταξη και επανένταξη των γυναικών που αντιμετώπισαν ή αντιμετωπίζουν τη νόσο αυτή στην αγορά εργασίας. Για τη διασφάλιση του πλαισίου οφείλει να φροντίσει η πολιτεία καταρχάς με τη δημιουργία ενός συστήματος κοινωνικής πολιτικής και πρόνοιας και ολοκληρωμένης μέριμνας. Όπως είπε προηγουμένως και η κυρία Βαρχαλαμά, η πρόσφατη ενσωμάτωση της οδηγίας 1159 του 19 για την ισορροπία οικογενειακής επαγγελματικής ζωής για τους γονείς και τους φροντιστές περιέχει κάποιες ευνοϊκές ρυθμίσεις σχετικά με τις άδειες και ευέλικτες ρυθμίσεις εργασίας. Από την πλευρά της επιχειρηματικότητας τώρα, οι σύγχρονες επιχειρήσεις μέσα από οργανωμένα τμήματα διαχείρισης του ανθρώπινου δυναμικού τους έχουν εφάρμοσαν στο παρελθόν και εφαρμόζουν πρακτικές ομαλής ένταξης και επανένταξης των γυναικών με καρκίνο του μαστού στην αγορά εργασίας και στην καθημερινή επιχειρησιακή λειτουργία, τηρούν την εργατική νομοθεσία και προχωρούν με ευαισθησία πέρα από αυτήν σε αρκετές περιπτώσεις και σε περιπτώσεις ιδιαίτερα που απαιτούν εξατομικευμένη διαχείριση τόσο ως προς το καθεστώς των απουσιών για την πραγματοποίηση των απαραίτητων διαγνωστικών ελέγχων, όσο και ως προς το καθεστώς των αδειών για τη διενέργεια της απαραίτητης θεραπευτικής αγωγής. Άκουσα βέβαια προηγουμένως και τους προβληματισμούς της κυρίας Μιλωνά και της κυρίας Κούρεντα για τη συμπεριφορά στον χώρο εργασίας. Όντως είναι θέματα που σε ορισμένες περιπτώσεις πρέπει να αντιμετωπιστούν. Διαχρονικά μεγάλες επιχειρήσεις στο πλαίσιο των προγραμμάτων εταιρικής κοινωνικής ευθύνης που εφαρμόζουν συμμετέχουν σε πρωτοβουλίες και δράσεις και σε συνεργασίες με μη κυβερνητικές οργανώσεις, με πανεπιστήμια, με φορείς, σχετικά με δράσεις ενημέρωσης και ευαισθητοποίησης σχετικά με τον καρκίνο του μαστού. Απ' την άλλη, οι μεγάλες και οργανωμένες επιχειρήσεις εφαρμόζουν παρέγκλιτα τις ευρωπαϊκές δεσμεύσεις που απορρέουν από τις κοινοτικές οδηγίες για τους καρκινογόνους και μεταλλαξιογόνους παράγοντες και αντίστοιχα τους χημικούς παράγοντες. Στρατηγικός συνεργάτης ήταν και παραμένει ο ιατρός εργασίας στις επιχειρήσεις που απασχολούν πάνω από 50 εργαζόμενους σε όλα αυτά τα θέματα. Και όλα αυτά που συζητάμε προφανώς πρέπει να εφαρμοστούν και να υιοθετηθούν και από μικρότερες και από λιγότερο οργανωμένες επιχειρήσεις. Τώρα, στο επίπεδο των εθνικών κοινωνικών εταίρων υπάρχουν τριμερή όργανα διαβούλευσης, τα οποία συμμετέχουν οι τριτοβάθμιες οργανώσεις και η πολιτεία, όπως είναι το Ανώτατο Συμβούλιο για την Υγεία και Ασφάλεια στην Εργασία, στο οποίο συζητούνται τα θέματα αυτά. Εν αναμονή του Εθνικού Σχεδίου για τη Στρατηγική για την Υγεία και Ασφάλεια, η οποία θα συζητηθεί και θα εγκριθεί από το Συμβούλιο αυτό, μπορεί να τεθεί το θέμα της σφαιρικής αντιμετώπισης του καρκίνου του μαστού στην εργασία, έτσι ώστε να ενσωματωθεί το αντίστοιχο ευρωπαϊκό σχέδιο, καθώς και ο αντίστοιχος ευρωπαϊκός οδικός χάρτης που υιοθετήθηκε τον περασμένο Νοέμβριο. Όλα αυτά βέβαια προϋποθέτουν μια φιλόδοξη και συνεκτική προσέγγιση, καθώς και μια συλλογική προσπάθεια. Πρέπει να αποτελέσουν τα εργαλεία και τους μοχλούς για τη βελτίωση της ποιότητας ζωής, ιδιωτικής και επαγγελματικής, αλλά και ουσιαστικής επανένταξης των γυναικών με μαστό στην αγορά εργασίας, το οποίο έχει πολλαπλά ωφέλη για τις ίδιες προσωπικά, κοινωνικά και οικονομικά, αλλά και για την κοινωνία γενικότερα. Αυτά τα λίγα και είμαι στη διάθεσή σας για οτιδήποτε χρειαστεί.
Σας ευχαριστούμε πάρα πολύ. Να απαντήσω ένα λεπτό, έτσι να έχω την ευκαιρία να απαντήσω και σε μια ερώτηση που έχει έρθει από το κοινό σε σχέση με την ανισότητα που υπάρχει στον ιδιωτικό και το δημόσιο τομέα με κάποιες διατάξεις προστατευτικές που αφορούν στα άτομα με αναπηρία, όπως μειωμένο ωράριο εργασίας, για όσο χρόνο υπάρχει το ποσοστό αναπηρίας, κάποιες επιπλέον άδειες. Να πω ότι ο Σύλλογος έχει καταθέσει από το Δεκέμβρη επιστολή έτσι, που θέτει όλα αυτά τα ζητήματα και ζητάει ουσιαστικά να τα λάβει υπόψη του σοβαρά το Υπουργείο και να εξισώσει, να περάσουν, να διαχυθούν αυτές οι προστατευτικές διατάξεις και στον ιδιωτικό τομέα. Έχουν δεσμευτεί, έχουμε τη δέσμευσή τους ότι θα μας απαντήσουν άμεσα, οπότε περιμένουμε να δούμε. Είναι πολλά αυτά που έχουν υποθεί. Το πλαίσιο, έτσι, φαίνεται ότι παρόλο που υπάρχουν κάποια εργαλεία, χρειάζεται πολλές προσαρμογές για να μπορέσει να είναι κατάλληλο, φιλόξενο, έτσι, και να καλύψει τις εργασιακές ανάγκες των γυναικών που διαγνώνονται με καρκίνο του μαστού. Εμένα αυτό το ερώτημα που μου προκύπτει πάντα στο μυαλό είναι ποιο θα μπορούσε να ήταν το επόμενο βήμα. Συνέργειες, σίγουρα, είναι πολύπλευρο το θέμα. Συντονισμένα πρέπει να γίνουν πολλά. Αλλά δεν ξέρω αν υπάρχει κάποια σκέψη. Ένα απλό επόμενο βήμα. Ποιο θα μπορούσε να ήταν αυτό? Μία σκέψη που έκανα εγώ, εννοείται όποια από τις ομιλήτριες θέλει να πει και κάτι άλλο που πιθανόν προέκυψε στη διάρκεια των ομιλιών. Έχουμε ακόμα 2 λεπτά. Ναι, 2 λεπτά. Βεβαίως.
Καταρχήν, να ευχαριστήσω πάρα πολύ την Έλλη, την κυρία Βαρχαλαμά, για αυτά που αναφέρθηκε σε μένα πριν, δηλαδή με συγκίνησε πραγματικά. Νομίζω ότι είναι πάρα πολύ σημαντικό να ανοίξει μια δημόσια συζήτηση από όλους τους εμπλεκόμενους φορείς. Το Alma Zois νομίζω μπορεί να την πάρει αυτή την πρωτοβουλία, γιατί για να αντιμετωπίσεις ένα ζήτημα, και μάλιστα ένα ζήτημα το οποίο είναι πολύ σύνθετο, γιατί αυτή είναι η πραγματικότητα, δεν είναι δηλαδή ένα απλό ζήτημα, οπότε θα έχουμε και μια απλή λύση. Χρειάζεται να συζητηθούν καλά τα δεδομένα. Νομίζω ότι υπάρχει η ωριμότητα και η επιστημονική γνώση και αυτό μπορεί να γίνει σε συγκεκριμένη περίπτωση, έτσι ώστε να βρεθούν, να μπορέσουν να υπάρξουν προτάσεις για να μπορέσουν να προχωρήσουν μετά σε δράσεις που πραγματικά μπορεί να έχουν αποτέλεσμα. Και μπορεί να έχουν αποτέλεσμα γιατί υπάρχει πραγματικά μια ωριμότητα και στο κομμάτι της αναπηρίας, αλλά και στο κομμάτι της αντιμετώπισης του καρκίνου. Άρα νομίζω ότι είναι πολύ σημαντικό αυτό πρέπει να είναι το επόμενο βήμα. Το επόμενο βήμα πρέπει να περάσουμε σε ένα σχέδιο δράσης.
Ναι. Κυρία Μιχαλοπούλου, μετά σε εσάς ο λόγος, κυρία Μιλωνά.
Όχι, ένα πολύ μικρό σχόλιο σε αυτά που υπόθηκαν πριν. Πριν κάποια χρόνια δεν μιλούσαμε καν για το θέμα της επιστροφής στο χώρο εργασίας, οπότε ακόμα και που μιλάμε γι' αυτό είναι ένα μεγάλο, πολύ σημαντικό βήμα. Γιατί μέχρι τώρα το θέμα αυτό αφορούσε αποκλειστικά την γυναίκα που νοσεί, αλλά σε σχέση με το πώς θα ξεπεράσουμε τα προβλήματα κτλ. Καμία διάθεση όμως να εμπλακούν από τον εργασιακό της χώρο ενεργά και μέσα από ένα οργανωμένο πρόγραμμα επιστροφής με συγκεκριμένα βήματα πάνω στις ανάγκες του ασθενή, αλλά πλαισιωμένα βεβαίως από μια σοβαρή πολιτική διαμόρφωση τέτοιων προγραμμάτων από την πλευρά του εργοδότη, του κάθε εργοδότη. Αυτό είναι ένα βήμα πολύ σημαντικό όταν βλέπεις. Εγώ θα ήθελα την επόμενη φορά όχι απλά να συμμετέχουν, να πάρουν την πρωτοβουλία οι επιχειρήσεις να διοργανώσουν ένα τέτοιο συνέδριο που να αφορά ακριβώς την επιστροφή των εργαζομένων και να καλούν το Alma Zois και τέτοιους αξιόλογους συλλόγους ασθενών και γυναίκες κτλ. και ανταλλαγή απόψεων. Αλλά νομίζω ότι είναι πολύ σημαντικός ο ρόλος του εργοδότη. Πάρα πολύ σημαντικός. Έχει το κλειδί για το πρώτο βήμα στα χέρια του. Ευχαριστώ πολύ.
Κυρία Μιχαλοπούλου.
Ήθελα να πω το εξής, ότι εδώ πρέπει να λάβουμε υπόψη μας ό,τι έχει σχέση με την επανένταξη στην εργασία, ότι μιλάμε για έναν πολύ μεγάλο αριθμό γυναικών. Δεν μιλάμε για μία μικρή ομάδα γυναικών που θέλει να επανενταχθεί. Αν σκεφτούμε ότι κάθε χρόνο είναι περίπου 7.500 τα άτομα που διαγιγνώσκονται, συν όλες τις επιβιώσασες, μιλάμε για ένα τεράστιο εργατικό δυναμικό, το οποίο σαν χώρα δεν επιτρέπεται να αφήσουμε στην άκρη και να το απομονώνουμε με τις συνθήκες που υπάρχουν στην εργασία τους. Άρα πραγματικά υπάρχει μεγάλη ανάγκη. Εγώ καλώ και τη ΓΕΣΕ και τη ΣΕΒ και το ΣΕΒ. Επίσης θέλω να πω ότι το Alma Zois πρωτοστατεί εδώ και χρόνια στην ενημέρωση των εταιριών για να μάθουν οι εργοδότες όλα αυτά τα θέματα, όπως και οι συνάδελφοι των γυναικών, και θα ήθελα πραγματικά ένα πιο ενεργό ρόλο του ΣΕΒ, ειδικά στη διάχυση της πληροφορίας μέσα από διάφορες δράσεις και κυρίως όταν κάνουν ενημερώσεις για το πόσο σημαντικό είναι να αλλάξει η νοοτροπία και των εργοδοτών και των συναδέλφων που έχουν ανάγκη να ξέρουν. Τώρα, όσο για αυτό που ανέφερε η κυρία Φωτοπούλου για το δικαίωμα στη λύθη, πραγματικά το θεωρώ σημαντικό, γιατί δεδομένου ότι τα ποσοστά επιβίωσης έχουν αυξηθεί πάρα πολύ, δεν είναι δυνατόν να μας ακολουθούν επειδή ασθενήσαμε κάποτε αυτά τα προσωπικά δεδομένα να μας αποκλείουν από άλλες ευνοϊκές συνθήκες, είτε με δάνεια, είτε τέλος πάντων κυρίως με τους ασφαλιστικούς φορείς. Επειδή αρρώστησα πριν 20 χρόνια, δεν σημαίνει ότι δεν μπορώ να ασφαλιστώ τώρα. Άρα δεν είναι μόνο θέμα μιας πρότασης που συντάσσουμε, αυτό θέλει πάρα πολύ δουλειά, θέλει συνέργεια πραγματικά, γιατί όταν μιλάμε για ασφαλιστικές εταιρείες αντιλαμβανόμαστε το μέγεθος, αλλά θέλει πραγματικά και εδώ, και ευτυχώς που έχει ανοίξει ο δρόμος στην Ευρώπη, οπότε δεν πάμε να ανοίξουμε εμείς ένα δρόμο. Ήδη μπορούμε να πατήσουμε σε βήματα που υπάρχουν.
Νομίζω ότι πρέπει να κλείσουμε σιγά-σιγά. Ήδη έχουμε πάρει αρκετό χρόνο και ευχαριστούμε πολύ. Ίσως χρειάστηκε ένα συνέδριο από μόνο του για το θέμα της εργασιακής επανένταξης. Ευχαριστούμε πάρα πολύ όλες για τη συμμετοχή σας, για τη συμβολή σας και νομίζω ότι αναδεικνύεται η ανάγκη ότι χρειάζεται να κάνουμε κάτι συντονισμένα, όλοι μαζί, για να αντιμετωπίσουμε ένα σίγουρα πολύ σύνθετο θέμα. Προχωράμε, έχουμε 10 λεπτά διάλειμμα λοιπόν και μαζευόμαστε ξανά εδώ στην αίθουσα για να συνεχίσουμε, όπου η κυρία Μίτση θα μας κάνει την ανακεφαλαίωση των τραπεζιών που έχουν εξελιχθεί μέχρι και σήμερα, μέχρι και αυτή την ώρα. Οπότε 10 λεπτά διάλειμμα και σας περιμένουμε πίσω.
Okay.
And at this point, we'd like to conclude today's session. We have completed all the scientific roundtables with distinguished speakers and commentators. Now, before we move on to our next speech, which is a bit particular, we're going to be talking about breast cancer and history. I'd like us to recap on what we have heard today. And we'll start by the first roundtable, scientific roundtable on screening and patients' registry. We began with the Secretary General of the Ministry for Health, who officially announced the establishment of the official screening program in our country that is going to start immediately. This is very good news because, as we heard by other speakers as well, the establishment of screening programs in Europe has been launched already since 2003. And in 2017, our country was one of the 3 countries that had not introduced a screening program yet. What has been pointed out by representatives of the medical community was that we need to follow clear guidelines and directives vis-à-vis the implementation, the conduct, and the quality assurance for screening. There are specific guidelines with regard to the implementation and the quality of care. Such guidelines are at the disposal of the Ministry for Health. To be used in the implementation of the program. As soon as we launch its implementation, this program will need to convince women to participate in screening. This is very important. And of course, we need to know how we will be able to direct such women to the proper services should a screening result be positive. We shouldn't leave them on their own trying to find what they need to be doing from that point onwards. And now, with regard to the patients' registry, the other Secretary General of the Ministry for Health mentioned that this too, the patients' registry, is in the pipeline with the use of digital tools and under a specific budget that has been allocated. Both the screening programs as well as the patients' registry are two important points that will help us achieve the goal of curbing mortality rates due to breast cancer. It has been mentioned that it is really important to maintain a clear-cut screening program because this will allow us to reduce mortality rates by 18%. With regard to the patients' registry, it has been made clear how useful it might be because on the basis of that patient's registry we can draw health policies, plan for specific interventions and be able to evaluate and assess the impact, the incidence of the disease in every country. This will help us better manage the situation. Therefore, we'll be glad to see the implementation of screening program, and of course we remain at the disposal of the ministry, both we and other associations, to help them In the second roundtable, we had the analysis of the value of integrated breast cancer centers. We heard a lot about the definition of breast cancer units or centers in accordance with the guidelines, the criteria that such centers should meet and fulfill. If we are to talk about inclusive and integrated medicine centers, we talked about evaluation criteria, quality of care criteria, and in particular the multidisciplinary team that is a prerequisite for such centers if they are to give us the added value of having specialized staff, healthcare professionals working there. A special mention was on the oncology nurses and the impact that this has on the quality of services provided to patients. We heard about the difficulties and the reason why we still have no such centers in Greece. There are some data as to what currently exists in Greece, and we heard about a good example, a positive example from our neighboring country, Italy, as regards their implementation and launching of certified breast cancer centers only in 2012. And this is an excellent example to be used as an example of best practices. There's the issue of the political will, of course, and we need to put pressure as patients and also have pressure exerted by pharma companies and see to it that we establish such centers. And finally, we heard about the need regarding the breast cancer centers, the need to coordinate our efforts. So, through time, within a 5 years period, to have our first breast cancer center in Greece. Regarding the next roundtable on high-risk women, we discussed about the issue of hereditary cancer, which represents a minority of breast cancer cases, in contrast to what we usually hear about as to who should be tested. We heard experts talking about specific criteria used in order to select women to undergo such testing, genetic testing. We talked about the benefits of genetic testing, both for breast cancer patients as well as for their relatives. Now, regarding patients who have already had a mutation, a BRCA1 and 2 mutation, we heard a lot about the plan of treatment and the risk assessment. There was a discussion as to the risk-reducing mastectomies and the skin-sparing mastectomies, and we heard an announcement about a specific study regarding the use of pharmaceutical treatment in women with such a mutation as a prophylaxis method. So there's yet another option for such women. We also had the pleasure to have with us the president responsible for the negotiation of treatments and reimbursements, who talked about the difficulties in enacting the reimbursement of drugs and treatments. The difficulty lies in the impossibility to find a model of an algorithm in search of this algorithm. They are going to have us to bring forward positive results, we hope, quite pretty soon. It was also mentioned that it was important for us to identify the regulatory framework so as for the medicine approval to go hand in hand with the biomarkers reimbursement if any treatment is going to be prescribed. Anyway, for something like this to take place, we need to have a biomarkers testing first. So it is an oxymoron to have the approval of the medicines without having the approval of the reimbursement of the biomarkers. We then had a very useful roundtable where we opened a discussion regarding return to work, quite complex issue, as we heard by our speakers. We talked about difficulties faced during the return to work, and this also included the approach of employers to this return to work. Return to work itself, in fact, for many women in multiple ways, constitutes an important element of the quality of life. We heard about the results of the working group of Alma Zois that has identified the needs, the obstacles that women themselves identify vis-à-vis their return to work, vis-à-vis an important issue which is currently being debated in Greece regarding the right to be forgotten, vis-à-vis insurance companies, banking institutions, employment organizations. Yet in Greece we still have no a legal framework, but despite that, the breast cancer should not be an obstacle to for a woman who would like to continue and go on with her life. Common finding is that indeed it's a complicated and complex procedure. We need to join forces, particularly on that topic. I hope that it is a random fact that we don't have anyone here representing the Ministry of Labour. I hope that it is only by chance that they are not here, because there's the elephant in the room and we shouldn't pretend that we can't see the problem. This topic could be the subject of a conference on its own. This is food for thought. Now, that's all from the first day. I'd like to thank you all, those of you who have been here with us today in person and those of you who have attended this event on the media. And I'd like us to move on to this special talk, a special presentation with the title Breast Cancer in History. Now we have the pleasure to have with us on the internet, joining us on the internet, Ms. Mandila Kosouni Maria, who is a pediatrician, who is an historian, and she is a professor of the National Kapodistrian University of Athens, and she is with us here to talk to us about a topic which is rather omitted. This historic review might fill us with new ideas and directions. We are really glad to have you, Ms. Mandela. You have the floor. We'll be happy to listen to you.
Thank you very much. Dear members of the board, dear participants, hello. I would like to warmly thank and congratulate the president of Alma Zois, Ms. Michalopoulou, board members, the organizing and scientific committee, for honoring me with this invitation to participate in this historic first conference on breast cancer. And at the same time, I would also like to congratulate you for this flagship work you undertake. I would also like to thank Ms. Panayotopoulou and Ms. Mitzi for the communication, technicians, and all the participants. I wish you but well. I wish you to be strong enough to tackle and address all difficulties that might come across your way. And I hope that you will always have good data to share with us. And let's hope that this breast cancer discussion will eventually grow in a more positive, grow towards a more positive direction. Now, I would like to quote Hippocrates, who said that it is a medical need that created medicine in order to address issues that affect people. So we know that cancer exists ever since human creatures emerged on Earth. You can see that on a parchment of 1600 before Christ. 8 breast tumors or ulcers that were cauterized back then. They would call that the fire drill, and those things are mentioned back in those parchments. And then we get to 520 before Christ, who treated Atusa, the family of Darius, and her daughter, because they said that Atusa would hide her breast because she had ulcerated breast cancer. And this is what Herodotus described in his writings, because she was feeling ashamed of her condition. The treatment back then did not include surgery, and according to the ancient Greek literature, where we can find the first references to medical knowledge, as of Hippocrates and on, is full of references of breast cancer cases. The term carcinoma is something that Hippocrates had mentioned, and we also have the relevant quotes in his work. And he was the first to identify the various types. He said that breast cancer was a crab-like tumor or mass, and they used the term cancer to describe cancers in the uterus, in the cervix, in the breast, etc. And then we also have Galen, who described breast cancer and gave the definition back in the 16th century. He said that human cancer is just like animal cancer, meaning that as it is the case in crab, which in ancient Greek terms was called cancer, you can see that we have swollen veins just like the feet of the crab. According to Paul from Aegina, this is a disease that is very similar to the crab, meaning that it is a disease that does not abandon or do any favors to the victim. And we also have those characteristics in both superficial, ulcerated, non-ulcerated, complicated, non-complicated breast cancer. When it comes now to the etiology, this was based on Hippocrates' review and perspective about the 4 humours: blood, phlegm, yellow bile, black bile. Normally, those things are well balanced, meaning that the person has eucrasia. Any distortion or disturbance in this balance leads to dyscrasia, meaning disease, and the fact that you feel unwell. And when those things accumulate in a single part of the body, then this is how cancer is generated. This interpretation has been retained for years, and many other authors had talked about this black bile, and they said that it is due to this black bile that cancers are generated. Callan talked about melancholy when he was referring to breast cancer. And it says that cancer might affect any body part, and this might also affect the breasts of women, and they derive from this black bile. And we also had other ways to address those things. Hippocrates said that it was very, very difficult to address this problem and this disturbance of the four humors. And they said that this can be treated only if it is treated at the early stages. When it comes to the size, we had Orivasius, who described that it might be as small as the eye of a fish or be as large as a watermelon or a melon. So you do realize that normally Paul of Aegina said that it might have various colors and their appearances might vary from yellowish to blood-like, etc. And they said that if this cancer stopped progressing, then that meant that the woman would die. And then we get to learn from Michael Psellos that this is a very difficult situation, the frequency of which is detected among women. And when it comes to the surgical management, we also have an Egyptian parchment that was discovered by Edwin Smith. This parchment dates back to 2500 before Christ, and prior to surgery they were using some herbs. They had the Asclepias, they had ivy, Helleborus, Aristolochia, Erysimon, etc. They were also using other cases of herbs or metals, for example lead, to treat the ulcerative cancers, and Hippocrates thought that only ulcerative cancer should undergo surgery. And we also had the Aulus Cornelius Celsus, who said that when an invasive tumor infiltrates the chest wall, then there is no point in performing the surgery. Majority of surgeons recommended surgery in the early stages. Before that, they would administer the right drugs and herbs in order to clear out this bile, this dark black bile. And of course, all those theories have been conveyed and transferred to Western medicine through the various Eastern physicians. And Leonidas says that breast cancers might also infiltrate chest wall, and there are specific ways to deal with them. The term sympathy would mean metastasis back then, and this is how we have other philosophers who talk about the sympathy in the meninges, the stomachs, etc. And we have other authors who talk about sympathies in the armpits, meaning the axillary lymph nodes. When it comes to the pain that is reflected in other areas of the body, we also had other authors who were using conservative methods, for example, diet, phlebotomy, or other pharmaceutical drugs or substances that could help the patient discharge this black bile. And there are other cases of physicians who report women who had get rid of their cancer through their feces. And they were also aware of the relapse term, and according to Paul of Aegina, they said that if you try to operate on a tumor, then maybe this might return and be worse than was at the beginning. On the basis of their experience, they knew that relapses were untreatable, whereas in the case of deep and ulcerated cancer, they would not recommend surgery because they saw that they relapsed quickly and they led to death. Leonidas, after resection and cauterization of the carcinoma, they would place implants and pads that were impregnated with solutions from Plantago Major, Hyso, Bituminaria, or Alcea. And they would use that to impregnate the cloths, and they would place those cloths on the armpits, on the breasts, and they would also recommend the woman to lie down in a warm environment. After the surgery, women were to avoid wine consumption, heavy food, and they had to follow another treatment so that this disease would go away. And Gallen would offer another conservative treatment for ulcerative cancer. For example, to drink aloe solutions or bituminaria for 5 days or other herbs, hot drinks. And according to the Hellenics, they would also place other pads with goat butter and egg yolk. In breast cancers that were not ulcerated, in order to help women be relieved from pain, they would use pomegranate seeds as a pad, or other herbs, or even plantago major. They might also use a mixture of honey and water in warm pads that would help relieve the pain in the most malignant breast cancer. In the most persistent cases, this might help the patient overcome the cancer. We know that breast cancer was quite widespread across all time periods and ages and claimed the lives of famous women, for example, Empress Theodora. In 16th until the 18th century, we have various paintings depicting breast cancer, and the same applies to the medical manuals, reciting surgery methods with or without cauterization, as well as the surgical instruments of the time. As of the 19th century and on, we have seen that the diagnosis of breast cancer has taken leaps forward. I would like to indicatively mention some milestones. In the first half of the 20th century, radiation therapy became a standard of care, where they would recommend the use of radiation therapy instead of mastectomy. And then they also started to identify the genes that were responsible for that. We also have Handley, who removed the inner mammary lymph nodes, and he later proved that removing the ovaries would not help in that case. And ever since, we know that mastectomy which was the golden standard at the beginning, has been gradually improved or enhanced, and radiation therapy has been systematically introduced in breast cancer treatment. In modern Greece, we have significant surgery professors who had a significant impact. I'm talking about Professors Fokas, Mermigas, and Geroulanas. And then Urban proceeded to radical mastectomy, resection of the chest wall, and resection of the inner mammary lymph nodes using a graft. And this was followed by the invention of mammography in 1970. This has been a major milestone for early diagnosis. And then 1978, we have the establishment of cynology as medical specialty in Brazil and Argentina. In 1990, we had the traditional conservative surgical choices for breast cancer made official by the National Health Institute in the United States. And then in 1992, we see that systematic chemotherapy is introduced as a standard of care. Today, we're here to discuss new treatment choices. As a conclusion, cancer begins and ends with human. Breast cancer had been extensively studied by ancient Greece, Rome, Byzantium, Arabs physicians. They had described many of its characteristics and therapeutic methods. Over the next centuries, we have seen huge progress in breast cancer diagnosis and management. Thank you very much for your attention.
Ms. Mandela-Kosuni, we'd like to warmly thank you for this excellent description of this historic review on breast cancer. At this point, we would like to move on to the welcoming addresses, since we have with us representatives from the political leadership, the scientific community. So first, I'd like us to start inviting the president of the Hellenic Association of Women with Breast Cancer, Alma Zois, Ms. Michalopoulou Paraskevou, who has been a visionary trying to support passionately the organization of this event and the engaging of this event into action. So you have the floor. Thank you very much, Christiana, for this nice introduction. Indeed, it's really touching. We, the Alma Zois family, are particularly touched today since our first conference on breast cancer becomes a reality. Despite the fact that the pandemic is not over and yet another crisis has been added to that in the form of war in order to render this landscape much more dystopic, breast cancer should not fall off from the list of the priorities that need to be targeted immediately. I'd like to warmly thank the organizing and scientific committee of this conference, as well as all our speakers and commentators. Now, making a review, I think an important moment before we reach today's event, our cooperation with the scientific societies such as Achaia, the Hellenic Society of Breast Surgeons. I'd like to thank the president, Mr. Venizelos, as well as the Hellenic Breast Imaging Society, particularly thanking President Mr. Koufopoulos and Ms. Broutsi, and then EOPE, the Hellenic Society of Medical Oncologists, thanking the President, Ms. Saridaki Zora. This partnership and cooperation led to the MOU regarding breast cancer in Greece, presenting our own positions on the management and treatment of the disease, which has been communicated to the Prime Minister and the Ministry for Health, and only recently it has been communicated to our MEPs and MPs. We have had some responses by the MPs and MEPs, and we are waiting to have a real actual cooperation with the Ministry for Health. We all know that breast cancer is the cancer most commonly diagnosed around the world and the main cause of death and due to cancer in women. So we go hand in hand with the action plan of the EU to combat cancer and the objective of the global cancer initiative by the World Health Organization, which is to reduce the mortality rates by 2.5% annually by deterring 2.5 million deaths due to cancer between 2020 and 2040, 25% of cancer deaths rather until 2040. So the three pillars to achieve these goals are the following: health promotion, timely diagnosis, and integrated management of breast cancer. The first pillar, that has to do with health promotion, calls for the cooperation between all agencies, particularly the ones of the state, through filling in the gaps in education and awareness. So with regard to the improvement of modifiable risk factors such as exercise, proper nutrition and diet, restriction of alcohol and tobacco, breastfeeding, etc. The second pillar, that has to do with the timely diagnosis of breast cancer, is also an important factor that needs to be seen in an organized way, and this should be part of the provisions of the public health system through screening programs, given that we know that in the countries where screening programs are applied, this has been associated with better outcomes. Another decisive factor is the reduction of delays between the time of first contact with the health system and the inclusion in the breast cancer management system. survival rates start to differentiate when delays for the onset of treatment are higher than 3 months. In our country, current delays in some cases, and not only because of COVID, if we think about the geographic allocation, distribution and fragmentation of health services, might exceed 3 months until women start their treatment. Finally, the third pillar includes integrated treatment and care for breast cancer. This has to be associated with universal and equal access to the most appropriate treatment at the right time in integrated care breast cancer centers being treated by a multidisciplinary team with the provision of all necessary services that will help restore health and help return to work. Whereas palliative care is the least thing required to support women maintaining their functionality and dignity and decency through the end. This breast cancer disease is a disease that shows the way we should treat other types and forms of cancer. For all these reasons, breast cancer should become a priority for public health. And we here today, each one of us from our own post, we share our knowledge and our forces towards this objective. So I'd like to thank you once again for having contributed towards this objective. Thank you. From the first patients' conference on breast cancer, we couldn't do without the Alma Zois associations in the country. I'd like to call upon the floor the president of Alma Zois in Achaia, Miss Stefanaki Angeliki, a woman who works endlessly regarding breast cancer in Greece, in Western Greece.
Ευχαριστώ πολύ, Χριστιάνα μου.
Thank you very much, Christiana. Thank you. Although Ms. Michalopoulou said it all, it is my turn on behalf of the board of Alma Zois of Achaia to welcome this new initiative of our parent association, Alma Zois. I'd like to welcome this well-tended event, which is the apex of an important work that began already 30 years ago. Ever since 1988, Alma Zois, we are proud to say, paves new paths and will keep on doing so. As was well said by our president, I will agree, this conference comes in an iconic conjuncture whereby the COVID pandemic and the recent geopolitical developments have almost monopolized our interest and have made us forget that there are other threats to our health that are luring by, such as breast cancer. Already we start seeing the dramatic impact of the underdiagnosed cancer cases in the past 2 years. We believe that this conference paves the path to a new era vis-à-vis the overall project of Alma Zois Association. This was what was missing, and we cannot but feel proud of being members and parts of this important pioneering family. And from the bottom of my heart, we wish constructive results for the introduction of therapeutic management to the benefit of breast cancer patients. Thank you.
At this point, I would like to give the floor to the president of Alma Zois Association of Thessaloniki, Ms. Rekenari Kula. She has been very active and she has helped empower many women in northern Greece. Ms. Rekenari, you have the floor. Hello, everyone. Good afternoon. I would like to share the greetings from all the board members of Thessaloniki and our 1,500 members. I am here with Ms. Partia, who is responsible for all the programs. I am very proud to see that this first conference has begun. We flew in Athens here today, this morning, and it is with great attention that I listened to all the speakers, but I could not help but keep reading this first patients conference for breast cancer in Greece today, and I'm sure that this will be the first, and many more will follow. We have shed light on many aspects of this disease. Many things that we wanted to be clarified. Either we talk about the various issues that have to do with patients registry. That's very important. Screening. Breast centers that were still missing. The labor rights, things that affect our members every day. Genetic testing. And it is at this point that I would like to congratulate the Hellenic Association, because every year, thanks to the proceeds from their year raise, they finance genetic testing to some women. I keep saying that knowledge is power. Tomorrow we will fly back to Thessaloniki and we will bring along with us much knowledge, and we'll return to Thessaloniki and I will be wiser. Congratulations, Ms. Michalopoulou. Congratulations all board members. Congratulations to all the people of the Alma Zois Hellenic Association. I'm sure that this will be the first of many, many conferences that will follow. You're here to join our voices, to raise our voices in order to claim everything we have been discussing, everything that we need to claim and gain, as it is the case in another neighboring country. If they did it in Italy, why not in Greece as well? Thank you very much. And we are joined online by a person who has worked for many, many years at the European level to the benefit of breast cancer patients, a person that has helped drafting European policies for breast cancer. I'm talking about Mr. Alberto Costa, who is an expert and a special advisor to the Commissioner for Health and Food Safety in the European Commission, Ms. Stella Kyriakidis.
Us digitally, Dr. Costa Alberto. Τρόμαξα λίγο, συγγνώμη. He's a special advisor for EU policy on cancer on the European Commission at the Cabinet of Commissioner Stella Kyriakidis. Dr. Costa, it is an honor to have you with us today. We know your history, we know your work, patiently working for the benefit of breast cancer patients on a European level, and we thank you for that. Thank you for all the support that you've provided to us during the organization of this first conference for breast cancer in Greece. We would like to hear you as a special advisor of the Cabinet of Commissioner Stella Kyriakidis.
Ευχαριστώ πολύ, Christiana. Kalispera to everybody. I apologize for not being able to continue in Greek. I also apologize for not being a woman, because this event, it's really created and dedicated to women, to the part of the society who more looks after the health. We know that women are much more careful on hygiene, on raising the children, on food, and they look after the health condition of the family, of the group where they live, which is why it's so important, women's health. it's so important that women are okay. And this is a very tough time. I don't need to tell you. You all know we're just out of the pandemic of COVID. We have now these horrible images again every night as a consequence of the Russian aggression to Ukraine. We are also very sympathetic with all the women and patients there who we hope can continue to be cured by the neighbor countries. We here in Brussels, there is a coordination center and doing all what is possible, particularly through the big effort of Poland to give assistance to these women. Unfortunately, this will also hit the Russian patients because they will suffer from the sanctions and the more difficult economic condition. And it shows how crazy and we have to admit, and as a man, I have to admit that it's always men doing this. Always men are doing war. There is no memory of a war declared by women. We will also have a lot of delays to catch up because of COVID, the screening program were suspended. You know, in Europe, we are 60 million women regularly screened for breast cancer. And this has been suspended for nearly 2 years, and we see the results. We see a terrible increase of more advanced breast cancer. And this will also have to be faced and recuperated. I wish to congratulate you because the idea of a conference for patients, it's extraordinary. You're very brave, courageous, and this deserves support. And I hope personally that this will become a model also for other countries. We have, I bring you the salutation and the best wishes on behalf of Commissioner Stella Kyriakidis, who is very close to you, as you know, because she is herself a breast cancer survivor, and she is very close to the community in Europe, and she has fought for a plan against cancer, which now it's an excellent example of what the United Europe can do. Very few people have realized that our European plan, it's even more funded than the American one. So it's a unique effort, and for the first time there are investment in survivorship, in quality of life, in the famous fight. I don't know if you have this problem in Greece, what we call the right to be forgotten. You know, the fact that if you have a stamp of a diagnosis of cancer, and particularly of breast cancer, you have a lot of difficulties with the banks for mortgages, with the insurance, and with the working place. And for the first time, there is this topic, this issue in a plan against cancer in Europe. So on behalf of Stella, if I may say so, or Commissioner Kyriakidis, more formally, I send you all the best wishes and congratulations for these 2 days of work. Ευχαριστώ πολύ.
Ευχαριστούμε πολύ.
Thank you very much, Mr. Alberto Costa. He himself touched upon the right to be forgotten, which was one of the subjects of our last scientific roundtable, and it seems to be something that we will be dealing with in the future, which is quite positive because it seems that survival rates are increasing. So, we've managed to have with us the Minister for Health, Mr. Plevris. So I'd like to give him the floor in order to give a brief address. So, dear Minister, you have the floor. Thank you for being here with us. I thank you too. Good afternoon. I do apologize for the delay. This delay is combined to a great extent with the talk that is being done right now. We had the final meetings regarding the screening program that will be under the Recovery and Resilience Fund. It's going to be launched early April. It will pertain to 1,300,000 women. And the particularity of this program, and I address myself to you who are very familiar with the battle against cancer. The particularity thereof is that it's going to be the first massive screening program. It's going to be under the name of FOFI Yanimata. Now, utilizing on the advantages we had from SMSs and emails for our vaccination program, we are going to go after those women who need to take the test, and sending the text and the message will be in itself a referral for a private or public structure where the woman will be able to have the tests. In the case of extra tests are needed, the program will be covering the meeting with the doctor in order for the doctor to guide the patient through. So it is important for us to see cancer in broader terms, particularly breast cancer, throughout its entire dimension, starting from prevention, which will help us have the as early and as timely diagnosis as possible in order to be able to achieve best treatments and best outcomes. At a later stage, we need to further strengthen the treatments. Already in the part of introduction of innovative medicines, negotiations method change. So high therapeutic value drugs will have realistic discounts in order for all patients to be able to access them. So we're talking about screening, treatment, care, and of course increased clinical studies. So it is with great pleasure that I welcome this conference, and maybe I'm in a pleasant position today, since this address does not only pertain to the typical presentation, but it is also accompanied by the first official reference to the program that will be launched, that will be combined with prevention of breast cancer. Thank you very much for allowing me to address you. Thank you, Minister. We are at your disposal, both with our scientific community and all our societies and associations. We are there to cooperate with you regarding the launch of this program. Thank you. Now we move on to the president of the Hellenic Breast Imaging Society, Mr. Koufopoulos Konstantinos. I call him from the floor. In the past few years, we've held many actions jointly, one of which was the memo submitted to the Ministry for Health. Now, Mr. Koufopoulos, you have the floor. Thank you very much for honoring me by inviting me here. I'd like to congratulate the board of directors of Alma Zois Association for their effort, this excellent effort since the 80s, where I was involved in this fight against breast cancer. I had always believed that doctors often had to place themselves in the shoes of the patients. So this is what Alma Zois does. They put doctors in the shoes of patients, and it's quite important. This is amazing beginning, an amazing start. There's cooperation between our societies and associations, always aiming at improving the services provided to women. I think that this is our joint goal, and I believe that we do have the specifications to succeed in it. Thank you.
Ευχαριστούμε πολύ, κύριε Κουφόπουλε.
Thank you very much, Mr. Kofopoulos. And now we would like to welcome the president of the Hellenic Society of Medical Oncology, Ms. Saridaki Zora Zenia. She's joined us online, and she has supported this conference as well as the Memorandum on breast cancer. Ms. Saridaki, you have the floor. Hello. Sorry for not being able to be there in person, but I will be tomorrow. Thank you for allowing me to address you at the opening ceremony of this conference. I would like to congratulate Ms. Michalopoulou, the members of the board, as well as all those who are involved in the organization. This is a high quality and extremely interesting program. I would like to know that EOPE is standing by your side with many of our members taking part as speakers in your agenda. And of course, we will stand by your side in all the fights you have been fighting all throughout the years to the benefit of the patients in Greece. I believe that this is a wonderful occasion to host this conference with so many important announcements made by the ministry with regard to breast cancer screening program. This is a program that normally should have already been in place. I might say that this is the anniversary, the birthday of the screening program, and we will keep remembering that because this is the first of many conferences that will follow. We're here by your side, and we are very happy that we are able to do all those wonderful things with you. Enjoy. I'm wishing every success this conference. See you tomorrow. Thank you very much. See you tomorrow. We're looking forward to talking about metastatic breast cancer. Now, let's give the floor to the president of the Hellenic Society of Breast Surgery, Mr. Venizelos Vasilis, who has been supporting all our actions in a very vivid way. And our collaboration with AHEM and himself have yielded valuable results. You have the floor, Mr. Venizelos. Thank you very much. I would like to warmly congratulate Ms. Michalopoulou as well as the board of Alma Zois. Allow me, however, also to congratulate Ms. Gavrilidou because she is the person that helped us evolve and grow. I believe that this is a turning point. And this conference marks this turning point, a turning point towards a better future for breast cancer patients. Many things have already been discussed. Tomorrow we'll be here to discuss even more interesting things. And why is this a turning point? Because it is the first conference. It is the first conference where the Minister for Health has announced something that is very important. Allow me to consider that a success of this association. I know that you have fought a lot throughout the years in order to raise awareness in the ministry, in order for the ministry to implement screening and many more things. Hopefully, now we see that we're in great terms with the Minister and the Secretary General. I would like to thank him for all his support. I believe that many positive things will follow. This is our goal, to translate those things as a benefit to all our patients. I believe that the topics addressed in this conference have been very important. Breast centers, the registry, all the things that we have heard about today is making its own contribution in order to improve healthcare provision in both the public and private sectors, in order to improve healthcare provision, in order to match the standard offered abroad. This is our goal, to be able to offer the same services offered by centers abroad. And believe me, we have this possibility because we have amazing human resources, both physicians and nurses. They're highly competent. All we need is some support and help in order to implement all those goals. The Hellenic Breast Surgery Society has always been by your side. This is something that we believe is an obligation of ours. We want to help, we want to support you in order to ensure the improvement of all those services that we can offer. On the other hand, I would like you to keep on the same track. What you ask us, it's something that we will do. It is very important, however, to know that you help both survivors and current patients, because we have both categories, and both categories need your help. And let us not forget the important role held by Alma Zois. There are too many societies, patient associations out there. But Alma Zois has played a decisive role. It's something that I have first-hand experience from, and I have my patients, when your volunteers visit them at the hospitals and they start hoping again. Hope to live. That's the most important of all. We will remain by your side. Keep up the good work. The first day has been very successful. I'm sure that tomorrow will be the same. It will be equally successful. We're looking forward to the next and the next and the next conference you will organize. Thank you very much.
Thank you very much, Mr. Venizelos. Now, before we conclude with the first day of our conference, since I have seen that we have with us the Secretary General of the Ministry for Health and Issues of Health Services, Mr. Kotsiopoulos, would you like to give us a brief address?
Σας έπιασα εξαπίνη, συγγνώμη.
Πραγματικά για χαιρετισμό, αλλά μου δίνετε την ευκαιρία, τη χαρά και την τιμή πράγματι να σας συγχαρώ για το πρώτο συνέδριο που γίνεται και μας δίνει αφορμή να συζητήσουμε πολύ σημαντικά και κρίσιμα.
First conference that allows us to speak about important issues. The priority is given to prevention, so this is where we place emphasis. We are here at the birthday of this program. I have the honor to head the Health Services Department and the Ministry for Health, and we've had the opportunity, together with Mr. Venizelos, to see how we can further promote these departments. I think that we are in the right way and the right path. Such things allow us to get ideas as to how we can move forward. This dialogue that we have developed with you gave us the opportunity to make progress on things. Together with Ms. Saridaki, we have worked on the technical bulletins or sheets regarding the neoplasias registry. You know that our country is amongst the few countries where there is no such neoplasias records or registry. So the added value of this conference is that it becomes a forum of dialogue on breast cancer. I think that through these four, we'll be able to shape together, hand in hand, the future, which will be much better. Thank you very much. I had the pleasure to listen to quite a few of the speakers. They are really high quality, high level, and thank you very much for that. Thank you very much. This concludes with today's conference. We'll see you again at 10 in the morning, where we are going to discuss equally important issues pertaining to breast cancer. Thank you.
Calamari. Calamari.